Good morning, everyone. Thank you for attending to our first sarcoidosis patient day across the UK. We are all thrilled to be part of this. I'm really happy to organize this along with my consultant group here at the Brompton, as well as the SarcoidosisUK and sarcoidosis specialists across the country. Also, international colleagues will join to share experience from Europe. I have a few things to say in addition. Just bear with me a moment to upload my screen. So this is the result of 3 patient events within cardiac sarcoidosis, and we have found that they have been particularly successful. We are particularly interested in educating our patients, which increases our patients' engagement. And for us, this is critical because our whole service is designed to be patient-centered, although consultant-led. We're interested to know your experience. We want you to be part of our decision-making, and we care about your safety. I want to thank everyone that is on this list, primarily Professor Wells, who's my mentor and actually leading sarcoidosis in the UK, but also across the world for a number of years. My very experienced colleagues, Dr. Chua, Dr. Renzoni, Dr. George, Dr. Molyneux, Dr. Kokosi, who have all been involved in our sarcoidosis clinics. You will see you will see our multidisciplinary discussion later on where other members of our team are joining, and I'm very happy to have everyone on board from cardiology, infectious disease, neurology, and dermatology input. I also want to thank all the sarcoidosis specialists who have dedicated a lot of time in the presentations today, as well as their whole career in promoting sarcoidosis. Special thanks to the team at the Brompton, the clinical nurse specialists and the coordinators who have helped me tremendously with this work. We are a tertiary center that sees more than 2,000 patients on an annual basis, and we run joint clinics to capture every given aspect of the condition. But primarily, this is a session for you. This is the first day of the Sarcoidosis Awareness Month. We are very happy to hold this, and I must tell you that this is going to be a sequel of events that will follow. You will hear a session that is going to cover sarcoidosis as an entity, focusing on the cause and diagnosis, treatment, as well as special forms of sarcoidosis that are particularly troublesome. Then we will have international speakers coming in from Italy, both patients and specialists, and you will experience a simulation of our multidisciplinary meeting. We will close with SarcoidosisUK and Brompton plans for research in the field, trying to show you that there is a lot of future here. Without further ado, I will pass on to Henry Selford from SarcoidosisUK.
Hello, and welcome everyone. Thank you, Vassis, and welcome to the Royal Brompton and Harefield Hospitals and Sarcoidosis UK Patient Day, the first day of Sarcoidosis Awareness Month, and this our first really global symposium on for patients on sarcoidosis. And we've had registrations from across the globe, so we're very excited. And Vasilis has been amazing. This has been his ambition for some time. And he has been responsible for bringing together all the speakers. This really is his day, and he should be absolutely celebrated. Thank you, Vasilis. And we also need to say a big thank you to all our speakers. And Vasilis has just gone through some. We've got people from the UK and again from across the globe. So it's a very exciting day, and you're going to learn about the patient experience, particularly in Italy, which I think is going to be very useful as a sort of compare and contrast. Some of you will, from our speakers, some of them you'll know from videos we've done before, some are going to be new. It's exciting to have them all. In the background, we've got Leo and Charlene, They are the staff, the workers who do everything at Sarcoidosis UK. And I just wanted them to say hello so we could thank them in person. You're not going to see them throughout the day, but they are working so hard and have worked so hard. Charlene, so if you want to say hello, and then Leah.
Yeah, hi everyone. Sorry.
I get to say it.
To myself. There you go. Hi, thanks so much for joining, everyone.
Yes.
Leo, do you want to say hello?
Hi everyone. I am actually going to be speaking today. I'll be doing a quick session about patient experience very shortly. But then after that, I'll be in the background dealing with people who are signing up still. It's great that so many people have signed up so far. We're absolutely thrilled to have so many patients here with us.
And what's our current number? And that's just registering them. We've got people watching online as well.
We've got about 1,300 at the moment, and on Facebook, I think we've got about 40 people watching live as well.
Already, and that will build. Charlene is the director of operations behind doing the technology, which makes it even more amusing that she was on mute. Charlene, do you want to say hello? You are still on mute, so.
Hi everyone. Sorry, need to be on mute because I'm doing all the technicalities behind the scene, but great to have so many of you join us. It's a really exciting day for all of us. We've been excited for it for a long time, very much looking forward to it and hearing from all of the speakers. So thanks everyone for joining.
Wonderful. And thank you for everything you're both doing. And I know how hard you've been working and are working today. I was asked to just tell a little bit about the charity. I'm going to do it very quickly. As many of you know, the charity is focused on 4 pillars. And that is information, quality information to you that you can rely on, that helps you, support, and you see that in our support groups, and you see you see that today, and this is a big part of what we're doing. Awareness, building people's understanding of sarcoidosis throughout both the population as well as the medical community, and research, where we put the bulk of our money. And some of our research partners are talking today, and obviously our main focus is to put ourselves out of business in terms of we fund research towards a cure, and the whole goal of this is to find that cure and go home. So that's and you'll hear from some research to see how we're trying to do that. I want to introduce Peter. As we grow, we continue to evolve the charity. I remain very much involved. But I'm splitting my role. So I'm chairperson of the trustees. I like to think of myself as the boss's boss. But we now welcome Peter as executive chairperson. And so he provides the more focus and guidance on the day-to-day. So he's the person who works primarily with Leo and Charlene on that day-to-day, what we're doing. He's been in that role since earlier that year. And this is a fantastic opportunity to have him introduce himself now. So hello, Peter, Executive Chairperson of Sarcoidosis UK.
Yeah, thank you, Henry, and hello, everyone. Really pleased to be part of this with the Royal Brompton today and with Vasilis. I think you've stolen pretty much all of my thunder, given I was going to introduce myself and how long I'd been here and what my role is. But really pleased to have been here since January. I'm working with the team on the day-to-day, and obviously the little help that I gave in bringing this today, and hopefully leading the development of the charity in the future, as you say, to find that cure and make ourselves redundant.
And Peter's going to come back and actually he's going to talk about the research we've done and our research that's ongoing and plans, because that's really talking about the future main thrust of the charity. So we're looking forward to that. Welcome everyone to today. I'm going to hand back to Vasilis, and I'm looking forward to everything to come.
Thank you, Henry. Thank you very much. It's a great pleasure to have all of you on board. So I would say that without further ado, I would be very happy to introduce Dr. Peter George, who's our clinical lead in the interstitial lung disease department. He's going to chair the first session. Sorry, it's Dr. Felix Chua. Sorry, this Dr. Felix Chua, who's our quite experienced, I would say, although young, experienced consultant at Royal Brompton Hospital with a lot of background in sarcoidosis, member of our clinics on a regular basis, and he will chair the first session. Sorry for the mistake. It's more the anxiety, Felix.
Hi, Vasilis. Thanks. We're running a bit early. I think I'm just looking at the list. It's 10:40. I think Simon's on the call, but I'm not sure if Mohanthan's joined yet.
I would suggest that we make a start and then we see, or is it? Leo,
I don't mind. We can make a start. I just had a call from Mohanthan. He's just finishing a few things,
okay.
And we're
Leo,
tidying up the questions.
I forgot it. Leo, would you mind presenting your survey?
Thank you.
Yes. So, hello everyone. My name is Leo, and I'm the senior executive at SarcoidosisUK. Absolutely thrilled to be here today, and I wanted to just take a 15-minute session to talk a bit about patient experience. Now, understanding patient experience is really crucial to what we do at SarcoidosisUK, as it defines our priorities and it really does inform the work that we do. And I think it is equally important for medical professionals as well to understand that patient experience and how to best care for their patients. So, like I say, I'm absolutely thrilled to be here talking about this today. Now, I do work with sarcoidosis patients every day. And one thing that I should mention is that trying to summarize a sarcoidosis patient's experience in a 15-minute session is a very difficult task. And the reason I say that is because, as many of the people who've joined us today will know, it's a condition that can affect patients in so many different ways. It can affect almost any part of the body, and there's a long list of symptoms that can vary from patient to patient. There are common patterns of symptoms that show up when a large number of patients are studied. However, I've found that, generally speaking, sarcoidosis patients have a very individual experience of sarcoidosis. Having said that, there are some key issues that we can discuss today. So I'm going to share my screen, go through a PowerPoint and talk about some of the things that I've found, as well as showing you a patient experience video as well. So some of the key issues that I've experienced, that I've heard about sarcoidosis that patients experiencing in my conversations and in my work with them. The first one that I think is very important for us to discuss is diagnosis. There is currently no agreed or accepted single diagnostic test for sarcoidosis due to the complicated nature of the condition that affects people in many different ways, like I said earlier. Sarcoidosis is often misdiagnosed, and that can be due to the symptoms mimicking those of other conditions. In fact, in a recent SarcoidosisUK survey, we found that 54% of the respondents said that their sarcoidosis symptoms had been initially diagnosed as something else. So diagnosis with sarcoidosis is often a process of elimination, and it can take a long time. And I think this can be a particularly hard part of the sarcoidosis patient experience. I think another thing that's important for us to talk about when talking about the sarcoidosis patient experience is the lack of information and answers that there seems to be. Once a patient is eventually diagnosed, this lack of information and answers is challenging. I mean, the cause of sarcoidosis remains unknown, and there is no known cure. Because of this, sarcoidosis is confusing, I think, particularly for those who are newly diagnosed with the condition. Helping patients understand sarcoidosis is extremely important to us at SarcoidosisUK, and something that we do take very seriously. All of the patient information that we produce, so that's our Q&A videos, our leaflets, our FAQ pages, our patient days like today, all of this is produced with medical experts and sarcoidosis specialists. And we provide all of that completely free of charge so that we can provide quality information to sarcoidosis patients. It's also our mission to find answers to those unanswered questions with the research that we fund every year into a cure. But I won't talk any more about research just now, because I know that we have a couple of sessions on that later on. The symptoms and side effects of medication are something that comes up a lot when I'm discussing the sarcoidosis patient experience. Not only are there organ-specific symptoms such as coughing or chest pain, there's also non-specific symptoms that often get overlooked or even minimized, such as fatigue. these symptoms, combined with the side effects of sarcoidosis treatments like steroids, can have a real impact on a patient's quality of life. One of our objectives as a charity is to raise awareness of the condition. Unfortunately, mental health problems are common amongst patients with chronic health conditions and rare diseases. In our survey, 25% of respondents have been diagnosed with a mental health condition during or following their sarcoidosis diagnosis. I think it's particularly difficult with a rare disease like sarcoidosis, where patients often won't know other people with the condition, and that can of course lead to feelings of isolation. I would really urge patients to try to connect with other people who can understand what you're going through. This could be in a support group. We currently have over 20 support groups across the country, and those can be a fantastic source of support. Or you could look online for support. There are some fantastic groups on social media. I mean, the SarcoidosisUK Facebook group now has well over 5,000 members, helping each other out and providing support and sharing their experiences, which I think is extremely important. If you do need any help accessing any of this support, please do get in touch with us at any point. You can contact me on leo@sarcoidosisuk.org. I would now like to share a video that I have created in the last sort of week with sarcoidosis patients answering questions about their experience. So I'm just going to share the video with you all and then come back to you.
Well, I was diagnosed in 1974 and I had frequent flares of eyes, joints, skin, lungs and spinal cord involvement. So I've been treated for 31 years.
Sarcoidosis has affected me mainly in two ways. The first one is fatigue, not just feeling a little bit tired, but actually feeling like I have a fatigue hangover after a day or two of physical exertion. The other main area is steroid use. They've had a brutal adverse effect on my personality and they've torn right through my family.
Well, I fall over quite a lot. I fall backwards rather than forwards. My hands and my arms go all tingly and like really painful because they're so tingly, and that's every single day, constantly. I'm waking up in the middle of the night, I'm waking up in pain in different parts of my body, and I get quite upset, I get quite weepy and teary.
The lack of lung capacity is overwhelming. It's worse in the morning, gets better as the day goes on, but it slows me down big time.
The steroids are very hard on your appearance, and that can be hard. Socializing, getting out there, doing the things that you want to do, it does take its toll.
The main concern I have with my sarcoidosis is about what the long-term impact of that will be, whether I am going to end up with impaired vision.
I don't know what to expect. That is one of the issues.
Fear of it becoming active again and causing more damage, and also the side effects of the medication.
My concern is that sarcoidosis is described mainly as a self-limiting disease. So often doctors don't give it credit for actually causing harm to people that may last for their lifetime. And also, when sarcoidosis is flaring, tests are often in normal range, so they may have to avoid referring you because they don't have proof, or refer you with little evidence to the consultant that you need to see.
But after I was diagnosed at the end of January, for some reason sarcoidosis came up on my page on my Facebook, and I realised that there was a Scottish page I joined, so I joined, and I think that's where I found a lot of that information, because I was like unaware of a lot of things before that. But it's joining all the dots for me, all the pieces of the puzzle have come together for me since joining this Facebook page.
The main way that I find my support is through Moorfields Eye Hospital and the Brompton, both of whom have provided fantastic support to me over the last 6 years since my condition was diagnosed. And I also really value being able to look at the SarcoidosisUK website.
Sarcoidosis support comes mainly from my friends, my family, and my partner. People have had to learn to deal with the new fatigued version of me on steroids and be patient with me.
I think that you need to educate yourself about the disease. There's just loads of information out there, but you have to look for it.
Managing sarcoidosis for me, other than medication, is to live as well as possible. This means eating well, exercising regularly, and being disciplined with sleep. It's still quite a trial and error thing for me, and I often get it wrong. But sticking to living a good life is the best advice I could give anybody.
I've seen a couple of times a physiotherapist, and the last time was last week, and he sent me some links and some printouts for exercises to do, and that's been a big help.
My tips for managing sarcoidosis is to listen to your body. It's hard to not feel guilty, but I'm seriously ill, and I couldn't accept it for years, so release the guilt. When flaring, it's like I've been poisoned in every fibre of my body. I've got a hangover, flu, and arthritis. And the more I do, the worse I feel. So pace yourself.
Well, I think my main tip would be that it's really important to think about your lifestyle. For me, it's been very important to think about my stress, to think about generally about healthy living. And I'm sure that as I have managed that better, that has also helped my sarcoidosis.
As with anything in life, you have to accept what you have. You have to make the best of things, keep a positive attitude, and take care of what you have the power to take care of.
I would have told myself to ask more questions of my GP. Exactly what does this mean for me? What treatment is there? I would have a list of questions that I could have asked.
I'd say it's okay not to be everyone's everything. Accept that this is a huge thing for your body. The more I fought the illness, the worse I got. The only way that your doctor can help you is to know your symptoms. Yes, with sarcoid, those aren't always supported by tests, but you need to give honest information, not just what you think the doctor can bear. Remember what sarcoidologists say: absence of evidence is not evidence of absence.
I think I really am still in the very beginning of my diagnosis. I still have trouble believing that I have this thing called sarcoidosis. I have to feel my pacemaker periodically to remind myself that, yes, Patty, you really do have this. This is true. So I tell myself to be patient. Don't allow myself the luxury of feeling sorry for myself. Learn what I can learn, do what I can do, and just keep putting one foot ahead of the other.
If I could give myself some advice at the point of diagnosis of sarcoidosis, it would be to be patient. It's going to be a long road with lots of bumps, steroids being the main one, and fatigue, of course. To hang in there, to trust the doctors, and to live well. From the sarcoidosis patient day, I'm hoping to learn new information from the doctors that will help me better understand and manage my condition. I'm also hoping to hear stories from other patients that would also do the same. And I'm also hoping to be able to pass on information from my own experience of sarcoidosis that others may find useful.
I'm hoping that this patient day helps promote understanding of sarcoidosis and the possible consequences to patients.
I would like to say a huge thank you to Omar, Michelle, Jackie, Patty, Martin, Jane, and Siobhan, all the people who shared their story in that video. I mean, as you can see, even just from the handful of patients we saw, the sarcoidosis patient experience is a varied one and something that we can all learn a lot from. I'm going to wrap up now because I don't want to run over, but we are, just to finish on this, we are so grateful when patients share their experiences with us, and that's good or bad experiences, because it really does inform the work that we do. So if you do have something you want to share, please let us know. We always want to hear from you. Thank you very much for listening. We're going to have a short 10-minute break now, and then we're going to be back at 10:40 with a very interesting session about sarcoidosis as an entity, which I'm really looking forward to. Thank you very much for listening.
in order to keep the schedule on time, I think Felix will introduce the speakers of the first session. I would like to introduce Felix myself. It's a great pleasure to have been working with him for more than 7 years now, Felix. He joined us after a successful career in St. George's Hospital. It's an absolute pleasure to have him with us. Felix, thank you very much.
Thank you very much, Vasilis. And thank you for describing me as looking very young. Actually, in fact, I found a setting on Zoom to make me look even younger. You can get this, so can you see the effect? It takes away all the superficial blemishes at least. Thank you so much. Good morning, everyone. Welcome to the Royal Brompton Hospital Sarcoidosis Patient Day. Dr. Kronos and SarcoidosisUK have curated an excellent day for you, and there will be 6 sessions. I'm chairing the first session, which is entitled Sarcoidosis as an Entity. The 2 speakers will cover, hopefully, 2 fundamentally important areas of sarcoidosis, mainly in relation to causality or etiology or cause. There'll be Dr. Simon Hart's talk, and the second talk is Dr. Mohanthan Thillai, who will touch on diagnosis with some light shed on biopsy. Let me introduce them. The format will be, we'll have both speakers in succession, and then we'll do the questions at the end, if that's okay. Dr. Simon Hart is a very experienced physician. He's the lead clinician in the interstitial lung disease service in Hull. Simon has been involved in research and clinical practice for a long time. He has research interests covering both laboratory and clinical research in sarcoidosis. He's a co-author on the BTS clinical statement on pulmonary sarcoidosis that was published recently. And the title of his talk is Causes of Sarcoidosis, What We Know and What We Don't Know. He'll be followed by Dr. Mohanthan Thillai, who is the lead of the clinical interstitial lung disease service in Cambridge, which is a very large service and a regionally very important service. Mohanthan's specific interest is in sarcoidosis. He's actively involved in research and clinical practice. He too is a co-author on the recent BTS statement on pulmonary sarcoidosis. And Mohanthan's talk is entitled Diagnostic Guidelines in Sarcoidosis, Is Biopsy Necessary? So that's the introduction. We'll do the questions at the end. I'm hoping to do, for Simon to take 2 or 3 questions. We've gone through the questions, grouped them together by connection, by relevance and common themes. So he'll do 2 or 3 questions, Mohanthan do 2 or 3 questions. But what we're going to do is take one from Simon, then one to Mohanthan, and vice versa. We'll do them in sequence that way. So Simon, if you're ready, off you go.
Thank you very much, Felix, and thank you also to Vasilis and Leo for inviting me to speak at this fantastic event. So the cause of sarcoidosis, what we know and what we don't. Well, we don't know the cause of sarcoidosis, and in that respect, we're not too different from Louis Siltzbach, an American pathologist who did a lot of sarcoidosis research in the middle of the last century. And this was a quotation from him 70 years ago. What has changed is that we understand quite a lot more about the biology, and I'm going to show you some of that evidence today. Why is it important to know the cause of sarcoidosis? Whilst many people with sarcoidosis get better with no treatment, many have persistent or progressive disease that causes a problem, as we've heard about from some of the patient stories this morning. And if we're going to develop better treatments, and if we're going to achieve the charity's ultimate aim of finding a cure, we're going to need to identify the cause. So in terms of thinking about that, let's focus down at the microscopic level and think about what's going on under the microscope in these abnormal areas in people with sarcoidosis. So in a person who has a biopsy, we would find abnormal areas like this, and this bit of lymph node is largely replaced with these round collections of cells that are called granulomas, and this is very characteristic of sarcoidosis pathology. And what each one of these granulomas, about the width of a couple of human hairs. So about
Simon, sorry to interrupt you. We don't have your screen.
Okay, I'm sorry about that. It looks like I'm sharing my screen, but let me just see. Maybe I didn't click the final share button.
Perfect.
Technical hitch at the beginning. This is the granuloma. These are collections of granulomas outlined in yellow here, and these are each the width of a couple of human hairs. And these are the characteristic findings in sarcoidosis. What are these granulomas made up of? If we look a little bit more closely, what cells are there? These cells are mainly called macrophages, and they're stained brown in this particular stain. So these are the dominant cells within the sarcoidosis granuloma. So let's think a little bit more about macrophages, what they are and where they come from. A macrophage, the word comes from the Greek, meaning large eater or large eating cell. And these cells are designed to eat and digest bacteria and other foreign particles. The macrophages themselves derive from circulating white blood cells called monocytes in the blood, which are themselves produced in the factory in the bone marrow. So when we're thinking about what causes the characteristic granuloma in sarcoidosis, it's worth thinking about what else do we know causes granulomas like this? Well, tuberculosis does, a disease that affects about 1/3 of the world's population. And so when we're thinking about how a granuloma forms, most of what we know comes from studies of TB, and we think the same processes occur in sarcoidosis. My own hospital, like many, used to be a TB hospital where patients were given fresh air treatment before the development of TB treatments. So let's use TB as an example of what happens when a granuloma forms. First thing that happens is that a person inhales the TB bacteria into their lungs. In the lungs, these bacteria are recognized and eaten by a patrolling macrophage. That's what the macrophage does. The macrophage finds that these bacteria are difficult to digest, so it realizes it's going to need some help here. So it sends out chemical signals that bring in more cells from the bloodstream, including these monocytes, which are going to later turn into more macrophages. At the same time, parts of the TB bacteria are shown to other immune cells called lymphocytes, which react by proliferating and dividing, and they're going to provide immune memory. They're going to remember this bug if the person sees it again, and we'll come back to that concept a little bit later. What happens then is that the monocytes turn into macrophages, more cells are brought in due to more chemical signals, the process continues, and you can see what's happening here. We're ending up with a collection of cells dominated by these macrophages in this round cluster, which is the granuloma that we see in TB and in sarcoidosis. Now, why don't these cells go on their way, go back to where they came from, die off, and the whole thing disappear? Well, they don't, because they release chemical signals that act on neighboring cells to maintain the cells in states of heightened activation and maintain the granuloma. One of these chemicals is called TNF, and we have drugs that can block TNF, and steroid treatment works partly by blocking these chemical signals. Now, in TB, we need a granuloma. The granuloma has a purpose to contain the TB infection and prevent it from spreading around the body. But in sarcoidosis, we can't find any TB bacteria. So what we want is that granuloma to slowly resolve, the cells to go on their way, and for it to go away. So thinking about the similarities between TB and sarcoidosis, Siltzbach again in the 1950s proposed that there were two concepts about the cause of sarcoidosis, that it is not tuberculosis because we can't find any of the bacteria, or that it is in fact a form of tuberculosis where for some reason we can't find the bugs. So that really brings us on to the first theory of sarcoidosis, that is that sarcoidosis is caused by an infection, maybe like TB, or if not infection, some other particle that stimulates an immune response. Why might we think that this is a reasonable theory? Well, if we just look at the parts of the body that are affected most commonly by sarcoidosis, they're parts of the body that are exposed to the environment, the eyes, the skin, the lungs, and so may be exposed potentially to infection. More evidence for infection comes from a historical skin test for sarcoidosis called the Gavine test, where patients with suspected sarcoidosis were injected with a mashed up preparation of a spleen from another person with sarcoidosis that may contain some infective material. And a few weeks later, if the person has sarcoidosis, when injected into the skin, this material leads to the development of these granulomas that appear as a lump, which can be proven then on biopsy of that lump. This suggests there may be immune memory in people with sarcoidosis against some sort of infectious agent, again, taking us back to this concept where bits of bugs are shown to cells of the immune system. And this is also relevant to studies of genetics of sarcoidosis. So the gene sequence in the DNA sequence that encodes our genes varies between each of us, and genome-wide association studies can look at how variations in genes are linked to disease risk. And a number of genes have been linked to sarcoidosis risk. And it doesn't matter what the names are, except that many of these genes are involved in this process of showing pieces of infection to other immune cells and generating immune memory. So that suggests an infective cause. So what might that infection be? Could it be TB, another bacteria, a virus, a fungus, some other sort of particle? All of these have been proposed. There are scientific papers supporting all of these, but also scientific papers refuting all of these. So overall, the evidence for a particular infection causing sarcoidosis is currently inconclusive. If microbiology can't give us the key, what about asking people with sarcoidosis what they're exposed to in part of their life, leisure, work, and compare that with what people without sarcoidosis may be exposed to and see if we can identify what it is that causes sarcoidosis. This study has been done, and I've just picked a few of the headline results here. And the column on the right, the odds ratio, is how much more likely these exposures are in people with sarcoidosis compared with healthy people. So any number above 1 is more likely in people with sarcoidosis. But these are weak risk factors, 1.5 times, a bit more likely. That's not very strong. And so the overall conclusion from these studies are that the risk factors identified are weak, but no specific cause could be identified. So I've shown you some evidence for and against an infective theory for sarcoidosis. Could there be another theory? Well, I'm going to propose some evidence to you for an alternative theory, which is that the cause of sarcoidosis is because these macrophage cells are overexcitable and tend to form granulomas in response to things that we're all exposed to as part of our normal life and work. This is not a new theory. In fact, an early variant of this theory was proposed in the 1960s, this time by a Dutch dermatologist called Kuj, and he called it terrain sarcoidique, which I don't really know what that means, but I thought it had a nice ring to it. What about an example? People with tattoos who are affected by sarcoidosis in their skin often find that the sarcoidosis granulomas prefer the tattooed areas of skin, suggesting that the cells there are reacting to the tattoo ink. These pictures were taken by a patient of mine who kindly consented to me sharing them with you. And these are little nodules or collections of granulomas in his tattooed skin. What other stimulants might induce an over-exaggerated response? This is a fascinating paper from Germany, just published this year, looking at how changes in sarcoidosis diagnoses in blue here were related to changes in air pollution in red and yellow, and suggesting that there was a time difference of a lag of a couple of months between changes in air pollution mirrored by changes in sarcoidosis diagnosis. Maybe air pollution may be a stimulant in some people. If we think the cells are overactive, can we prove that in the laboratory? We can take those blood monocytes, the precursors of the macrophages, and this is some work from our laboratory where we simply stimulated these cells in the laboratory with an extract from uncooked red kidney beans, so a general stimulant of immune cells, and found that the patients with sarcoidosis had blood monocytes that reacted more strongly in terms of releasing these chemicals that maintain the granuloma that we saw earlier. So they do seem to be hyperreactive. Here's a nice study from Ohio, where they took the monocytes from people with sarcoidosis and stimulated them with undigestible plastic beads, and found that the monocytes from people with sarcoidosis formed clumps in the dish in the laboratory, shown here, a bit like a granuloma. And my final piece of evidence that I'm going to show you is this fantastic work from Vienna, where they developed genetically modified laboratory mice, where the macrophages in particular were overactive. And they did that by manipulating a chemical pathway inside the cells called mTOR. And these are laboratory mice, so they're not exposed to infection. They have a very clean environment, and all by themselves, these mice develop granulomas in the lungs and in the skin, very similar to sarcoidosis, suggesting that if you have overexcitable macrophages, you can develop granulomas like sarcoidosis. So I've presented to you some evidence for and against two theories. And on further scrutiny, some of the bits of evidence I've shown you can actually be interpreted either way in favor of either theory. And it may be that the truth is that there's a bit of both. That in order to get sarcoidosis, people need for some reason to have overexcitable monocytes and macrophages, and potentially then be exposed to a stimulus to trigger the formation of granulomas. So whilst we don't know the cause of sarcoidosis, similar to 70 years ago, we do understand more about the biology. But what you can see is that there's a lot more research to be done. And that's why the work of Sarcoidosis UK in terms of funding research, with funding from its fantastic fundraisers and those of other sarcoidosis charities internationally, that's going to be absolutely vital going forward. Thank you very much.
Thank you very much, Simon. That was excellent. We're going to go to Mohanthan. Mohanthan, it's over to you.
Thank you very much, Felix. I'm just going to try and share my screen. So please tell me if you can't see this, but I'm assuming that everybody can see this. And can you see the slides, Felix, okay?
Absolutely.
Great. Okay. So hopefully there isn't too much of the other stuff on there. So thanks a lot, Felix, and thanks, Simon, for a great talk. Thank you to Leo and Sarcoidosis UK, and also Vasilis and all his colleagues at the Brompton for putting on such a fantastic day. It's really exciting to talk to you all about sarcoidosis. So I'm going to talk about biopsies. I'm based in Cambridge at the Royal Papworth Hospital, and we've been thinking a lot in the last few years about biopsying different parts of the body and biopsying the lung for sarcoidosis. And there has been a relatively radical shift in our thinking for biopsy. In simple terms, 20 or 30 years ago, doctors and nurses wanted to biopsy all parts of the body, especially the lungs, to try and diagnose sarcoidosis. We're a little bit more conservative now, primarily because CT scans and the ways we look at images of the lungs are so much better that we don't always biopsy the lung when we have a confident diagnosis. And I'll explain that to you. So you saw this picture earlier from Simon. This is from a recent publication, and this shows you that sarcoidosis around the world can affect almost any part of the body, the liver, the bone marrow, the kidneys, the spleen, but it predominantly affects the lungs. In between 70 and 90% of cases, the lungs are affected. And if other parts of the body are affected, like the heart or the eyes, often the lungs are also affected. So most of sarcoidosis, especially in the UK, is looked after by lung doctors and nurses, but we have to have an understanding of different parts of the body, especially when we want to think about biopsy. And so why do we biopsy? For something like this? This is a CT scan, and so some of you as patients will have seen your own CTs, but if you haven't, imagine this as a very detailed X-ray, and this is a slice through somebody's chest. The very big blob in the middle is the heart, and the two larger black areas are the lungs, and there's an arrow there pointing to a lymph node. And in this person, the lymph node is a lot bigger than it should be. And the problem with this sort of picture when you see a patient is that this could represent one of a million things. It could be sarcoidosis, it could be cancer of the lung, it could be cancer spread from somewhere else, it could be an infection, it could be anything. And interestingly, in this patient, it turned out not to be sarcoidosis, but a fungal infection. And so often when we do biopsies, it's not necessarily to confirm sarcoidosis. It may be that we're pretty confident that it's sarcoidosis, but there are other diseases like cancer and infections that we're worried about, and we don't want to miss that. So sometimes we biopsy patients really just to make sure it's nothing else, even if we're reasonably sure it's sarcoidosis. And Simon showed you earlier, when you biopsy, you get these very typical clusters of cells called granulomas. The big round cluster in the middle is a collection of cells that you find in the lungs or anywhere else. And often this is quite strongly suggestive of sarcoid. So why have things changed? Well, there have been 2 new guidelines in the last year, one from the United Kingdom and one from America. And I want to briefly go through those guidelines in terms of biopsies. And the reason this is important is that these are the first new guidelines for more than 20 years. Until the last year, the main set of guidelines were published in 1999. This was an international statement by Europe, Japan, and North America, and this was called the International Statement of Sarcoidosis. And back then, which wasn't that long ago, things were very different in terms of biopsies. And that guideline strongly suggested that a biopsy was almost always needed to diagnose sarcoidosis. And as I said, in the last year, we've radically changed the way we think about biopsies. So going back to 1999, the statement then clearly said that in order to diagnose a patient with sarcoidosis, you needed 4 things. And the very first thing that it suggested was histologic confirmation of disease. And histologic is histology, which is biopsy. So the guidelines suggested strongly that the first thing to do was get a biopsy of somebody's lung or heart or organ. You then needed to work out the extent of organ involvement, work out whether the disease was stable or not, and work out whether treatment would be useful. But the biopsy was first and foremost. And they talked about types of biopsies, and they said the number 1 way of biopsy is called a transbronchial lung biopsy. And I'll show you an image of that later. A transbronchial lung biopsy is usually done under sedation. Some of you would have had this procedure, I'm sure, or know about it. And you pass a camera through the nose of the mouth into the lungs, and under X-ray guidance, you take a little piece of lung tissue out. Now, it's a safe procedure, but like any procedure, it does have risks, and it's something you always think about carefully before we go ahead and do. The guideline also said that if you can't do transbronchial biopsies, or if you do a transbronchial biopsy and you don't get an answer, then you need to call our surgical friends. And our surgeons come along and they put the patients to sleep with a general anesthetic and do a proper big lung biopsy, usually from the outside through keyhole surgery. And again, that's a relatively safe procedure, but it's not without risk. And our surgeons here in Patworth and in many other hospitals do this, but it's more of an intense procedure. And interestingly, you'll see that it said that some patients may refuse a biopsy. Now, we don't really use words like refuse anymore. We're much more patient-centric, as you can see if you read the guidelines, which is great. But back then, they very clearly said biopsy, biopsy, biopsy. And if you're not sure, do a biopsy. So what's changed? Well, in the last year, as I explained, 2 statements or guidelines have come out, written by various experts, doctors, nurses, and patient groups. The British Thoracic Society statement came out a few months ago, and Sarcoidosis UK were part of that. And the British Thoracic Society document looked at lung sarcoidosis in totality, from diagnosis, including biopsy, to scans, to treatment, to follow-up of patients. Around the same time, or actually a few months before, the American Thoracic Society sent out their own guidelines. Now, these guidelines were not about lung sarcoidosis in general, but about diagnosis and detection of sarcoidosis. And so they also went into quite a large amount of detail about biopsies and when to and not to. And the really fantastic thing is that although both statements are written totally independently by different groups of people, they pretty much said the same thing when it came to biopsy. So what we now say is that we should biopsy patients when the diagnosis is unclear, meaning that in some circumstances, the clinical story, the scans of the patients, the images are so clear that this is sarcoidosis and so very unlikely to be anything else that actually we don't say you should biopsy those patients. And I'll show you 2 examples of such patients. We also say in those situations, even if we don't biopsy patients, we still have to follow them up quite carefully. And finally, what we all say clearly now in Europe and North America is that these decisions to biopsy or not should really be made with specialist advice. we've gone away from the days of a single doctor, perhaps a lung doctor, making decisions on when to biopsy the lung. We now have regular meetings called multidisciplinary meetings, or we sit down as teams of doctors and nurses and we make decisions about things like biopsy. And it's really crucial that the patient is always part of that, because even if we really want to biopsy somebody's lung or heart or something, the patient may not want to. And it's really important that we sit down together and talk about the risks of a biopsy and the need for a biopsy. So here are two situations where we don't biopsy anymore because we're reasonably confident the diagnosis. So all of the guidelines now in the UK and in the USA say that if you have this condition, Löfgren's disease, that some of you may have had or heard about, we don't biopsy. Löfgren's is a very acute form of sarcoidosis. It tends to come quite quickly, and it usually has a triad of three things. On the left, you can see a picture of somebody's X-ray, and the big triangular thing in the middle is the heart, and next to the heart there's two big white blobby areas are lymph nodes. And when you have very classical lymph nodes like that, and a type of arthritis, usually in the ankles but can be anywhere else, and the third thing, erythema nodosum, this very typical skin reaction, often on the front of your legs, that comes on very quickly and tends to all go quickly, we're very confident that if you've done some blood tests and taken a good story from a patient, that this is sarcoidosis. Now, we don't tend to biopsy these patients, but we do tend to follow them up with scans and images and breathing tests. But here's a very clear example now where we don't biopsy patients unless there's a very specific reason. This is the second type of patient that we don't biopsy, because sometimes, as you know, sarcoidosis is very acute and people get unwell very quickly. Other times it's either an incidental finding or they've had a diagnosis of something else for many years. And when we look back at the scans, if we're confident that on CT scans you have sarcoidosis, and importantly that it's chronic and stable over many years, that makes it much less likely to be anything different, much less likely to be a cancer or a lymphoma or something else. So if we see patients as new patients, but they've had a story that sounds like sarcoidosis for many years, and they've got scans going back many years, then again, we don't tend to biopsy. And just to go through these scans on the left to show you what they are, they're all CT scans. So again, very detailed X-ray type images. And on the left, there's a red arrow and it's pointing to a little outpouching. And this is an endobronchial lesion. So when you look down the airways into somebody's lung, there's an outpouching, which is quite typical of sarcoidosis. In the middle picture, the lymph nodes are shown, and that little white fluffy bit that it's pointing to is called icing sugar calcification. And that could be due to other things, but in the right setting, icing sugar calcification is suggestive of sarcoidosis. And finally, the picture on the right is what we call endobronchial beading along the fissure. So the fissure is a line that separates different parts of the lungs. And if you have little beads along that, again, that's very typical for sarcoidosis. So just to summarize what I've said, and this comes out from the British Thoracic Society statement from a few months ago, in general, when we have confident imaging, so a confident picture of somebody's lungs, whether it's on a scan or an X-ray, and as a team, we're confident the story sounds like sarcoidosis, we don't tend to biopsy those patients. We do follow them up because sometimes we get it wrong, of course, and we have to be quite careful that we follow these patients up in the clinic with scans or breathing tests, but we don't tend to. However, if the features on scans are what we call atypical, so they're not highly suggestive of sarcoid, they could be sarcoid, but they could be something else, that's when we offer a biopsy and we sit down with patients and say, something along the lines of, well, we think this is probably sarcoidosis, but I'm not completely sure it is. And given the fact that there's a little bit of uncertainty and there are some other worrying things it could be, we really would want to do a biopsy. And those are the situations where we now do a biopsy. Talking about biopsy, and I'm talking again about the lungs, because most of the time we biopsy the lungs, although we do biopsy lymph nodes and skin lesions as well. There are different ways of biopsying the lungs, and some of you would have had a bronchoscopy. You may have been awake or sedated, you may have seen what's happened. In the top left, that's a picture looking down the camera, down the telescope into somebody's lungs. And you can see all the way down to the bottom where the airways go down to the edge of the lungs, but it looks very unusual to those of us who do bronchoscopies. It should be very pink and smooth, but you can see lots of outpouchings, and we call that cobblestoning. And And if you biopsy that, that's quite typical for sarcoidosis, and you often find those sarcoidosis granulomas. The top right picture is something called an ultrasound biopsy. And again, in 1999, in the original types of guidelines, we didn't talk about ultrasound biopsy because it was a new thing. It's a much more common thing now. And here, if we want to biopsy the lymph nodes, so those are the lymph nodes outside of the airways, when we put the camera down into somebody's lungs, we then add on the ultrasound probe. And that allows us to see outside of the lungs into the lymph nodes. And you may be able to just see at the top of that a very sharp white line going down. And that's the needle going out to the airway into the lymph node as it's biopsied. The bottom left is just a tube to suggest that we sometimes wash out people's lungs, and some of you might have had a washing of your lung to look for sarcoidosis. It can't diagnose the disease, but it can sometimes help support the disease. And we also do washings of people's lungs when we want to look for infections in sarcoidosis. And then finally, the bottom right is the transbronchial biopsy, the one that I mentioned at the very beginning. We do those, but less commonly nowadays. But we do those by passing a very small needle through the camera and out of the end of the camera to the edge of the lung. And we take biopsies from the edge of the lung itself. And very clearly in the British Thoracic Society guidelines, if you read them, it very clearly tells you if you're a lung doctor or a lung nurse, how to go about biopsying the lung and in which circumstances. So as I've said before, if it's a very typical situation or you have very chronic long-standing sarcoidosis, we don't biopsy. We may do bloods and breathing tests, but we don't biopsy the lungs. If it's unusual and the patient has very big lymph nodes, then we tend to do what's called an EBUS, that ultrasound biopsy type thing. If they tend to have not big lymph nodes, but lung disease, so actually the lymph nodes are okay, but the lung tissue is affected by what's probably sarcoidosis, that's when we do this thing called the TBBX, that's the transbronchial biopsy predominantly. And we also say if you've got sarcoidosis throughout your lungs, in the lymph nodes and the lung tissue, we tend to choose the ultrasound version first. The reason being is that you have a higher diagnostic pickup rate than the transbronchial biopsies. And if you look at all the data over the last 20 years, it tends to be a safer procedure to do than the transbronchial. So just to finish up with my last couple of slides, something that's slightly different, and you'll hear Dr. Karanas talking about this later, heart sarcoidosis. We tend to get a bit twitchy about heart sarcoid because sometimes patients are well, and even though they have lung disease, we don't treat them. But if they have heart disease, it can be, not always, but it can be something more concerning. So if we have a patient and we're unsure as to whether or not they have heart sarcoidosis, we tend to have a slightly lower threshold for biopsy, because in those cases, we need a really confident diagnosis. It's very rare that we biopsy the heart. We do it in our hospital and other hospitals. The reason that's rare is that, one, it's slightly riskier than biopsying the lung. But secondly, because sarcoidosis, when it affects the heart in patchy areas, unlike biopsying the lung, it's a lot harder to work out where you're going in the heart, and you're more likely to be taking blind biopsies. And it may be that the areas that you biopsy actually don't have the typical granulomas, and you've missed it by just biopsying. So what we tend to do is, as I mentioned at the beginning, a lot of these patients with heart sarcoid also have lung sarcoid, is we tend to do a lung biopsy. And then we tend to do a special heart scan, an MRI or a PET scan that you'll hear about later. And combining them, we say we're confident you have heart sarcoidosis. I haven't talked about the skin or lymph nodes, but these are other areas as well. So in summary, things have changed over the last 20 years, and we don't just biopsy sarcoid for the sake of it. Sometimes, whether it's a very acute case of sarcoid like Löfgren's or very chronic disease, we can be reasonably confident this is sarcoidosis. And as long as we follow up patients, we don't have to biopsy them. Secondly, because the lung is the organ that's most affected, that's the organ we tend to biopsy. And there are many different ways of biopsying the lung, using ultrasounds, using X-ray type probes, but we now have very clear protocols on which type of biopsy to do in which order to get the best answer. And then finally, the heart's a special case. And if we're worried about heart sarcoidosis, we may need a little bit more confidence. And so we may biopsy the lung to be absolutely sure in instances where we wouldn't if we weren't worried about heart sarcoidosis. So thank you very much. And this is our lovely hospital in Cambridge that some of you might have come to. And I'm going to hand back to Felix and stop sharing the screen. Thank you, Felix.
Mohan, thank you for that excellent talk. and to Simon too. So we're going to do some questions. We've got a bit of time, actually. I think we've got until 11:20, so there's 11 minutes. The first question is an amalgamation of two short questions, and this is going to be for Simon. And Simon's seen the question, so we can amalgamate them. Essentially, how big a part does genetics play in sarcoid? And the person who's asked this says, as a parent, I worry about it, whether my children will get it. The second question, which is very similar, overlapping, is how far is sarcoid hereditary? So Simon, if you could answer that question, please.
Thanks, Felix. This is clearly something that concerns people. We had a few questions submitted in advance about familial risk of sarcoidosis, and I see some questions in the chat this morning about the same. So it's clearly something that concerns people. The research that's been done, Felix, suggests that if you have an affected family member with sarcoidosis, a first-degree relative, so a parent or a brother or a sister, that you're probably about 4 times more likely yourself of developing sarcoidosis than somebody who doesn't have an affected relative. So that is a reasonable genetic risk. But remember, you should be reassured that sarcoidosis is a relatively uncommon disease. So if you think that the risk of sarcoidosis on average in the population might be 1 in 10,000 people per year, then if you have 4-fold increased risk, then your risk is about 1 in 2,500 per year. So 2,500 to 1 is still pretty long odds. So the familial risk does tell us something about that there's a genetic component, something about your genes, but it doesn't confer an absolute very high risk. I hope that reassures people.
Simon, thank you very much. Can I just add a little bit to that, because other people may be thinking this. In regards to not so much genetics, but ethnicity, what are the overlaps between ethnicity and genes in sarcoid? Maybe just a broad answer to cover that bit, if you could.
Yeah, that's a very good point, Felix. We know that sarcoidosis much more commonly affects Black people. So the Black population has about a 10-fold higher risk of sarcoidosis than the white population, and they tend to get the different forms of sarcoidosis as well. So clearly there is risk related to genetics related to ethnicity. There is variation across the world as well.
Wonderful. Thank you very much, Simon. The next question is for Mohanthan. Mohanthan, the question is, if sarcoidosis is affecting various parts of the body, for example, the skin, the lungs, the brain, and the liver, what specialists should you see? And how would you prioritize this in the context of several organs being involved, or at least having symptoms coming from several organs? I think this is a very common question in the clinical arena, isn't it? So that's for you, Mohanthan.
That's an absolutely brilliant question, because it affects any part of the body. When you're first diagnosed, you may end up not seeing a lung team. So if you have an eye problem, you may end up seeing the ophthalmologist. A heart problem, you see the cardiologist. But at the end of the day, once you have the diagnosis, you tend to come to the respiratory team, the lung team, because most of the time when you have sarcoidosis, the lung is affected. Now, we have lots of patients in our clinics, like all of your clinics, who have lung sarcoid and actually only have minimal lung sarcoid, but maybe have very bad eye disease or very bad heart disease. So it's really important that if they're seen in, and I'm using the lung clinic because that's where they're most commonly seen, that we work with our specialist colleagues and all of the various different teams to make sure patients are getting the best care. And there are certain, and if you read the BTS statement as well, there are certain times when we worry about sarcoidosis and treat them. And often it's outside of the lung. So I mentioned the heart. Patients who have heart sarcoidosis, we worry about a bit more. And so we're always careful that they're under a cardiology team. Patients with eye sarcoidosis, we worry about. So we now tend to recommend baseline eye tests when you're first diagnosed. If you go on certain drugs that can cause eye problems, we do regular eye tests. So again, you can come into the diagnosis of sarcoidosis through many ways, but unless you have isolated organ disease, so just eye disease, let's say, nothing else, you tend to be under the lung doctors and nurses primarily.
Mohanthan, thank you very much. Simon, I'm going to come back to you. I'm going to combine a question I've just seen on the chat and one of the questions that was sent in yesterday. So the first question comes from the chat. If a person has sarcoid in, say, the lungs, and there's another member of the family with sarcoid in a different site. Clearly that's possible. Perhaps you could touch on how likely or how common that can happen. The second question is related to that. Does current research differentiate between possible causal factors and the site of sarcoidosis, please?
Thank you, Felix. Good questions. I'm pleased that Mohantan, in his talk, gave a little description of the acute form of sarcoidosis called Löfgren's syndrome. I didn't know Mohantan was going to be talking about that, but it's actually quite important in terms of answering the question, because much of the genetic risk studies, particularly related to that immune memory antigen presentation bit that suggests an infective etiology, most of those studies have been done in those patients with acute Löfgren's syndrome, which seems to be particularly common in Scandinavia, but does occur in this country. So I think that the infection theory is more likely for the acute Löfgren's syndrome, which does often appear as a flu-like illness with a fever as well. So it's kind of like an infection. Whereas I prefer the macrophage overexcitability theory for those patients with more chronic ongoing sarcoidosis. In terms of the different parts of the body, well, the Löfgren's does tend to affect the parts that Mohantan talked about. Of course, the other difficulty with trying to compare sarcoidosis in different parts of the body is that it does depend on how hard the doctors look at the different parts of the body as to whether you find it there or not. So I think that's a difficult one to answer.
Simon, thank you very much. Mohantan, back to you. The next question is, I originally had a biopsy done by a skin specialist, and later I was sent to an infectious disease doctor. I was told that there was no way to differentiate, to tell between TB of the skin and sarcoid. This led to another biopsy and culture, and I was finally diagnosed as sarcoid and was told that there was no treatment. So I think the question is touching on similarities and differences between, and the difficulty in differentiating between two conditions that mimic one another. And if you could touch on that, please.
Sure, and that's a brilliant question. I mean, these questions are really good, actually. It's a shame we haven't got all day to answer them. As Simon said in his talk, going back to his great talk, TB may be a trigger sometimes in sarcoidosis. When we look at populations, especially in Eastern Asia, so Japan and China, there are a number of different types of propionibacteria bacteria related to sarcoid, and in Scandinavia, a number of different kinds of mycobacteria, so a type of TB. One of the reasons we biopsy patients is to try and work out whether it's sarcoid or TB, because sometimes they can look very similar. And so when we do biopsies of the lung for sarcoidosis, we always send them off for culture for tuberculosis staining. Now, the problem with that is that TB bugs take a very long time to grow. So you may have to wait for some weeks before you actually grow TB. And sometimes, of course, patients have sarcoidosis and TB, so it makes it even more complicated. There are a newer set of blood tests for TB that have come out over the last few years. They don't tell you whether you've got active tuberculosis or not, but they do generally tend to be quite good to tell you whether you've got a history of tuberculosis infection. So I think the short way of answering that very long answer is that those diseases are very similar, and that's one of the reasons why we tend to do lots of biopsies. And sometimes we get it wrong, and sometimes patients have coexisting latent or dormant tuberculosis and sarcoidosis. And then you run into all sorts of difficulties about, do you treat the TB first or do you treat the sarcoid? And so this is quite a complicated area, but it's another reason as to why we do sometimes have to biopsy patients.
Thank you, Mohantan. And I guess in the clinical arena on a day-to-day basis, often, as you said, we conclude that it may not be TB. We can't rule it out. We do go for TB treatment because if that person then needs heavy immunosuppression at some time in the future, at least you've bought that insurance, that you've covered the TB part.
Yeah, that's exactly right. So we tend to be, like you said, extra cautious and sometimes give them a few months of TB treatment, thinking, actually, I want to be absolutely sure there's no active TB before I start giving them steroids or even stronger drugs for their sarcoidosis. Yes. Yep.
Thank you. There is just 1 or 2 minutes. In fact, I've just realized there's a 10-minute gap for a break. So we could probably just run over a couple of minutes. The next question, I think I'm going to put it to both of you. There are 2 questions in the chat. One touched on lymphoma. Somebody has said, I've had sarcoid and a member of the family has a lymphoma. Another person has touched on breast cancer. So I guess malignancy lymphoma and how they interject and overlap with sarcoid. Is there such a thing? So to either of you, please.
Well, there is, if I may start, there is a connection. And I didn't have time to mention that. I think people should be reassured, and I see some questions in the chat about, if I have sarcoidosis, might I develop cancer? Well, the answer to that is generally no. But people who have cancer, some people get something that looks like sarcoidosis or a sarcoid-like reaction, where the trigger there is not an infection, but actually seems to be the tumor itself. So we do see some people with lymphoma or other cancers who then develop sarcoidosis. Not that commonly, but it does happen. Mohantan, over to you.
Yeah, it's exactly the same, Simon. So sarcoidosis is not cancer, and it's not the same thing. But we do see cases of patients, and they tend to be cancer in the chest, really, or in the abdomen, that sometimes causes sarcoidosis. So I can think of a number of cases where patients have definitely had cancer and it's all been cured, and then a couple of years later it looks as though the cancer's come back or spread, and luckily for them it turns out it's sarcoidosis. So we're pretty confident this is what we call a sarcoid reaction to the cancer, because as Simon said in his talk, we don't know the cause of sarcoidosis, but when your immune system is altered by something like cancer, it may make you more likely to develop sarcoidosis down the line.
Thank you, Mohantan. I think there probably is time for one more question. Is everyone up for it? It's the last question on the list that was sent for Mohantan, but again, open to either of you. And I think this is important because, you know, sarcoidosis is for many people, it's a lifelong condition. And this person asks a very pertinent question. How confident can I be that the diagnosis of my fibrotic pulmonary sarcoidosis is exactly that, without having a biopsy? Because they're looking at years of having this condition and treatment to go with it. So either of you, please.
I mean, I'll say briefly and then let Simon. That person sounds like they're a professor of sarcoidosis to ask such a question. You can't be confident. So at the end of the day, without a biopsy, you can only be very, very confident, but not absolutely confident. And sometimes when you have fibrosis of the lungs that looks like other diseases like IPF or idiopathic fibrosis, it may be that it was sarcoidosis all along. Now, there are images and things within CT scans that make you much more confident that it's sarcoid. But sometimes without biopsies, you don't know. And the problem is when somebody has very fibrotic and damaged lungs, they may not be suitable for a biopsy, or they may not be safe for a biopsy, or even if you biopsy them, you may just see fibrosis and not sarcoidosis. So that's a difficult thing. But with the advent of some of these newer anti-fibrosis drugs, some of them may be available for fibrotic sarcoid down the line. So in a way, if you've got very bad fibrotic sarcoid, you might have the same sort of treatment as if you have lung fibrosis in general.
I completely agree with you, Mohantan. It's one of the challenges, and clearly one of the things that we spend a lot of time doing careful detective work with, including in our multidisciplinary meetings, isn't it, to try and work things.
Absolutely, yeah.
Great. We've got 8 minutes of the 10-minute break. The last question will be from me. For the two of you, we're going to set the bar very high for this session. So all other sessions I have to hit this bar. To the both of you, is sarcoid an autoimmune condition? And we're not going to restrict ourselves to the conventional confines of autoimmunity, but is it, broadly speaking, an autoimmune condition?
I'm going to say one word, maybe, and then I'll let Simon give a proper answer.
Yeah, well, I come back with the same. I mean, in my little diagram that I put up, albeit very briefly, about the possible triggers, the antigens, self-antigens, which are the causes of autoimmune disease, are in the list as well. Some have been proposed, things called vimentin and serum amyloid proteins. There is some evidence, but like all the other things, there's evidence against as well. So I think unlikely, but I can't rule it out.
All right, great answer from the both of you. Thank you very much indeed to Dr. Mohantan Thillai and to Dr. Simon Hart. Leo, I think that concludes the first session for today.
Yes, thank you very much. We'll now have a short break and we will be back at past. Thank you very much. That was fantastic.
Thank you, everyone.
Bye.
Thank you, Felix. Thank you, Mohantan. Thank you, Simon. I think that we can move on to the next session. And it gives me great pleasure to introduce the next chair, as well as the speakers. Dr. Elizabeth Renjoni is one of our senior consultants, being part of our group since 2006. She is very well known for her excellent clinical skills as well as relationships with most of our patients. I've learned a lot from her over the years, and thank you very much, Elizabeth.
Thank you, Vasilis, for that very kind introduction. And I just wanted to join the others in complimenting you for putting together such a fantastic day. We hope it will be the first of many. And thank you to Sarcoidosis UK for allowing this to happen. It gives me great pleasure to introduce this session, which promises to be very interesting. We have 3 speakers, and we will have a question and answer session after each speaker. The first speaker is Professor Wells, whom you all know. Arthur is a very dear friend. He has been a mentor to all of us, has been a tireless patient advocate for sarcoidosis, has led in clinical guidelines, is the vice president of WASOG. And I think one of his many talents is that of simplifying what could seem to be very complex issues in the management of sarcoidosis. And so we will hear more about this from Athol.
Prof, if you can unmute yourself.
Yes, I'm just grappling with the technology here. Those that know me will not be surprised about that. Can you see my slides?
Yes, we can.
Very, very good. So add my congratulations to Vasilis and also to Sarcoid UK. And I have to say, I have to recover slightly, Elizabeth, from your introduction and regather my thoughts. Now, what I am going to present today is very simple, and I will try to keep this to about 12 minutes. I was struck by the quality of the questions. I've taken out 1 or 2 beautiful slides that don't actually add to the content. And what I'm going to speak to is really terribly simple. It is a sea change, I think, in how we think about introducing treatment in sarcoid. The concepts underpin much of what is said in the BTS clinical statement on pulmonary sarcoid. They also underpin the first world guideline on treatment, which is now virtually in press. And so let me proceed. I'm talking about treatment, and I'm talking about drug treatment. Plainly, treatment includes many other actions, and that includes the provision of clear information, reducing stress and anxiety that may in itself drive sarcoid activity. So I am narrowing down to treatment as drug treatment. And let me start by describing the past confusion. Around the world, there was a tendency to overtreat, introducing steroids and second-line agents whenever there was evidence of active sarcoid, and continuing therapy in the long term, driving doses up to suppress all signs of activity. What one gets from the pooled experience, though, is that steroid therapy is a poison that should not be used by the amateur poisoner. So what do I mean by that? There is no doubt that the overuse of steroids at high doses for too long has led to a tsunami of steroid-linked problems. And we now see this in sarcoid patients with diabetes, high blood pressure. They have issues with their weight, osteoporosis. I can go on, but the compelling information now recently emerging is the sharp linkage with these disorders between past overuse of steroid. But by contrast, a neoholistic approach, and one centre was well known for this, of not intervening at all when the disease burden is huge or promises to become so, is also a huge problem. So we have an issue of balance here. And it struck me more than 20 years ago, we are dealing with a complex disease. We are dealing with drugs that create major issues in some people if overused in the long term. How do we find the right balance? Because this is not the 1960s. Sarcoid patients cannot be expected to collaborate with longer-term treatment approaches in this setting unless the logic of treatment, the goals of treatment are crystal clear. And so what came to mind first of all is, what does anyone need from a treatment in a chronic illness? And one plays around with more complex statements, more detailed statements, but in the end, what anyone wants with a chronic illness is to live longer and to feel better, and feeling better may be a benefit without side effects. There may be side effects, but there needs to be a benefit that greatly outweighs the side effects. Therefore, if we're going to construct logical reasons to treat, and we're going to do this in partnership with a shared logic, we must base our reasons to treat on this dichotomy. And from this comes the treatment indications in sarcoidosis. Living longer, so identifying those people who are in danger. Maybe you're talking about a shortening of life expectancy. But I have to say as well, the danger covers permanent disability because of damage to major organs. You may not have a shortened life if you have that problem, but you do certainly have a reduced life. And then, by contrast, unacceptable loss of quality of life. And you have to separate these problems in sarcoid because in many people, they don't link. Now, in many diseases, they do. You will find that those people in danger are those people, by and large, that have unacceptable loss of quality of life. But sarcoid is one of those disorders where this is uncoupled. There are people whose quality of life is good, but they have hidden danger. And you have people who have unacceptable loss of quality of life in the shorter term, but they don't have the sort of danger I'm describing. Now, let me break this down a little, because how we break this down influence critically how doctors and patients speak. So it is very helpful to start by excluding danger, because if danger is present, you've got a rock solid reason to discuss treatment. And knowledge on this really comes from medical expertise. You'll see why I'm saying this when I get to quality of life. But you are looking at tests that establish severity in major organs and tests that establish high future risk from major organ involvement. Now, treatment decisions here obviously remain a partnership, but this is a situation where key information is sought by the doctor, provided to the patient, with a shared logic in why treatment should be used. Now, I make these points because it's radically different when it comes to choice made based on quality of life, because there is only one expert in the room at that point. I cannot do a blood test to find that somebody has 17.73 units of fatigue. So the question you're asking, I often ask people to take 4 weeks to think about it, think about their life from day to day. But is the quality of life so reduced that something needs to be done? And while some patients still want a doctor to decide for them, and they have a right to have this happen, I think many other people prefer to decide themselves on this question, but they need to know that danger's been taken out of the equation, because otherwise you look at loss of quality of life, you think it actually signals danger, and you cannot think clearly about this separate question. And the approach to what you do, I'm not going to talk about different drugs, obviously that's the next talk, but the level of therapy differs radically. Now in dangerous disease, this is what is generally described as typical treatment in sarcoid, and I'm afraid many people with loss of quality of life have been subjected to this approach with a net reduction in quality of life due to the side effects. But you are talking about taking control. You switch off the disease, and then you find often that a civilized dose of therapy in the longer term that could never have taken control maintains control, and you're finding the minimum longer term dose that preserves the gains. Now, by contrast, and I speak for many people, I make 20 different deals with 50 different patients in finding the right approach to treating loss of life. I have somehow lost my screen at this key moment. I don't think I did anything, but I will do a new share and try to recover my equanimity.
We can still see your slides.
That's very good, I couldn't. Now, time forbids detail, but there will be a negotiated start of therapy. Very often you're talking about finding out whether very civilized doses looked at in the short term transform somebody's life. And then you're encouraging the patient to experiment with levels of low dose to find the best balance between benefits and side effects, because that's very individual. You can't do a doctor knows best on that question, but you better be sure there isn't danger when you embark on this pathway. And I think my second to last slide is entitled Traps for Young Players. So not all quality of life problems in sarcoid can be defeated using standard drugs. And I would mention fatigue, which needs a different approach, depression, and I think if you've got a major illness with great anxiety, the normal human reaction is to feel happy. The abnormal human reaction, I have to say, is to be ecstatic about this. Sleep loss, lack of attention to whole life health, and this problem of brain fog. So I'm just listing some of the issues that you can't cure with a drug menu. And finally, many chronic symptoms in people with sarcoid are not actually due to sarcoid, and they shouldn't be attacked with steroids and other drugs. There's a long list, and I've only listed frequent culprits, and part of the job of a sarcoid physician is to work out those things that are a problem that are actually not sarcoidosis. So I'm going to summarize. I'm afraid this has taken a little longer than I had hoped. But in summary, I think we can say half of patients with sarcoid do not need to be treated. Now, that's not half of people coming to this day. You're here because you have more problems with sarcoid, but you should not treat in sarcoid unless you tick one of the two boxes, danger and quality of life. I've said what I want to say about bullet 2, 3, and 4. And finally, your need for long-term treatment should always be challenged. And sometimes that means you end up on a lower dose, but you don't come off treatment immediately. Thank you very much.
Thank you very much, Athol, for that excellent summary. And we have about only 5 minutes for questions. So I'm going to move to a few. I'll try and summarize some themes that I'm seeing from the chat and from the previously submitted questions. One concerns stopping treatment, and how do we decide whether it's okay to stop treatment?
Case by case, you've got to be very clear indeed about danger versus quality of life. I think you should always experiment with time, and that sarcoid activity often does burn out. For quality of life indications, you're simply reducing the dose and finding the minimum dose that is required. It may mean stopping treatment, it may mean reducing, then stopping treatment, but you find that out. For danger, the problem is activity is suppressed, so you can't see it's still there until you reduced therapy, but you should do that periodically. And plainly, you will be less likely to do that sooner if somebody's in a high-risk situation, more likely to do that sooner if somebody has good reserve and you've treated because you anticipate there will be trouble at the time of introducing treatment if you don't treat. So look, this is case by case, but the guiding principle is that if you can come off therapy, you should come off therapy, but you shouldn't rush into it in the first year or two if the sarcoid burden is serious. And one final point, if you reduce too soon, you actually increase the average dose of steroid because you have to go back to higher doses.
Okay, and thank you for that. And a linked question, which several have asked in different ways, is once you have a return of symptoms, let's say systemic symptoms, a-specific symptoms, how can you know and how can we test to tell us whether it is sarcoid activity coming back or it's something completely unrelated?
I'd say there are three aspects to this, and each will be a sentence. First of all, patients know how it feels to have active sarcoid, and they can often tell you that their sarcoid is active, and you should trust that. If in doubt, I believe. Secondly, you are looking for clusters of symptoms that together are decisive, whereas one individual symptom might not be. Lastly, if you are in doubt, you can do selected tests that demonstrate that sarcoid is active.
Thank you. Thank you, Arthur. We're getting loads of questions also on the chat. A few questions relate to the new biologics and the fact that steroids so often cause side effects. So rather than go for steroid side effects, can we not just treat with the newer? And of course, Anjali will also be speaking to this, but what is your view?
Very simple, actually. To talk about steroids as if all doses are the same drug is a sad mistake. So we're all on prednisolone 7.5 milligrams daily. If you have extra steroids, you reduce what you make. We all have spurts of higher dose that we make naturally. So a low dose of steroid does verge on natural therapy, whereas high doses of steroids are highly unnatural because they subvert body mechanisms that are tuned to low doses of steroid. So we're not talking about steroids on block versus other therapies. And I think you have to have a hit list of the nastiness of therapies. So I think the nastiest is high-dose steroid in the long term. The nicest therapy on average is a very low dose of steroid plus or minus hydroxychloroquine. And the other drugs are somewhere in between. So if your dose of steroid is going to be unacceptably high or you have a particular problem, you move early to other things. If in fact you're tolerating low dose therapy and it's doing the job, why would you go to therapies that are more toxic? And then sometimes people have particular wishes not to use steroid, and you shouldn't go on arguing at that point, but you should consider going straight to a second line agent. But I would go to methotrexate before biologics, because I think the trouble associated with biologics, they feel like they're a miracle of the space age, but actually the grief associated with them tends to be higher than low to medium dose methotrexate.
Thank you, Alpha. Unfortunately, we're only going to have time for a final question because we only have 1 minute. There are several questions on vitamin D. Why is it not recommended? What do you do if you have osteoporosis and have low vitamin D, but also have sarcoid? Very quickly, in like 30 seconds.
Well, you've occupied the question time in asking the question. Look, I'm going to say there are 4 problems with vitamin D, and I don't have time to say what they are. I'm going to say that just occasionally low vitamin D can drive sarcoid, and that's terribly rare. And I'm going to say that once in a while you must use vitamin D for bad osteoporosis. But all I will say, because there isn't time, is that there are 4 separate issues with vitamin D. 4 separate problems that it can drive in sarcoid. Therefore, it's another poison not to be used by the amateur poisoner.
Thank you very much, Alpha. I'll have to leave it there. And it's now my pleasure instead to introduce Dr. Anjali Crawshaw, who is working as a consultant in University Hospital Birmingham, completely focused on IOD and sarcoidosis. She leads a regional multidisciplinary sarcoidosis service and has a lot of experience. So we will hear from her about the new and old therapies for sarcoidosis, what medication to choose when treating. And the floor is yours, Anjali.
Okay, thank you very much to Vasilis and Sarcoidosis UK for asking me to speak, and also for giving me the slot after Professor Wells, who's always a hard act to follow. So I'm going to take you through the medications, the treatments that we can offer for sarcoidosis, assuming that you and your physician have come to an agreement that treatment is at this stage required. There's a lot of, there are many different options, and when you first come to clinic, it can be very overwhelming to hear about these. And so learning about them early gives you the opportunity to think about things and help in the decision-making process. I'm going to talk about steroids and then the more classical immunosuppressants, a little bit about other options such as biologics, antifibrotics, and other things we can do and offer for treatment. Before talking about the medications, I think one of the questions we're often asked quite rightly is, what's the evidence for one drug over another drug? Why should I be choosing this? Why are you choosing this? Why are you recommending these things to me? When we are learning about new drugs, the ideal way to learn about a drug and whether it's going to be helpful in treatment is doing a clinical trial. How do we do a clinical trial? We take a group of standardized patients with the same set of symptoms, the same level of disease activity, the same makeup, same gender, and split them into 2 groups, give one half the treatment and one half no treatment or a placebo. But actually, in sarcoidosis, we all know that's not the case. The disease is so different, presents differently in different people, level of organ damage, level of disease activity, the symptom burden. And this makes it really difficult to design a study for sarcoidosis patients and for medications in sarcoidosis. And much of our evidence comes from either small series of patients or people that when you pick at the details of the study, actually the people entered into those studies or trials were actually having very different disease. So deciding whether a drug is good for sarcoidosis or not becomes more difficult. Much of our recommendations on sarcoidosis is using these studies in context and with expert consensus. So we've all heard about steroids, and in the UK, prednisolone is the steroid that we use most frequently. What does it do? Well, it reduces inflammation and it suppresses some of the chemicals that are produced by the inflammatory cells that Simon talked to us about earlier. The study suggests that there is some short-term improvement in both symptoms and the biomarkers, but we know that biomarkers or the chemicals, the blood tests that we do don't necessarily correlate with either how patients are feeling or the level of damage occurring. Despite the years it's been used, there's still actually a remarkable lack of current evidence to demonstrate long-term benefit for use of steroids, any clear alteration in the natural history of sarcoidosis, and also importantly, a lack of evidence to suggest improved mortality. So when do we start steroids? Well, we start steroids as Prof. Wells has suggested if there is dangerous or potentially dangerous disease, and that includes cardiac sarcoidosis, neurosarcoidosis, or sarcoidosis affecting the eyes. And I understand there are talks about this later, so I won't go into that much further. But also when we feel that the risk of damage or the burden of symptoms outweigh the risk of the treatments that we're offering. So steroids, and I will touch on this in a moment, come with a set of risks, a set of side effects, and it's important to weigh up the relative risks. For lung sarcoidosis, we use breathing tests as a guide, and there are specific parameters that we can help guide us, but then it's different for every patient. And it's important to remember that the breathing markers in different people vary greatly. So actually, often it's a drop from baseline that we're looking at. What dose of prednisolone do we use? Well, traditionally, people were started on very high doses of steroids, but actually we find that's probably not required, and a dose of around 20 to 40 milligrams is probably enough. We'd use lower doses in patients whose sarcoidosis has been grumbling along. It's not presented with that bang presentation that Simon presented earlier, but more gradual, progressive, and we finally say, well, the balance is tipped in terms of starting treatment. And we also give very much higher doses, sometimes intravenously, if we feel there's life-threatening or organ-threatening disease. So the side effects of steroids, now there's a long list of them, and for many people they can be very problematic. Now that's not to say that everybody who started on treatment has side effects, and not everybody has all of the side effects. One of the most frequently concerning to people is the increase in appetite and subsequent weight gain and associated indigestion. But other important things include difficulty in sleeping, changes in mood and behaviour, which really can be, for some people, quite disabling. They can feel irritable or anxious. There's also increased risk of infections, the effect on potential blood sugar or diabetes, blood pressure, and if you're talking about more long-term steroids, risk to of bone thinning to your eyes, and a condition called Cushing syndrome. I think some of the questions proposed earlier were saying, well, I've been on steroids, I started them, when do I continue them? How long do I continue them? And when can I get off them? That's the question. As soon as we start talking about treatment, we want to know, well, how long is this for? Well, we continue it based on treatment response. If they're working, great. If they're not, we might need to think about moving to other things. We would want to constantly reevaluate the need for treatment. There's no one thing that tells us, yes, your sarcoidosis is active. There's no one blood test. There's no one parameter that we look at. And it's important to understand that actually in a study of patients looking at how long their disease lasts, we know that around 40% of patients will go into remission without treatment at all. So when you're feeling well on treatment, what we need to understand, but is difficult to know, is, am I feeling better because I'm on treatment, or is it I'm feeling better because my disease is in remission? There's no clear way of knowing that. And actually, this is why constant consideration for withdrawal of the medication is really important. We're aiming for the lowest possible maintenance dose of steroids, ideally 5 to 10 milligrams. And then balancing the risk of treatment, so the side effects that we get with steroids, versus the risk of triggering or allowing irreversible disease progression. Ideally, we should consider attempting withdrawal at 6 to 12 months, but continue the treatment for if there's relapse with either dose reduction or withdrawal, understanding that actually for many, prolonged treatment is often required. I saw a question in the chat, I think, about inhaled corticosteroids, and we know from the sarcoidosis registry that around 8 to 10% of patients are on inhaled steroids, but actually the evidence for this is not great. The idea that you're getting steroids to where it's needed is an attractive one, but so far we don't have the evidence to support that. So beyond steroids, well, what do we do next? So this is when, as Professor Wells said, actually, perhaps we should consider being seen in a specialist centre or by someone in your local centre who has a clear understanding of the secondary medications that we can use. The first thing we need to check is that you and your clinician have the same understanding of the dosage that's being taken. Often people quite rightly feel that they're on a dose that they are not happy with, or other things have happened in the interim and the dose may not be the same as as the dose your doctor understands you to be on. And that can affect what we decide to do next. So making sure that everybody knows what dose you're on and the problems that you've been having is really important. When would we add treatment or refer you to specialist care, a specialist centre? Well, if there's progression of disease or there's an unacceptable symptom burden, if the side effects from steroids are intolerable, or we're unable to reduce the steroids below 10 to 15 milligrams a day, because that's the dose at which we find the side effects become more problematic, particularly long term. Or if there are other considerations, comorbidities that really make steroid use a problem, such as diabetes, obesity, osteoporosis or high blood pressure, or if there is patient strong preference to against using steroids. So what are these other drugs that we use? Well, there are also drugs that suppress the immune system, the overactive cells in sarcoidosis. Well, what's our evidence for using these? Unfortunately, it's a similar story to that seen in steroids. Small-scale studies in patients that are not necessarily so similar to be able to draw strong conclusions. We talk about methotrexate, azathioprine, mycophenolate and leflunomide, and I'll go through those briefly so that we have heard of these medications to give you that power to be able to understand and participate in discussions when you're talking to your clinician. Second-line immune suppression also has risks of toxicity different to steroids, risk of increased infection, marrow suppression issues, and for people of childbearing age, conception planning issues. Many are not suitable for people with chronic viral infection or reduced or liver or kidney function, and they require regular blood monitoring, which for many can be a significant side effect. So methotrexate, this is one of the most commonly used second-line agents worldwide. It inhibits the blood cell synthesis, and there's no evidence to suggest that methotrexate is better than azathioprine. Its efficacy, or how good it is reported to be around 50%, with a response rate, so the number of people who respond being around 40 to 60%, and that's based on looking at breathing tests. It can be taken as a tablet, and also usefully for many can be used as taken subcutaneously, so as an injection. You need to have folic acid supplementation with this to prevent toxicity. And the dose is usually something around 5 to 10 milligrams to start off with, increasing up to 15 to 20 milligrams as required and tolerated. Side effects include nausea, lung inflammation, but importantly not lung fibrosis, some problems with blood count, nausea, sometimes hair loss, and skin rashes. Azathioprine is the other drug very commonly used. There's less evidence supporting it, but it's about as effective as methotrexate. It again inhibits blood cell production, and there are no randomized controlled trials looking at this. Open label studies, so series of patients, suggest that there's a modest improvement using azathioprine. A dose of around 50 milligrams once a day, increasing up every 2 to 3 weeks till a dose of between 100 and 150 milligrams is usually used. And again, similar side effects in terms of nausea, dyspepsia are often seen. It can have problems with low blood counts, and it can be difficult to differentiate the low blood count issue seen as a result of azathioprine with that low blood count seen in sarcoidosis itself. We would do a blood test before giving you azathioprine to determine the risk of toxicity. There's possibly a signal that there's more opportunistic infections with azathioprine. The rest of the medications are used less frequently, and I'm going to go through them slightly more quickly. We use a drug, we often use mycophenolate. The evidence for that is, again, even less than azathioprine and methotrexate. It's widely used in other inflammatory conditions, and our understanding has been extrapolated from those conditions. And we use a dose of 1 to 1.5 grams a day. Similar side effects: diarrhea, leukopenia, low blood count. Leflunomide, again, our understanding about this is extrapolated from rheumatoid disease, can be better tolerated, but our experience in sarcoidosis is limited. Cyclophosphamide is a very old-fashioned agent used for inflammatory disease, but it's rarely used in sarcoidosis, so it's just to know it exists. Hydroxychloroquine we do use quite frequently. It inhibits blood cell activity, the way the inflammatory cells work in sarcoidosis, and can be helpful in skin disease, joint disease, and high calcium levels. Also,
Anjali, sorry, just to interrupt you, but we only would have 4 minutes for questions now as we start. So just to give a few questions.
Okay, fine. Sorry, I've only got a couple more slides, actually. It was just one of the questions was, a few of the questions have been about biologics. Why aren't we using them? Is money an issue? And actually, biologics are antibodies that target the inflammatory pathway. They're widely used in other inflammatory conditions, but not routinely available in the UK for sarcoidosis. And that's because the evidence isn't great. The small studies that have shown looking at the biologic agents don't really show a large amount of benefit. And so being able to give those they're not yet funded. Antifibrotic agents, a study last year suggested they could be used in sarcoidosis. It's important to treat coexisting conditions, and I think those are going to be discussed later by my colleagues. I won't talk about future research because I know that's coming up. So really, what I wanted to get to was your consultation messages. And the most important thing is decision to treat is based on multiple factors. And that's how you're feeling, what the side effects of the treatments are, and really the balance between the two. The trial evidence for various treatments is sparse and based on expert consensus. And while steroids are usually the first choice, there are other options. And so thank you for listening, and sorry to have to hurry the end of that.
Yes, thank you very much, Anjali, for a very thorough, comprehensive review of treatment. I'm sorry to rush you. It was just to give you the opportunity to answer a few questions. We've got 2 minutes. So a few of the questions concern COVID. One is, how does the COVID pandemic change our choice of treatment? And I imagine the question is, how worried should we be about using immunosuppression during a COVID pandemic? And another series of questions also in the chat concerns the similarities between long COVID and sarcoid. Could it be that some of the patients that have long COVID actually have sarcoidosis?
So in terms of choices of medication in the context of a COVID pandemic, actually, we really need to be looking at the same factors, which is how dangerous is the disease. And really, we should only really be considering treatment if the disease is dangerous or there's an unacceptable burden of symptoms. And so in that context, really the balance would favor treatment, even allowing for the COVID pandemic. I don't know what you would say, Elizabeth, but I think really we have to be certain that the disease is going to cause more danger than not treating. And then the other question was regarding long COVID. I think there's another talk about COVID and sarcoidosis later, but yes, I agree that the symptoms are very can be similar, and I think the jury's out on that front, really.
Thank you. Yes, I would agree with what you've said about the immunosuppression during the COVID pandemic. If needed, one would go ahead and continue with that treatment. some of the comments were, it was a shame that we rushed you in the last bit of your talk. So in terms of the biologics, for example, infliximab, would there be particular subsets of sarcoidosis where you would consider them? When would you consider the use of biologics? As I rushed you through that, and it seems to have been an interest.
Yeah, so there are groups of patients that we give infliximab to. So, for example, we've got very good experience for patients with cardiac sarcoidosis and neurosarcoidosis who've not responded to conventional therapy, so steroids, and then a second-line agent. We found that they've had very inflammatory disease, and treatment with infliximab has caused that disease to melt away very quickly. So I think those groups of people, and also significant skin sarcoidosis again can respond. Lung disease, there's much less evidence for that.
Thank you, Anjali. There's lots of questions on the chat. I don't know if you want to have a look at that to do.
No, they're
coming very fast.
Very quickly.
But everyone's has really appreciated your talk, so thank you very much. And we move to the last talk, which will be given by Charlotte. Here she is. So Charlotte Hogbin, our lead clinical nurse specialist here at the Brompton, together with Benedetta Vitri and Melissa, do a fantastic job in keeping us in check and communicating with all of our patients. And she's going to be talking about the role of the clinical nurse specialist in care delivery. And I would say that in one word, indispensable, but I will leave Charlotte to detail it further.
Thanks, Elizabeth. Let me just get my screen going. Okay, is that showing the slide in a way that it should be, I hope?
Yes, yes it is.
So, the role that we play in care delivery, it will be different across the country in terms of who is available in your local centre and exactly what the nurse specialists do. And I can only talk really from our perspective, but I think there are some ways to try and find additional support if you haven't got someone that you know of in this role. But the key things that we're involved in doing is, first of all, being a point of contact for both patients and GPs, being a link person who can liaise with all of the multiple specialities and the consultants. We're heavily involved in drug initiation and monitoring, giving advice on side effects, symptom management, and also onward referral to other services. Our team, hopefully for those of you who are under the Brompton, you would know how to contact us if you've needed us in the past, and we have phone numbers and email addresses on our letterheads. And hopefully, I know across the patient group, we have a great degree of variety in terms of how much support people need. Some people don't need to contact us on a frequent basis at all and simply talk to the consultant regularly in clinic. And don't need anything additional from the nursing team, whereas there are other people who have to contact us frequently due to medication difficulties, problems with bloods, problems with symptoms. So there's a great deal of variety in terms of how much support you might need from a nursing team. But I would suggest that if you don't know who your local nursing team is, having a look on your letterhead, see if there's any contact details, a phone number, an email. If there's nothing specifically for a nursing team, then maybe for a secretarial team. And you can always find out from them if there is a nurse you can contact. And most importantly, if you're having a consultation in clinic and you haven't previously been aware of anybody who you can contact in between those consultations, ask the doctor who your point of contact should be, and they hopefully will be able to let you know. The other way to try and find out for your local area is via any support groups and patient groups. There may be other people who are under the care of those services who are able to help point you in the right direction. But as I say, we have all our details on our letterheads, phone numbers and email addresses to contact. And we are here Monday to Friday every week, and any call or email that comes into us, we will get back to as soon as possible, usually the same day if it's a simple answer, or if someone's needing a really urgent answer. But if someone is asking a question where we need to do a bit more research and get a bit more information, it might take a bit longer before we get back to them. One of the key benefits for patients, really, in terms of having a contact with a nursing team, is that we can link in with all the different specialities. As sarcoidosis is a multi-system condition, you might be under different teams for management of different elements, and we can help coordinate some of that and contact different teams. Or if you develop new symptoms, we can liaise, for instance, with a dermatologist in order to see if they feel that a rash you have, for instance, could be related to sarcoid. So contacting us for issues like that, we have those links and we have that ability to liaise with those different teams. As I mentioned, one of the key things that we do and that we spend a lot of our time doing is helping manage the medications that were just previously being spoken about. In particular, the most common treatments are the immunosuppressant treatments because, as we were told, they need regular blood monitoring. They have lots of side effects potentially associated with them. And often GP practices are either unable to prescribe them or are unfamiliar with the medications and need support from us in helping manage that. Because many GP practices are unable to prescribe medications, you can't get them via the usual pharmacy. It might be that we're involved in setting up home delivery of medications. We would also be speaking to you about potential side effects, about the blood monitoring that's required and the kind of things to look out for in terms of difficulties that you might have. And we will also liaise closely with the GP about the blood test. Now, for our patient group coming to the Brompton, you may well be spread quite far from the centre. So whereas we would find it very easy to arrange blood tests for you here, it's not going to be easy for you to be travelling here for the blood test. So we tend to ask the GP or local teams for help in arranging blood monitoring, and we give the GPs our secure email address that they can send through any blood results that they have, any concerns about any results, and we're very happy to advise on those in conjunction with the consultants. And that's one of the key things that we're involved with. Also, very specific to here, because it could be very different in your local area, one of the other things that we're involved with and that we would potentially contact patients about is arranging IV therapies. So where people are having, in those sort of limited circumstances, biologic therapies, or where we're arranging IV steroids as more urgent treatment. The phone calls and email address, the phone number and email address are there really to be able to offer advice on managing symptoms, whether that's side effects from medications, helping identify whether symptoms you have are related to sarcoid or whether they need further investigation by the GP or local services, and liaising with your consultant in order to advise on any adjustments of doses that might be required of your medication depending on your symptoms, and discussing any concerns that you have in between your consultations, because it's obviously not possible to directly get in touch with your consultant on a day-to-day basis between your clinic appointments. But that's what our number's there for, is to contact us with any concerns you've got, and then we can take those to the consultant and arrange any earlier follow-up, earlier tests, or any changes of medication that are required, or offer advice back to the GP or local services to carry things forward. We would also be involved in making referrals to other services. So we would potentially point someone in the direction of patient groups and support groups. So particularly if someone's just been newly diagnosed, they may not be aware of SarcoidosisUK, so we would point them in the right direction, and also encourage people to get involved. We also, if someone has lung involvement, we might be suggesting that they do pulmonary rehabilitation courses, and we can make those referrals directly. If someone's got severe disease and fibrosis, we might need to arrange oxygen assessment. If someone's having difficulty with weight loss or significant weight gain, we may help get dietitians involved in order to help advise on that. And we can also make referrals to psychology services for additional support. Here at the Brompton, we're sort of divided into two groups. We, in the ILD team, and my team are primarily the lung involvement advice, and can help with other elements as well. But Sue Gilmore is the heart failure nurse who has the particular focus on cardiac sarcoid and those who do develop heart failure. She sent me some information. Now, this isn't my area at all, but she unfortunately was unable to attend today. But she sent me a few slides just to run through. So, as she points out, some but not all patients with cardiac sarcoid have an element of heart failure, and her role is to act as a point of contact in a similar way to us to give advice on their condition, providing education and support, adjusting medications in order to manage the condition. As she says, the immunosuppression treatment and monitoring is done by our team, the respiratory team. These are some of the medications that she might be involved in monitoring and adjusting treatment doses: ACE inhibitors, beta blockers, diuresis. But if you are in this position and have cardiac sarcoid and you're using these types of medications, you probably already are in contact with her or someone similar in a similar role as a heart failure nurse. The type of education people need obviously varies according to patient, but she would educate on being aware of symptoms to look out for, monitoring weights, and when to seek additional help. She'd be making changes to medications based on blood tests, based on other parameters, and in particularly monitoring kidney function. And some of that monitoring does overlap with our team, and we might be offering joint advice on how to manage the condition. I have saved a couple of bits and pieces for some of the questions, because I know they've been very specific. So I'll hand to Dr. Enzoni to go through the questions that had come in.
Thank you very much, Charlotte. Thank you. And if we don't manage to answer all the questions, they are all listed in the chat, so you can. But many people are also expressing thanks for your help with them throughout the year. To go through some of the questions, one is an very important one. Why, I mean, they're all important, but this one, why aren't there more nurses trained in sarcoidosis and how to help patients with the condition that they can talk to?
I think one of the key difficulties or the complication that comes with sarcoidosis, obviously, is because it's a multi-system condition, and the way nurses tend to go through their training is they start to specialize in a particular area, such as respiratory, such as cardiac. And so the nurses that are there to help on within the sarcoid teams are generally embedded within another area. So for instance, Sue, who would help with cardiac sarcoid issues, is embedded within the general heart failure team. And we, as the respiratory nurses, we're within the wider ILD team, but are very much focused on sarcoidosis as well. So the nurses might not be labelled a sarcoidosis nurse as such, but there are lots of different people involved who can offer the advice and guidance. Of course, that's going to be different across the country, and certain areas will have better levels of support than others. And I think it's something that can always be campaigned for through your patient groups to get better funding for more nurse support is certainly something we would advocate. We always feel that there should be more nursing support available.
Definitely, I can only echo that, because of course it will be important to have more and more specialist nurse support across the different areas in the UK, whereas probably there is still a lot of heterogeneity in the type of support and level of support you can get. Another very good question is, what is the role of patient organizations in the delivery of care, just for some increase of health literacy, or is it part of the therapy?
I think it's part of therapy, because peer support is so important. You know, as much as we can advise on drug therapies and potential side effects to look out for, we don't know ourselves how it feels to have your sarcoidosis symptoms. We don't know how the fatigue feels. We can't even begin to imagine that. So being able to talk to people who are in a similar situation as yourself, and being able to join support groups and have those discussions with people who experience the same things is really important. And every individual will have little tips about how to manage their symptoms, and how to help themselves outside of the medication side of things. And you can only really get that from your peers. That's not something that you can get as thoroughly from us, because as I say, we don't have those symptoms.
Thank you, Charlotte. And another question, which you have already touched on, but just if you wanted to underline, what questions and queries can or should a patient bring to specialist nurses rather than waiting to check with a GP? When should we come to you? When should we approach the GP?
So I mean, the difficulty that people will always have when you have a diagnosis like sarcoidosis is often you'll go to the GP and they will perhaps suggest you speak to your sarcoidosis service because there's an assumption that it's related. And if that's the case and you've spoken to the GP and they have asked you to contact us, that's fine. If we don't feel it's sarcoidosis related, we'll contact the GP, get back to them and ask them to further investigate. But the key thing for me really is that, yes, you know, side effects from medications, we're probably more experienced in managing those. If you're having a flare of your symptoms that are very similar to what you've had previously, and you recognize them as your sarcoid symptoms, or if you just need general advice in managing your care, we're really happy for you to get in touch with us. The only time I don't want someone to get in touch with me is if it's an urgent emergency issue. We're not an emergency service. We're here Monday to Friday. We can't necessarily answer a call immediately. And if you have got sudden changes in your symptoms, like you're suddenly much more breathless, suddenly having chest pains, then that's not something to call us about. You need to contact emergency services, whether that's NHS 111, contacting 999, or calling your GP for an urgent call out. They can then liaise with us for advice. We're not expecting them to manage your care, particularly if it is related to your sarcoid. But it's always a worry when we have a message that's been left on a Friday evening with someone who's saying they're much more breathless, and we haven't picked it up until 10 o'clock on a Monday morning. So certainly those kind of things should go by the GP. If you've got a simple issue, like you've got a chest infection you've had before, the GP can manage that. Or if you feel it's unrelated to your sarcoid, of course, approach your GP first if you can. Sorry, you're on mute.
Yes, I saw that. Thank you very much, Charlotte. Very comprehensive answers, and as I said, there are lots of messages on the chat. I think we don't have time for more, but for all the panelists. As I said, there are several questions. A few will probably be dealt with in the next sessions. There are several questions about what should pulmonary physicians be screening for at presentation for other types of organ involvement. And I'm sure we'll hear more about that in the next session, where specific forms of sarcoid will be discussed, including cardiac sarcoidosis. So we now have a 10-minute break, and then we are back for that session, which will be chaired by Peter George and started by Vasilis. Thank you very much.
It gives me great pleasure to introduce the chair for the next session. This is Peter George, our clinical lead in the interstitial lung disease and sarcoidosis unit at the Brompton. He has transformed our unit, which is now, as traditionally been consultant-led, but it is more than ever patient-centered. Peter, over to you.
Thank you, Vasilis. Thanks for your kind words, and thank you to yourself and Sarcoidosis UK for what is turning out to be an absolutely amazing day. Huge number of patients, fantastic speakers. We're really fortunate to have this opportunity, and I'm really excited to be chairing this session, which is around specific challenging forms of sarcoidosis. And when we think of those challenging forms of sarcoidosis, really one of the areas is cardiac sarcoid, and we're extremely fortunate through Vasilis and Dr. Rakesh Sharma to have one of the leading cardiac sarcoid services in the world in terms of expertise and numbers. So I'd like to introduce them both to you and then let them get on. So as you know, Dr. Vasilis Koronos is a respiratory consultant in the interstitial lung disease and sarcoid service. He really is the lead for our sarcoid service and has been the mastermind of this wonderful day. And Dr. Rakesh Sharma, who's a highly experienced consultant cardiologist who leads the cardiac sarcoid service at the Royal Brompton Hospital. And between Rakesh and Vasilis, they really have built up, along with Athol Wells, a formidable partnership looking after some of the most complex cases. So I'd like to hand over to you both for a presentation titled Cardiac Sarcoidosis Presentation. Is this different to other forms of the disease?
So thank you very much, Peter and Vasilis, for the kind introduction. Just to echo what's been said, I'm most grateful to Sarcoidosis UK for putting this fantastic program together. And it's a true privilege to speak to patients in this forum. So I'm going to share the screen so that we can go through the slides. So hopefully you can see my slides. So the course of the next 30 minutes, Vasilis Koronos and I will be talking to you about cardiac involvement with sarcoidosis. We'll try and keep the number of slides to a minimum just to allow time for questions and discussion. But essentially what we're going to talk about is why it's important to make an accurate diagnosis early and how we can achieve that, and also how we can engage with our patients to try and learn from them and to try and provide a good service in terms of cardiac sarcoidosis. So you would have heard from our colleagues already that sarcoidosis is a multi-system disease. And in fact, the most common organ which is affected is the lung. And this is why many of the speakers today come from the respiratory department. Having said that, when there's cardiac involvement, this is when patients can present with potentially life-threatening issues. And as a result, it's very important as doctors that we try and educate our colleagues on how to try and make the diagnosis early on to try and protect patients, and actually to try and prevent serious problems down the line. Now, this is a rather medical slide, but I'll talk through the key principles. As you've heard from other speakers today, we know that sarcoidosis is an inflammatory condition. So what that means is that the body's immune system is actually working against itself. And as a result of this inflammation, tissues can become swollen, and there's a process known as edema, which can form in different parts of the body. So certainly if there's edema and inflammation in the heart, then this can lead to serious sequelae. And one of the main ways in which patients can present with the first episode of symptomatic cardiac involvement is through heart block. So this is when patient's conduction system becomes involved and the patient can sometimes even collapse or have other problems. One of the key factors about diagnosing cardiac involvement is that we want to try and halt this inflammatory process early to try and prevent the edema and ultimately to try and prevent fibrosis, which is a scarring process in the heart, which if left unchecked can lead to heart failure. So how, as a patient, may you know if there is cardiac involvement? Well, many of our patients who refer to the service actually may not have any symptoms at all. And we often get referrals from our respiratory colleagues to the cardiac sarcoidosis unit, where a patient with respiratory sarcoidosis has had, for example, an abnormal heart tracing, such as an ECG, or an abnormal heart scan, such as an echocardiogram. So once we receive these referrals, we would often initiate more advanced imaging tests. Cardiac MRI is a fundamental tool for diagnosing the condition, and in fact, there are many different indications for a cardiac MRI scan, and certainly these scans are now being performed all around the world and all around the country, and there are certain hallmark features on the MRI scan which may suggest that the patient may have sarcoidosis, even if there's no extracardiac known involvement. So MRI clinicians are actually referring patients to our service, even when patients themselves may not have symptoms. But clearly, patients can also develop symptoms if there's cardiac involvement, and the symptoms can vary between palpitations, dizzy spells or fainting if the patient's had conduction block, but also in more advanced cases, if the patient's developed heart failure, then they can become breathless and sometimes develop signs of fluid accumulation. So how can we make the diagnosis? Well, with cardiac sarcoidosis, because there's no single test which can clinch the diagnosis, very often it feels like putting together different pieces of a jigsaw. And this is where we look at the patient's symptoms, their presentation. We would ideally like to get some tissue evidence of sarcoidosis, and most often this tissue may come from the lungs. We rarely biopsy the heart because very often we can miss the diagnosis because of the patchy nature of the condition. We also heavily rely on advanced imaging, so echocardiograms can give an idea that there may be some cardiac involvement, but it's really cardiac MRI and FDG PET which can give us a clue as to whether there's inflammatory processes going on and whether that inflammation is actually due to cardiac sarcoidosis. And clearly there are other tests which we will do to try and help support the treatment, but certainly it's about getting tissue diagnosis from outside the heart together with putting that information with advanced imaging modalities, like putting a jigsaw together to come up with the diagnosis. And we're heavily reliant on an MDT approach. MDT stands for multidisciplinary team meeting, because not one person can have all the skills necessary to try and manage patients with cardiac sarcoidosis. We really need a team-based approach. And since the MDT was first put together several years ago at the Brompton Hospital, we've completely revolutionized the way we diagnose and treat patients, and hopefully this has led to much better outcomes. So why should we approach patients in this way? Well, sarcoidosis is a relatively rare condition, particularly when it affects the heart. And so when it comes to a rare condition, in order to try and provide good treatment, we need to manage patients in centers where there's a high volume of patients being seen. Most cardiologists will see only 1 or 2 patients with cardiac sarcoidosis in a year. At the Brompton, we would see hundreds of patients with this condition. So that means that we do develop expertise and also can provide a more consensus approach to managing this condition. Another hallmark of sarcoidosis, particularly affecting the heart, is that it can mimic other conditions. And very often there will be a debate in our MDT meeting as to whether this is a high likelihood or moderate likelihood or even a low likelihood of a patient having cardiac involvement. And this is just one example. It's a condition where there's change in the heart muscle and conduction, a condition called arrhythmogenic cardiomyopathy, which can sometimes mimic sarcoidosis. And again, it's about having the right people in the MDT to try and tease out what the most likely diagnosis will be. As I've already said, there's no single test which can confirm the diagnosis, which is why putting together all the pieces of the jigsaw is important. And patients may present with a variety of non-specific symptoms. And certainly we've also learned in our practice that even if patients have had a diagnosis of cardiac sarcoidosis and they're treated and the condition goes into remission, without careful follow-up and surveillance, some patients can relapse even without having symptoms. So this is where imaging is key. I also think it's very important to have an open mind when it comes to making a diagnosis. As I've shown in one of the earlier slides, there is a natural history of the condition. And certainly if a patient presents early on, where there's no change on the imaging, but the patient then subsequently develops fibrosis, the condition may become more evident later. So in cases where there are truly borderline criteria, we need to keep an open mind. This is a very busy slide, which I'm not going to go through, but just to say that we try and have a systematic approach for diagnosing patients, because without having a system in place, it's difficult to try and provide uniform treatment. And certainly this is a protocol which has been replicated in other centres where we try and provide an evidence base to what we're doing in terms of tests and then diagnosis. Just a few words about treatment, because I think this is a whole different talk, but just to say that if patients do develop heart failure, which is where the fibrosis has led to impairment of cardiac contractility, then there are different drugs which are available to us to try and help improve the cardiac function, symptoms, and also ultimately prognosis. And as mentioned earlier, conduction system problems can sometimes manifest either with heart block or ventricular rhythm disturbances, and this is where device therapy is very, very important. We have different types of devices according to the patient's need, and very often these devices we will implant through a kind of minimal invasive approach. We're very lucky in our MDT to have arrhythmia doctors, eye implant pacemakers, but we also have electrophysiologists who will advise on ablation. So it really is a joined up effort to try and help provide the best treatment for our patients. So I think I'll stop there to allow Vasilis to talk about treatment in a bit more detail, and then I'll be available for questions.
Thank you, Rakesh. Let me share my screen. So, cardiac sarcoidosis is one of my main interests, and what I understood from the very first moment that I came to the Brompton was that an eternal battle happening in A&E, but even behind the scenes between cardiologists and respiratory physicians, it gave place to a very strong collaboration between us. And I'm really proud about the development of the multidisciplinary team that I think is changing the field in the diagnosis and management of cardiac sarcoidosis. I will touch on the main challenges as far as I can think regarding cardiac sarcoidosis, and that includes the current poor screening strategies that are used across the world, different mode of presentation of the disease that is also posing diagnostic challenges. And many patients are trying to understand the predictors of outcome that would depend on the studied population. Unfortunately, we have lack of controlled data for effective treatment, and the main guide remains our experience. So I will just touch on the screening strategies, and at the moment what is recommended is that the patients are asked about cardiac symptoms in every single visit, and if possible perform an ECG in every single visit. That's not always the case, but at least symptoms can be obtained. And as you can see in this table, the cardiac symptoms offer a sensitivity of 65% and a specificity of 57%. They're not great, but they're actually catching up to 50% of the patients. The current guidelines recommend performing, obtaining symptoms and doing an ECG, which only increases the sensitivity from 65 to 69%. Whereas if everyone was performing an MRI, the overall sensitivity will be up to 97%. The reason for not performing this is A, for financial reasons, and B, because even if cardiac MRI detects limited changes, it doesn't mean that the patient's outcome will change. So there is a lot of research going on at the moment to actually answer that question. It was mentioned to the previous session about the recommendation of how patients should be evaluated at baseline, and the top right table is actually showing what is currently recommended. And I use that to show that it's not different since 1999, and the patients are recommended to have cardiac history recorded and ECG. And if patients had cardiac symptoms or ECG abnormalities, they then move on to have a cardiac MRI or even a PET. Echocardiography is a tool that is more and more used at the moment, but again, this is not performed in all centers. What we need to be very careful about is the type of the symptoms and how long they last for, because any one of us has felt anxiety, any one of us has felt fear, and this causes palpitations. Interestingly, nowadays we have seen patients who developed cardiac manifestations, and one of the main things has been the atrioventricular block. And later on, they are found to have cardiac sarcoidosis, although in the beginning they were not suspected. This is one of the main reasons why our service has actually increased in capacity, because now cardiologists are aware that this entity exists. But that means that every patient who has an atrioventricular block below 60 years old, or even has VT or heart failure, should be checked not to have cardiac sarcoidosis. And this is a lot of work in progress and a lot of awareness to be raised. This is a busy table, but it actually shows how cardiac sarcoidosis is diagnosed, mentioned by Dr. Sharma. But the important bit to say here is that patients need to have extra cardiac biopsy. That is, as we heard earlier, is not always easy. It's not always obtained. They either present with heart failure, major arrhythmia, or signal on imaging like MRI and PET. But the key point is that in the guidelines, it is recommended that other diagnoses are excluded. And this is where the value of the multidisciplinary meeting lies. And this is what makes the difference in actual fact. Regarding the prognosis, patients with cardiac sarcoidosis, yes, they have a worse outcome compared to non-cardiac sarcoidosis patients. This has been shown, and it related to the fact that these patients have cardiac damage as is represented on MRI, so they have a higher risk of sudden cardiac death, major arrhythmia, or even heart failure hospitalization. We don't know exactly what is the extent of the fibrosis that is associated with the worst prognosis. But what we do know now is that if you are diagnosed with cardiac sarcoidosis, and if you have left ventricular impairment, active inflammation, or at least high extent of fibrosis, this is associated with worse outcome. With regards to therapy, you have heard a lot, but sarcoidosis-specific therapy is what is used from the sarcoidosis specialist point of view, and we rely on cardiologists' expertise for the antiarrhythmic and device implantation, as well as heart failure management. Again, these treatments integrate, and a multidisciplinary approach appears to become a gold standard approach, because one could ask which treatment should start first. One could ask, should I take cardiac medications instead of immunosuppression? And the answer is that a combination is the only way forward. What we are doing from a sarcoidosis perspective is that we want to evaluate whether there is cardiac sarcoidosis activity. We are very vigorous with treatment when active disease is identified, because we believe that this way we can eliminate or at least prevent disease progression. And we always evaluate our response before formulating a long-term plan. The monitoring is key with regards to the adjustment of sarcoidosis-specific therapy. And when it comes to cardiac sarcoidosis, the treatment, unfortunately, has to be prolonged. We are very much aware of the toxicity that steroids cause, and there are studies lately that have shown that, so we want to minimize their effect. But what someone needs to remember is that even when discontinuing treatment, patients are not safe. So even if they have no activity and we decide to discontinue treatment, which is what they would really want, there was a study that showed that there was a higher risk of mortality or decline in cardiac function. All of these would suggest relapse of their disease. So this needs to be carefully monitored. This is just an example of a patient that was given vigorous treatment, and you can see on the lower part the active disease that was evident in the heart and elsewhere in the body, and you can see the excellent response that the patient had afterwards. And I would, despite what has been discussed about the side effects, I would like to point out that this patient was treated with steroids, continued on steroids and methotrexate, and actually had his ejection fraction improved. I think that despite a huge effort from both the clinicians and the patient's perspective, we did manage to improve his prognosis. As I mentioned, we are a very closely working team. It is patient-centered but consultant-led, and our key and core tool is the MDT approach. This is how patients look like after success and after complete resolution of their treatment, and this is what we would like to succeed for most of you. Thank you.
Thank you very much, Vasilis. Would you mind sharing your screen? That's perfect. I don't know what to make of all those boxing references. You're obviously you're psyched up for the day, which is fantastic. And that was a wonderful talk from the both of you. So thank you very much. It stimulated a huge number of questions. Sorry, I'll start my video so you can see me. A huge number of questions, and we've got about 10 minutes to go through them all. So I'm really grateful to you both for that. A number of questions have come up about what patients need to be aware of in terms of symptoms. So when I reflect on my own practice, chest pain is quite a common symptom of sarcoidosis. What is it specifically that patients need to think about? And as clinicians, how can we direct them to the sarcoidosis, the cardiac service when at the right time?
Thank you, Peter. Should I take this question, Vasilis?
Yeah, sure.
Thank you. So when it comes to chest pain, obviously it's important to try and characterize the type of chest pain. If there's inflammation of the heart, a condition called myocarditis or even myopericarditis can develop. So that's when there's inflammation within the muscle and the membrane around the heart. And typically the chest pain tends to be worse on change in posture. It can be sharp. It can be worse if patients have a cough, for example. It tends not to be the type of chest pain that patients get with coronary artery disease, which is more like a pressure sensation on exertion, which goes away when patients rest. But having said that, not every patient fulfills the textbook descriptions. So I think if anyone is getting chest pains, they need to be reviewed by a specialist, and the standard tests such as an ECG, blood test will be done anyway. But certainly in sarcoidosis, if there's inflammation of the heart, patients can present with chest pain. What we tend to find is that a more common symptom is actually palpitations. So very often patients will present with either skip beats or extra beats or even rapid heartbeats. And again, that could be due to inflammation, but it could be due to fibrosis as well. And for each patient, it's about trying to work out what's happening with the rhythm, because it could be a benign rhythm or it could be something a bit more serious.
So the focus is really on chest pain, which is slightly different or changing, and palpitations. So your heart rate, being aware of your heart pumping, beating, and it doing so in a way which is not normal for you, and they would be concerning features.
Peter, I would like to add one more thing to Rakis's comment. And we have seen this increasingly nowadays, is that because of the ability of the MRI to detect cardiac involvement, we are now performing scans to patients who have disproportionate breathlessness. And disproportionate breathlessness would be defined as patients who have normal or normalist lung function that cannot really explain the degree of breathlessness that they feel. So we have identified that patients who previously were reporting breathlessness on exertion that could not be easily explained had cardiac involvement.
So breathlessness is a really important symptom, isn't it, in this context? A number of questions have come through surrounding whether, if a patient has been diagnosed, for example, with mediastinal lymphadenopathy, so enlarged lymph nodes in the chest and perhaps skin involvement, can they then develop cardiac sarcoid later on in their illness? And is that something they need to look out for?
Should I take this question first, Vasilis, and maybe you can add to it? So yes, sarcoidosis is a multi-system disease, and very often patients will present in either one of two ways, either because there's extra cardiac involvement, and the classic scenario is someone goes to A&E and has a chest x-ray that shows some lymph nodes in the chest to be enlarged, and then they have the test which show this cardiac involvement. But We also know there's a condition called isolated cardiac sarcoidosis. So this is where the condition for some reason is located just to the heart. And even though we look for extracardiac disease, such as with a PET scan, we don't find any. So, and that can affect up to about a quarter of patients. So isolated disease we tend to find is a bit more difficult to diagnose. It does certainly warrant an MDT approach, and also the outcome, unfortunately, tends not to be as good as patients who presented with more systemic disease. Vasilis, did you want to add to that?
I think that this goes down to screening and whether you know, how can we screen actually patients. I would be more happy to screen patients if they, for sarcoidosis, if they had a cardiac manifestation that is core, in the sense that they had a major arrhythmia or heart failure that they were not aware of. And this would be by performing a CT scan rather than a chest X-ray. And with regards to sarcoid patients, how they should be screened, I think that nowadays blood tests with biomarkers on top of ECG and Holter monitoring are really helpful. That's what I would say. I think because of the anxiety that cardiac involvement causes to patients, we just need to be mindful of being very accurate to what we are doing, rather than jumping and doing all sorts of tests that may not be needed and cause a lot of psychological distress too.
Yeah, no, thank you, Vasilis. So, so biomarkers are just blood tests which might suggest an underlying problem that can go up or down as that disease improves or gets worse. So it's just a way for us to monitor the activity of a disease using blood tests. We're obviously very, very fortunate at the Brompton to have a highly active transplant service. And I know that we've been working increasingly closely with our lung transplant physicians. We have weekly MDTs now, monthly MDTs, and are doing many more lung transplants, including for sarcoid. How about transplantation for cardiac sarcoid? What's your experience of that?
Again, should I start, Vasilis, and hand over to you? So it's a very timely question, actually, because yesterday we submitted an abstract to the British Cardiac Society about our experience for cardiac transplantation for cardiac sarcoidosis. So we looked at the number of transplants which took place from 2010 to 2020, so over 10 years. And out of approximately 250 patients who were transplanted, there were 7 who had cardiac sarcoidosis diagnosed. And the unfortunate aspect is that even in the ones who had the transplant, there was apparently a relapse of 40% in the transplanted heart. So there's some process which is going on, which is driving this condition. And although transplantation is a very rare form of treating cardiac sarcoidosis, for some reason, in up to 40%, there is some relapse. So we don't really understand the mechanism for that. Vasilis, did you want to add to that?
Yeah, I would like to add that I think that we are actually fortunate to have a very limited number of patients who end up being on the transplant list or being transplanted, in the sense that we have seen good response to the therapies that we use. But on the other hand, I think that this is offered, and there is another new development that is quite commonly used nowadays, which is LVADs. These are new devices that the transplant physicians are using as a bridge to transplant, or even in isolation, to help patients that have severe heart failure go through the symptoms. So there are a lot of advances in that field. We try to keep our the options open for our patients, primarily because they are young and they are in an age group that would be candidates for it.
We have 1 minute left. I'm going to ask one final question. Rakesh, perhaps if you take this, what is the value of cardiac rehabilitation in improving ventricular function in patients with cardiac sarcoidosis?
Very good question. I think the answer is we don't know. In terms of cardiac rehab, we do use this for patients with heart failure, so we can extrapolate. And several studies have shown that if there is heart failure, patients do benefit. For the cardiac sarcoidosis population, there's no reason why that shouldn't apply as well. Certainly with COVID, there's been a huge impact on cardiac rehab across the country. The service has been done remotely. But I think we do need proper prospective studies to answer that question properly.
I suspect, watch this space. If anyone's going to do them, it'll be Dr. Sharma and Kuranos, who I'm sure will be leading on that kind of work. So I'd really like to thank you both for a wonderful presentation. Really, you've touched on a very difficult topic and simplified it for us. I think people will look forward to reading your slides back and taking their time to pour through them. So thank you both. It gives me a great deal of pleasure to introduce our next speaker, Dr. Christopher Atkins. Now, Dr. Atkins is a consultant in respiratory medicine at the Norfolk and Norwich University Hospital. He was a member of the BTS sarcoidosis statement, and he's an expert in fatigue relating to sarcoid. And this is an area that we know patients really struggle with. So I'm very excited to listen to you. So Christopher, over to you.
Thank you very much. I'll just try and share my screen here. Can everyone see my screen now?
Yes, we can.
Great. So firstly, I can only echo what the previous presenters have said in thanking the organisers and SarcoidosisUK programme. And I think it's been absolutely fantastic, and it's also brilliant to be able to talk directly to patients in SarcoidosisUK. I'm recently appointed as a consultant. I was still a training registrar when I was on the BTS panel putting together the guidelines. So it's also a real honour to talk alongside the people who've been a real inspiration over the years in terms of how to manage sarcoid and how to treat patients in the way that I now do. With that in mind, my talk today is about managing quality of life in sarcoidosis and what to do. And this is a complete 180 from the previous talk, which obviously involves a lot of investigations that can definitively show whether or not cardiac sarcoid is present and interventions with robust evidence behind them. I don't really have that behind what I do, but as mentioned, my research interest for several years now has been about chronic fatigue in sarcoidosis and the other issues that affect quality of life. So I hope to be able to discuss something that might be of use to patients and perhaps colleagues as well. So I think it's important to start with what affects quality of life in sarcoid. It's easy to think about sarcoidosis as something that is a disease that just causes direct organ damage and dysfunction through the infiltration and deposition of granulomas that Simon spoke about this morning. And around this, we also find the systemic symptoms that cause people to lose their quality of life. So fatigue, muscle weakness and pain, and small fiber neuropathy, which I'll come to as well alongside fatigue. And that these together reduce an individual's ability to perform activity, their so-called fitness. And so we treat with medications such as corticosteroids to try and dampen down the activity of the sarcoidosis, but this in itself carries a significant risk of treatment side effects, of which fatigue is most certainly one with corticosteroids, particularly high doses. And we refer to this bunch as the symptom burden. So all these are direct symptoms that occur. But how an individual then perceives those symptoms and is debilitated by those symptoms, or indeed not, is affected by further things. I should add that with the symptom burden, this then leads to disability, which is a loss or change of job or reduced activity. And someone asked, one of the questions is whether sarcoidosis is considered disability. And under the Equality Act in 2010, if you have a physical or mental impairment that has substantial and long-term negative impact on your ability to do normal activities, then yes, it is considered disability. So the answer is yes, it can be, depending on how it's affected you. And it's also important to note that certain manifestations such as cardiac sarcoid that was mentioned previously can in certain cases lead to death. But the burden of symptoms can be affected by further aspects. And so we know that anxiety and depression modify how we perceive our symptoms and indeed the world around us. And that's further affected by our symptoms often impairing our normal ability to do activities, making us more isolated and losing social contact. And overall, this is the psychological burden. And together, these two things lead to an impairment of quality of life. And trying to tease apart which of these are the predominant problems and which of these we can do something about is part of the challenge in individual patient cares. And it's why it's important to treat every patient with sarcoidosis individually. So what do we need to treat? Well, there's essentially two reasons, and this was mentioned by Professor Wells earlier, and I think he was being a little bit modest because this paper that I've taken a screenshot of refers to it specifically as Wells law. And so there is the reason to treat because of danger to organs, and there is also the reason to treat because we want to try and improve an individual's quality of life. From that paper, these are the rough headings for why we treat. I'm going to remove eye problems from quality of life and stick that under danger for ocular disease. I'm going to take out calcium dysregulation, as I think long-term that causes danger on multiple levels. I'm going to take out lung symptoms because we have discussed these before. And as much as I'd like to be, I'm not a dermatologist, so I'm not going to talk about cosmetically important skin lesions. So I'm going to focus on fatigue and small fibre neuropathy, which I think we should refer to as the awkward squad, because let's face it, they are difficult to treat. I'd like to briefly talk about small fibre neuropathy because I think it is important, and it does lead to a number of symptoms that can cause problems. This is where small nerve fibres within the skin, the density of them become reduced, and so you can get various symptoms, most commonly probably shooting pains or sensitivity of the skin for no apparent reason. And that's from the loss of these fibres, which comes about not because the fibres themselves have been destroyed by the activity of the sarcoidosis, but more as a phenomenon around the immune activation. And it can cause a long and numerous list of problems. This is the small fibre neuropathy screening list, which has been validated for looking for small fibre neuropathy. But I don't like necessarily using screening lists, which are often more research tools than dealing with an individual patient's concerns. But it does flag up the kind of things that can be causing problems for an individual. Pains, shooting pains in the arms or legs, also things associated with the autonomic nervous system, which is the part of the nervous system that deals with the parts of the body which are under automatic control. So things such as bladder control, things such as swallowing. It can also lead to things such as palpitations, dizzy spells. So various other symptoms which can overlap with other true manifestations of sarcoid, even cardiac sarcoid, without any evidence of overt disease activity. Unfortunately, for some people, it is manageable. For some people, it can be very difficult to treat, but it's important to be aware that sometimes some of these symptoms can be managed with symptoms, and there is, this paper has summarized the treatments that have been trialed. Again, the evidence isn't always great, and it's sometimes a case of trialing with an individual what works for them, but it's also important to recognize that these medications have their own significant side effects. And so working out whether the treatment is going to be better than the side effects it itself causes is something that has to be discussed individually, but I'm sure some people have been tried on drugs like amitriptyline, duloxetine, topiramate and lamotrigine, and have had benefit from them because of these type of symptoms. However, I'd like to focus a little more on fatigue, and I could literally write a thesis on this. Fatigue is a big problem. This is the data from the British Thoracic Society's Sarcoidosis Registry. And some of the authors you'll recognise who've spoken earlier today or will be speaking later. And fatigue was number 3 in patients presenting to clinic with a diagnosis of sarcoidosis, so new cases. And although this was only a small number of cases because it was quite early on in the registry, it was about a third of patients that were reporting fatigue. And I have to say that when I say reporting fatigue, I mean that the box was ticked on it by their physician that was entering them into the registry. And it's important to note that not everyone screens for fatigue as part of what's going on. So this may well be a slight underrepresentation, particularly when you consider looking at other evidence. And this is just one study, which admittedly was looking at something else, but had recorded fatigue in prevalent cases. So these are long-term cases of sarcoidosis. And as you can see, the lowest rate was 41.6% in patients that had purely extrapulmonary, so not really any evidence of lung sarcoidosis, or predominantly abdominal sarcoidosis. 40% of those patients suffered significant fatigue to them, and all other clusters of manifestations of sarcoid, they were looking at 2/3 or above of those patients reporting fatigue. So it's a really common symptom, and it can really debilitate an individual. And it can sometimes be difficult to define. I think it's important to try and define what's fatigue and what's tiredness, and the two can often overlap, but they are different. Tiredness is the feeling of wanting to sleep, and that's usually relieved by sleep as long as your sleep is working fine, your sleep architecture is normal, and you can get refreshment from sleep. But if you feel that you need to shut your eyes to go to sleep and then get some sleep, that's very different to fatigue, which is a daily lack of energy, and that's not relieved by sleep. You may find that you wake up with minimal refreshment from sleep or no refreshment from sleep and very quickly feel that you have little energy to carry on. But the other thing that I think is important to identify is whether that fatigue is physical or mental. Physical fatigue relates to muscle power, muscle strength, muscle weakness, a frequent side effect of corticosteroids, the inability to do prolonged physical activity, and this is really physical exhaustion that we're talking about, and that can be a big problem in sarcoidosis. But the problem that I've found from patients that I've been seeing in clinic, the absolute number one thing that if they wish they could get rid of it, it's the one thing they want to. It's the mental fatigue. It's the inability to start or complete tasks, the inability to think clearly, and the term brain fog is frequently used, and it's a very good term to describe how they feel. And trying to improve on that can be very difficult. Sometimes centres use screening tools to work out if fatigue is present or not, and this is the fatigue assessment scale tool, which is used quite commonly. And it's quite simple. It identifies symptoms which patients report commonly. It has domains which look at physical and mental exhaustion, and it's very good. But really, it's only very good when you're doing research, because although there's a defined improvement that can be seen and there are defined thresholds for where an individual could be deemed to have fatigue or severe fatigue, actually, when it comes down to it, when you're in clinic with me, your fatigue is what you tell me it is. And if your fatigue assessment scale score is only 20 points, but you tell me that you're shattered all the time, you can't think clearly, you can't do anything, that's what I'm going to believe, and not a questionnaire score. There's multiple reasons why fatigue comes up in sarcoidosis. First, it can be directly attributed to sarcoidosis itself, and it's not uncommon for someone who's having acute sarcoidosis to come to clinic, and fatigue is part of the presenting complaint. Sometimes they need to go on to acute treatment because of the level of symptoms, and it can respond to things like steroids and hydroxychloroquine. But equally, steroids, particularly at high doses, bring with them their own problems, and so the fatigue itself can be directly attributed to the side effects of those. And steroids wreck your sleep, make you put on weight, affect your muscle physiology and how much you can exercise. And so at high doses, and as Professor Wells alluded to earlier, in the hands of the wrong poisoner, they really can be worse than the disease itself. And then finally, there's alternative causes which can occur alongside or because of sarcoidosis without being directly attributed to the granulomas that are being formed, or indeed something that's completely incidental. Patients with sarcoidosis do, after all, get other illnesses as well. And this is why in the British Thoracic Society position statement there is a flowchart to try and allow physicians and patients to review a structured approach to how things can be reviewed. And it doesn't mean that you need to do each step in order and have to try everything before we move on to the next one, but it's a consideration of things that may or may not have a benefit for individuals, and we can roughly break it down into eliminating those alternative causes that can contribute to fatigue, and by that I mean anemia and iron deficiency, thyroid dysfunction, calcium abnormalities, and also sleep disorders, and things such as restless leg syndrome and obstructive sleep apnea are more common in sarcoidosis. And then the second half of the flowchart is to try and identify those where it's purely sarcoidosis-associated fatigue and how we might improve that. And taking that structured approach can take time. And it's important to take that time, I think, firstly, to make sure that we're not missing anything obvious, and secondly, to understand what quality of life goals we want to try and meet. And having an open discussion about those is very important. And we can then discuss, once we've gone through ruling out alternatives and seeing if there's anything that improves things from that point of view, about treatment options directly trying to target the fatigue. Now, trialing low-dose steroids with or without hydroxychloroquine is one possibility, although, as mentioned, steroids bring their own set of problems to the table, and so it's important to be frank about that. Exercise therapy and pulmonary rehabilitation, they have evidence to show that they do improve things, but the evidence is slightly biased in that there isn't really a blinded group to exercise. The patients that go into these exercise therapies go into it because they want to, and therefore it's a self-selecting group of patients that are fired up and willing to give exercise a chance and therefore most likely to benefit. But nevertheless, if you feel up to doing exercise and increasing exercise or taking part in exercise classes, they're likely to benefit you. Identifying what causes problems for you, keeping a diary of what activities have gone on in a day, when you're having bad days, when you're having good days, and then working out when to pace oneself. So someone asked me about how to better do housework without exhausting yourself, and I think this is where pacing advice does come in and come to the fore. So spreading out the various household activities across the week, roping in other halves and other people in the household to do things as much as possible. These kind of things, working out how to pace yourselves and not exhaust yourself. There is a mention of ginkgo biloba, which is a health supplement that's available from health stores and is derived from the ginkgo biloba tree, which is a Chinese tree which is ancient and has fossils going back to 200 million years ago. There's minimal evidence from other conditions such as MS. There's not anything in sarcoidosis, but it is something that can be tried. But I'd certainly recommend discussing with your physician before you go ahead, just in case there's an interaction with other medications. And then finally, there's direct treatment with neurostimulants. This is to try and target the mental fatigue, but these are no magic bullet, and I will discuss that in just a moment. And with any treatment that's given, it's important to monitor the response closely and whether a holiday is needed. With neurostimulants, we've based the suggestion that they can be trialed based on previous evidence with methylphenidate, which is a stimulant used normally in ADHD, which is attention deficit hyperactivity disorder, most commonly in children, but also affects adults. It basically improves transmission of various chemicals and electrical processes through a part of the brain called the prefrontal cortex. And that's like your brain's manager. When there's not enough processes going through there, then you tend to be unable to start tasks, complete tasks, or think very clearly, which I think for some people will probably sound very familiar. And so it was tried in 5 patients as and then reported in a single letter to a journal, and it was well tolerated and there was subjective improvement. And then it was tried again in a study in America from Cincinnati, where 10 patients were involved in a crossover study. So that meant that they got both the active drug and a placebo, and that improved the fatigue assessment scale score by an average of 5 points, more than the typical minimal clinically important difference. And then likewise, modafinil, similar study, again, similar improvement, both of these being neurostimulant medications. But the problem is, the evidence for this was crossover, so it means that patients receive the active drug and also receive placebo. And these drugs have very well or very easily identifiable side effects. So there is the risk that you unblind yourself, and so you know when you're getting the drug, and you know therefore when you're getting the placebo, and you'll report your symptoms differently as a result. And so this was a small randomized controlled trial with patients being randomized to either placebo or methylphenidate for up to a 24-week period, and then a 6-week washout. And then we looked at then the fatigue assessment scale score was measured. And lower scores here are better. The little dashed line across going horizontally is the minimal important difference. And you can see that those that were in one group, well, everyone really benefited. Mostly they came down below the minimally important difference. But the one in the dashed line group, they did better, not hugely better, but nevertheless better. And unfortunately, that group was the placebo group. And so it raises the questions about whether neurostimulants are largely acting as a placebo, with patients believing that they're going to work and therefore benefiting. I think there's more nuance to it than that. I think it's also important to mention that in that study, the placebo group became far less anxious in terms of their hospital anxiety and depression scale score during the study, and we know that anxiety affects fatigue, so that's one thing that may have impacted. But that doesn't mean that they're useless, and for some people they do seem to make a huge difference, but I think this reinforces the importance of individualized therapy. So I think the ultimate question for those of you watching is, what can you do? And I think that looking at the video that was put together this morning, there was one person who was talking about their fatigue very eloquently, and also talking very much about what they've been able to optimize. And I think that commonly this is referred to as the common sense approach. What works for me? What can I do better? And this largely relates to sleep, diet, and exercise, making sure that you've got as good a sleep quality as possible. And that can be difficult when you're on steroids. That can be difficult when you're unwell with your sarcoid. But having a cool room, having a dark room, having regular bedtimes, having regular times of getting up. Diet, obviously eating healthily, exercise, trying to maintain levels of activity. That's been difficult in lockdown. We've seen a lot of patients who have got worse in terms of their symptoms without identifiable worsening of their sarcoidosis. So, you know, there's a lot of things that that can be improved by individuals. And also being part of the support group, I think, is hugely beneficial. But I think actively seeking out what works for you is definitely the most important thing. So I'll wrap up very quickly by saying that, going back to that original diagram, we can use immunosuppression, but it often has more risks than benefits. We can use antidepressants and neuropathic agents where pain and small fiber neuropathy is a prominent symptom. We can use neurostimulants where fatigue is the big problem, but they are not a magic bullet, and they really should be one of the options of last resort rather than anything that we should be reaching for straight off the bat. CBT, psychotherapy, talking therapies, these are all things you can self-refer to in the NHS and can have an impact on psychological impacts. Exercise and pulmonary rehab, definitely beneficial, as is pacing to make sure you don't exhaust yourself. So what to do? It's important to identify what it is that works for you, and that's equally important for you as a patient, me as a physician. Everyone has individual strategies that they respond to. Agree those treatment goals, individualize the therapy, as multiple strategies may need to be tried or even used simultaneously. But finally, also, not everything is always due to sarcoidosis, so do keep an open mind. And that's all I have to say. I think I may have run over a little bit. I do apologize. But thank you very much for the opportunity to talk about this today. I could literally go on for hours.
No, thanks for not going on for hours. Wonderful, really, really, really clear talk. Lots of very positive comments in the chat. We're not going to have a time for questions, unfortunately, but really a lot of the interest maybe around the small fiber neuropathy and how that explains a lot of people's symptoms. So perhaps that might be another opportunity to think about in future talks of this nature. But thank you very much, and we're grateful for your attendance. And
thank you.
Next, I'd like to introduce Dr. Rubina Coker, who I believe is on the call. Rubina, are you with us? Can you put your camera on just so I can see? I know that Rubina was just logging in. Rubina, you are here. I can't see you on the screen, that's all. You pop your camera on. Okay. At the bottom on the stop video. So what Rubina, I can see you on the chat. If it's proving challenging for now, I think Lisa's very kindly agreed to go first, if you would prefer. If you just put me a message on the chat to let me know, that would be very helpful. Okay, Leo, would you mind touching base with Rubina and helping her with her video function? I think there's a problem with that. And Lisa Spencer, if you're okay to jump on, perfect, thank you. So we'll while Rubina is getting her camera sorted, it gives me great pleasure to introduce Dr. Lisa Spencer, a good friend, and she is giving us a talk on the British Thoracic Society response to the pandemic. Lisa's got a very senior position in the British Thoracic Society as Honorary Secretary. She's been involved in the registry, I think, from inception up until recently, and continues to be highly active, representing the ILD and sarcoidosis community at the highest levels of NHS England and beyond. So thank you, Lisa. We're very much looking forward to your talk.
Hi, Pete. Just bear with me 1 second. I'm just having a slight issue sharing my screen for some reason. We tested it earlier and it worked fine. Let me just... Right, hopefully. Is that
yeah, so if you
is that working now? That's working now, okay, and you can hear me?
You can. If you just click on the presenter view, then we'll be able to, that's it. Perfect, thank you.
Are we okay there? Yeah, sorry, I was just not prepared with the screen sharing there. Okay, sorry about that little glitch. Thank you, Pete, for that very generous introduction. Hello to everyone. It's really, really lovely to be here today. I've managed to dip in and out a bit because I had some other commitments today. But what a fantastic day so far. It's been really good. So hello to all the patients out there. And I would like to thank Leo and Dr. Kranos and the Sarcoidosis charity for the kind invite to come and talk to you today. So I think what Dr. Kranos wanted me to touch upon today was some of the work that your lung healthcare professionals have been doing in the background that may have been slightly unseen. So they wanted me to do something around the British Thoracic Society, which is our medical specialist society for lung healthcare professionals. And talk about our response to the pandemic, and obviously try and focus that in a bit on interstitial lung disease. So what is the British Thoracic Society? Many of you may not be that aware of it. So it's a registered charity with members, and those members consist of respiratory doctors, nurses, physiotherapists, physiologists. Those are the healthcare professionals that take you through your breathing tests, and also scientists and other people that are interested in respiratory care. The aim of the British Thoracic Society is fairly clear. I think it's about championing excellence in diagnosis, treatment and care of people with all lung diseases, and also in those who are delivering it. And the BTS is intrinsically involved with training respiratory professionals in the exam setting, delivering exams, and driving up standards of care. So we have a program of guidelines and guidance that we produce every so often for diseases. And this allows a good standard of care amongst the respiratory professionals, but also people from other specialities can take those guidelines and apply them and give good respiratory care outside of their specialist area in an easy manner. We encourage support research. And we also deliver 2 respiratory conferences each year where we share information and hopefully improve knowledge. So I had to sort of sit back and have a think when I got this title of this talk as to really what to focus on. The BTS it does a lot of stuff normally in non-COVID times, but it's been extremely busy, as you can imagine, during COVID. So I've made this brief list of things that I think are ILD sort of specific, and there's 4 things here that I'm going to run through about things that I think made a difference to ILD care. I just remind that when I say ILD, that incorporates sarcoidosis. Sarcoidosis, as you'll know, is a form of interstitial lung disease and covers many diseases. So one of the things that we did a lot of website guidance, and in particular, we provided quite early on a document for the care that we thought would be best delivered for ILD patients within the pandemic. And this was put together by a number of ILD specialists and specialist centres, a number of collaborators put that document together. We also took that to the next level, and we published national guidance about ILD management, which went out on the NICE website. So I know we've got some overseas participants today, so you may not be familiar with what NICE is. NICE is the National Institute of Clinical Excellence, which is a body that covers care in England and Wales, and it's there to ensure standards of care and improve care within the NHS. And it's a very well trusted and respected body, so to get guidance on their website is very helpful to getting the word about what's going on. We also got national agreement quite early on with respiratory colleagues to prioritise actually interstitial lung disease patients, sarcoidosis patients, to have access to breathing tests. Some of you may or may not know, but the lab shut down for a while, causing problems and backlogs. So that was good that we got that access agreed early. And I think the other important thing that we did is we took action early to protect ILD patients by adding them to shielding lists. Now, again, if you're joining us from abroad, you might not be aware about what shielding is. I think it was a bit of a UK thing, the terminology. And I'll come on to that and some of these points a bit more as we go through the slides. So what about website guidance? Obviously, I've mentioned we had an interstitial lung disease document, but actually, like many other medical specialist societies, when COVID hit, we had to open up a web portal and a hub for information. Of course, because COVID is primarily a respiratory problem, everybody was wanting to know information and wanting it from the respiratory people. So over a very short period of time, weeks, we produced about 30 pieces of guidance, and it was no mean feat. And initially, it was a very small number of us at the BTS leading on this. And then as time went by, we managed to get more people involved, and some of our specialist advisory group members who have got experts on help to put some of these documents together. And you have to remember that this was happening while the first COVID surge was going on. So all our respiratory colleagues were either working extra shifts, extra on calls, and were absolutely hammered at the time. And they were doing these things at night, weekends, under great pressure, and it's a real credit that they got some of this work out there. I remember this first period of COVID as being one of the worst of my life, and being very, very tired with all the things that we were having to do. So people did really well to get all that stuff out there. The documents are quite widespread, actually. We cover certain diseases and how they should be managed during COVID. Things like procedures. How can you do a bronchoscopy where we put telescopes into lungs to get samples and things? How can you do that safely in a COVID environment? There's a lot of aerosol generation, people coughing. How do you do that safely without harming the patient, harming the staff? Also, procedures like lung function tests, how can you do those safely? We need to get our evidence out there to keep our patients safe, to keep our staff safe. We needed the staff to be at work to look after all the patients. Also extended out into the community. So a lot of our airways patients with COPD and asthma managed actually a lot in the community, and we needed to extend our advice out into their care as well to make sure that everyone was looked after properly. We also had to collaborate very closely with other specialist societies, particularly, for example, the Intensive Care Society. These patients were ill with a respiratory breathing problem. They might start on a medical or a chest ward. They might transit into intensive care, transit back out. We had to agree between us what were the right points that we would escalate their care or de-escalate their care. And we had to ensure that guidance that was coming out from different medical specialities was saying the same thing. We didn't want one specialist society to say one thing and one another. For example, around affects sarcoidosis patients, a lot of patients might be on drugs that suppress their immune system. And we had to link in with societies like rheumatology, who use a lot of these drugs, because we didn't want to give the rheumatology patients different advice to the sarcoid patients, because it would have been extremely confusing for patients. And also we wanted to give clear messages where possible. So there was a lot of back chat and information sharing going on, and also talking to the charities. You know, where there was patient information coming out, we wanted to get that out through the charity avenues, because the charities have been amazing supporting patients and getting information, accurate information out to patients. So there has been a lot going on. Just early on, just to give you a couple of examples, I remember very early on, one of the first sort of controversies we had was, is it safe for people to have a nebulizer if they might have COVID? And of course, initially, swabs took a long time to go back. We didn't know whether the patients had COVID or not, and we put them in different areas. So on the top right of the slide, there's a picture there of a nebulizer mask. There's sort of mist coming out of it, which is the nebulized drug. Nebulizers look different, but there's a chamber underneath where you put the liquid drug, and then the tubing goes to a machine that pushes air through, nebulizes the drug into this aerosol, and it makes it very easy for patients to inhale it. Now, most commonly, that sort of drug will be used actually for asthma or COPD, perhaps, and those nebulizers can be life-saving treatment. But you can imagine if you think someone's got COVID and there's all this steam coming off their face, and at the time we were worried, we didn't know how COVID was spread. Were we putting COVID virus particles all over the A&E area or all over the ward? There was a lot of controversy and questions and worry, understandably. So we were actually, in the end, we were quite quickly able to put that myth that it was dangerous to give nebulizers and it would spread COVID to bed. But if we hadn't hit on that and got that sorted out earlier, people would not have got drugs that they need that could be life-saving. Another example is over the use of CPAP. That stands for continuous positive airway pressure. And the bottom picture on the right is a picture of a circuit, a face mask going into a yellow sort of oval shaped filter down to some oxygen tubing and some tubing to a machine. This is a sort of typical setup that we might use to give CPAP, which we are very familiar with as chest physicians. We used it for a long time for people with sleep apnea to help them sleep better, but we were using it now to deliver oxygen, and that wasn't done very commonly before, and certainly outside of chest units it wasn't really done by anyone else. So, but the patients with COVID weren't just sitting on chest wards, they were sitting on medical wards, and sometimes they were being looked after by non-respiratory doctors or surgical teams with physicians paired up. So these other teams were not familiar with these circuits, how to keep them safe, how important it was to put this extra bacterial filter that we don't normally use in the community outside of COVID. These filters will stop the disbursement of viral particles. So, we had our own patients to look after. We were also outreaching to other teams, supporting, checking that patients on these pieces of equipment were safe. And that guidance we were putting out was very important for lung doctors to check what was right, and also for non-lung doctors to make sure that we're doing the right thing. So I have no doubt in my mind that some of the advice that we out, it made things safer and it saved some lives. And so that's very important. And you might wonder, well, was it used? Was it accessed? Did anyone listen? Did anyone read it? Well, we've got some data now from 13th of March 2020 through to March 2021. Our systems tell us that we've had 345,000 views of these documents now. We've had over 280,000 downloads. That's around 1,000 visits a day to our website and 750 downloads per day. Traffic is huge compared to the normal sort of traffic we get pre-COVID. It's a wonder that some of the websites and the internet didn't crash at points. And actually, if only 10% of those downloads helped a clinician and their patients, the BTS there, if only 10% was helpful, helped 28,000 clinicians during that year. So it was a massive amount of work. Moving on, I mentioned that we got an escalation of our guidance, not just on our website. We got it out with a NICE guideline. During COVID-19, NICE has produced 36, approximately, I think, rapid guidelines across many disease areas, across all of medicine. A fifth of those guidelines have had significant respiratory input, obviously because of the disease. And so we've had a lot of input into a lot of guidance around interstitial lung disease, different diseases like asthma, COPD, cystic fibrosis. And again, this was all done when respiratory doctors were under a lot of pressure. So, it wasn't easy to do. Why is it important to get these documents out? Why doesn't just our website? Well, it's important because it reaches a wider audience. People can access the information. They will use the NICE website for reliable information. And importantly, I think for interstitial lung disease, as I've highlighted in red here, we managed to get into this document about something about shielding. I'll come to shielding in a minute. But it was quite controversial shielding. And as many of you will know, interstitial lung disease was not on the original shielding list, which caused quite some problems for me and all our colleagues, as you can imagine. But we've got a mention about shielding in here. And this was the first sort of public national document we got it in and got it written in. I think that was an important step forward. We also made it clear in this document that ILD centres were open for business. We were still there to see patients who were getting ill and needed urgent, rapid treatment. We could still see patients face to face if it was important to do so. So we made that clear in this document, and that went out there. We talked about blood monitoring and how GPs could help with that, and GPs were great. They helped with the community blood monitoring. We also mentioned things like home spirometry, which wasn't really documented anywhere else apart from on our website, that it was okay to use this to monitor patients where needed, so the patient could remain at home and remain safe, but still have assessment of their condition. And interestingly, when I was reading it the other night, we put quite a little bit in about not stopping steroids and not stopping immunosuppression on our patients. And at the time, that was actually quite controversial because we know now steroids are good for COVID most of the time. But back then, people were worried that they would harm people. And actually, we got that into this document as well. So don't stop the drugs unless you've got a good reason. And that may, in retrospect, have been a very sensible decision. I mentioned about us getting priority for ILD patients to get access to breathing tests. You may or may not have been aware, but when the initial shutdown happened in the UK, where everything shut down, our labs shut down completely as well. We had no access to breathing tests. And this is because in the early phases, it was felt that doing breathing tests would be an aerosol generating procedure, an AGP, another word that's come into our vocabulary since COVID, along with other strange words that we use now. So this means that because patients cough often during a breathing test, that we know that coughing can release COVID into the air, and that was considered to be a risk. It might make the room infected with virus, if you like, and it might infect the staff. So we had to, when things were shut down, we had to then make everything very COVID safe, COVID secure, to reopen those labs and get the tests going. So there was a backlog where no lab service was available. And then once it reopened, because to make it COVID secure, we had to do a lot of air changes, leave time between the room, clean the machines. All that took time, and there are less slots. But we managed to agree with our colleagues who were very supportive that to start treatment, stop treatment, and change treatment ILD, it was important that we got the access to the lab tests. We were second in line to cancer, which for obvious reason, cancer services did continue as much as they could. But then we got the next access to ILD, to breathing tests, which I think was very important. And so far as I'm aware, there's been no outbreaks through labs. And just so you know, breathing into the machines don't get anything inside them. They don't get infected with virus because there's lots of filters and things. So the machines are quite safe. This is about cleaning down the outside of the machine, clean the room, which is all in place. And we've had no outbreaks, which has been immense credit to our lab staff. Shielding, I mentioned briefly before. So we know in the UK, ILD patients weren't named. Other respiratory diseases were named. A lot of controversy, which I don't have time to cover really, but there was a lack of communication perhaps between the chief medical officer and the specialist societies. At least that's our perception. And this led to perhaps some diseases that should have been in there were left off. But what we managed to do is we managed through the ILD community to contact all the specialist centres and get letters sent out to our patients. In Liverpool alone, I had to send out over a few days 2,700 patients letters from my clinic. And at the time, we had no administration staff because they were either sick or diverted elsewhere. Doctors and nurses were all busy on the ward, and it was hard to do, but we did it. Some people may feel that we overprotected patients, but there was an opportunity to review their shielding status and unshield them if necessary later. Shielding is important because for those who might not know about it, perhaps those of you who are listening in from abroad, it permits access to support networks, get people helping you to get your shopping whilst you're staying inside. It can also give you protection against being sent into an unsafe workplace for you. It can be difficult, though. Obviously, the isolation and the mental health issues you get with it can be very tricky. Hurrah, shielding ended yesterday. This is a good thing because obviously we're moving forward and getting away from the serious end of the pandemic now, we hope. That is also, though, going to cause some anxiety because people might have to look at whether they can go back to work, which involves discussions with your human resources department, occupational medicine input, but a very nervous time for patients. Just a quick news flash. I don't know whether you're aware. Shielding meant as well, of course, that patients got early access to the vaccine, which has been a good thing, I think, for our patients. If you hadn't been on the shielding list, that wouldn't have happened. You'd have to wait turn. Sarcoidosis patients, often in the younger end, and would have waited much longer. This is a news flash. This has come out 2 days ago, and I suspect people may not be aware of it yet, but it's important for sarcoidosis because a significant number of sarcoid patients will be on immunosuppression. You are now able to access early vaccination for your partner, family, carers, household contacts over the age of 16. We don't know how you get that access yet. They've not told us that. But who lives with you will be able to get vaccinated earlier to protect you. So that's a bit of a newsflash item. This, I think, is virtually my last slide. This isn't a COVID thing, but many people have talked about the BCS clinical statement on pulmonary sarcoidosis today and how that's going to hopefully improve care. It wasn't done during COVID, it got published during COVID. And I just mention it as something else that we're doing around sarcoidosis. And also just to mention, I don't have any time left to talk about it. Pete's about to switch me off, tell me my time's up. We do run a national sarcoidosis registry. And I hope, all I say is I hope in the future it plays a bigger role in improving care. This is my last slide, just to acknowledge COVID has been a nightmare for practically everyone. Here's some colleagues here who are wearing PPE, another word that we wouldn't have known in the past. Well, we're all pretty sick of COVID, I think. So here's my attempt to cheer things up. This was me working on Christmas Day, trying to cheer everyone up. But I think I'm scaring people, actually. And I'd just like to say thank you to everyone. Sorry, I'm getting emotional. I don't know why. Thanks to everyone who's worked really hard. And to all my respiratory colleagues. Sorry about that.
Lisa, that was a wonderful talk. And actually, after you've had a glass of water, you should go and have a look back at the chat and see just how much.
I couldn't follow it.
Have a look at it afterwards and have a look at just how much the work that you and other members of the BTS did really for the community, for the patients, but also for us as consultants and healthcare workers in the area. So we're very grateful. We're actually really grateful for all that work and for your talk. So thank you.
Yeah, sorry about that. I wasn't expecting that. It was seeing all the staff again. Sorry about that.
Thank you so much, Lisa. We're very grateful. And do have a look back through that chat. I think you'll enjoy it. It's a nice read.
Okay. Are we doing questions or are we moving on?
Move on, Lisa, just in the interest of time.
Yeah, okay.
We had a list of about 20 questions and you managed to hit them all through your presentation. So everything that was asked, you actually answered.
Brilliant. Okay, I'll switch off then now. Thanks very much.
Yeah. Thank you. And Rabina, I think I just saw your video on.
Yes, thank you, Pete. You should be able to see me. Do you want me to share my screen?
Yes, that's perfect. Dr. Rabina Coker is a consultant respiratory physician in Imperial College NHS Trust. She runs the Sarcoid service at the Hammersmith, a large service. Got very senior roles, not just within her trust, but also within the region. She's the clinical director for the NIHR, reference CRN, Northwest London. It's a lot of abbreviations. I'm getting tongue-tied even though I'm part of it, so that's embarrassing. But I'd like to pass over to Rabina. You're going to tell us all about COVID-19, the sarcoid, and and what's changed with regard to risk and benefit in management and monitoring? So thank you, Ravina.
Thank you very much, Pete, and I'd like to thank the organisers of this symposium very much for inviting me, and it's a real pleasure to be with you this afternoon, and I'm sorry I had to join you a little late. So I've been asked to talk about COVID-19 and sarcoidosis, and despite Pete's warm words, I doubt that I'm going to be able to answer all your questions, but I will do the best I can with the data that we have at the moment. And right through this talk, I'm going to try and think about what we should or could have done differently, perhaps, or perhaps we wouldn't have done anything differently. What can we be doing now, and what might we do differently in the future? And I'm going to touch on some of the amazing work that Lisa Spencer, whom you've just heard, did with the BTS, which undoubtedly made a huge difference to all of us. And it has been a very, very difficult time, but there are some things we might take forward and we might hold on to. So we'll talk about some of those in a few minutes. And I've tried to address some of your questions. I'm really grateful to those of you who've put questions in, submitted questions in advance. They're really good questions. And I'm not sure I've covered all of them, but I've tried to cover as many as possible. So I was asked to talk about risk and then changes in management and monitoring. So I'm going to talk a little bit about the risk of people with sarcoidosis catching COVID. And then I'm going to talk a little bit about the risk of serious illness when you've caught COVID. And of course, this time last year, we were very much focused on the risk of acute illness. But we know now that many people have longer term symptoms, what we now call long COVID. So I'm going to touch on that as well. And then I'm going to think about changes in management last year, this year and beyond next year. And I'm going to talk about monitoring as well as part of all that. So in terms of the risk of catching COVID, there's really no evidence or rationale for an increased risk of catching COVID just because you have sarcoidosis, unless, of course, you are immunosuppressed, and that is the risk. So if you're on immunosuppressant medication, that will make anyone, including anyone with sarcoidosis, more susceptible to any infection, including COVID-19. And this was the basis of the UK shielding advice this time last year, which initially included people on immunosuppression. But as Lisa mentioned, it was the BTS really that moved the goalposts and said, actually, we should be including all patients with ILD and sarcoidosis. And that was at the end of March last year. And I'm sure this was definitely the right thing to do. We were very worried about many of our patients, and you'll see why in a few moments. So what about the risk of severe acute illness? Well, as early 2020, really, so before the lockdown in the UK, it was very clear from the data that were emerging from Wuhan that there was a greater risk of serious illness with COVID and indeed mortality if you had certain pre-existing conditions, and those included established lung disease. And the headline lung diseases were COPD and asthma, but not surprisingly, there was nothing about ILD really. And the data is still very limited. Gisli Jenkins and a number of us published this international multi-center study of over 160 patients with ILD in the Blue Journal at the end of last year. And that showed a higher mortality in patients with interstitial lung disease or parenchymal lung disease, so changes on CT, compared with matched controls. But you can see here that there were only 9 patients with sarcoidosis. The numbers are really very small, unsurprisingly. And there was a worse outcome linked to male gender, impaired lung function, and obesity. And the impaired lung function is the important thing to note here, because that's going to come up again. The poorest survival in these groups was associated with patients who had a diagnosis of idiopathic pulmonary fibrosis, followed by chronic hypersensitivity pneumonitis and rheumatoid-associated interstitial lung disease. And actually those with sarcoidosis had the lowest mortality in those groups. But remember, again, very small numbers, so it's quite difficult to draw any conclusions. And then there was a New York study of over 7,000 patients with just 37 sarcoidosis patients. And that showed that a diagnosis of sarcoidosis didn't predict a worse outcome. It wasn't associated with a worse outcome, but a worse outcome was associated with a moderate to severe impairment of lung function, whether you measured it with spirometry or gas transfer in the last 3 years. So that really does seem to suggest that impaired lung function is important. And then in terms of immunosuppression, and as Lisa's alluded to, we were very worried initially about continuing patients on steroids. And in fact, I had phone calls from surrounding hospitals quite a lot during the first 4 weeks saying, we've just admitted one of your patients, should we stop their steroids? And I said, no, don't stop their steroids. But it was a slight act of faith at the time. I felt, for the reasons I'll discuss later, that it was important not to stop them. But nobody quite knew, and there was a lot of anxiety about steroids. Anyway, a retrospective North American cohort study of over 2,000 patients in hospital with COVID, and that was published earlier this year, showed they had a 5% were immunosuppressed. And that showed that those immunosuppressed patients didn't have worse outcomes in terms of length of stay, risk of progressing to invasive ventilation, so CPAP or intubation, or indeed mortality. So that's quite reassuring insofar as it goes. And then what about the risk of long COVID? Very limited data so far. And NICE published a review of long COVID in December. And in terms of risk factors, they looked at 13 studies, and they noted that the data were quite low quality. That's not surprising, of course. They were gathered quickly and during a pandemic, which made it very difficult to do. And the studies were often small. And there were a very wide range of risk factors that were identified. And the NICE reviewers felt that the risk of bias was really quite high or medium at best. And so they felt they were unable to draw firm conclusions on possible risk factors for long COVID, and the evidence they'd gathered was not generalizable to the entire population. But of course, one of the reasons they did this was because they didn't want to exclude anybody from long COVID clinics or access to support. And they emphasized it's important to monitor anyone with symptoms of long COVID, regardless of whether they're perceived to have been at particular risk of long COVID. So that's a bit on risk. What about change in management? So last year, the headlines were the shielding advice, and Lisa's talked very eloquently about that. Some of you may have been to hospital because urgent hospital visits were regarded as essential travel, quite correctly. And the BTS advice, and I think it was absolutely the right advice, and it was what we were doing on the ground, was to advise patients to stay on their current medication if they were stable. And the aim was very much to use the lowest dose of immunosuppression to control the condition. And I actually think that is good practice anyway. It's what we should always be doing, but certainly being in the middle of a pandemic focused the mind on that. And there was a very understandable and I think justifiable reluctance to increase immunosuppression or start new agents unless it was absolutely necessary. And so we had to assess everyone on an individual case-by-case basis. And again, I would say that is the correct approach normally and is part of good clinical practice. And then, of course, towards the end of last year, there was a wider rollout of the seasonal influenza vaccine, which may have impacted some of you here today. What about changes in monitoring? Well, most hospitals, if not all, very quickly moved to remote consultations, particularly during the first and second waves, either telephone and in some cases video. Lisa's alluded to the fact that the lung function laboratories were almost completely closed. A lot of that was due to the risk, as she's talked about, of aerosol generation through the procedures that we do in lung function, where we make you cough and blow hard. But of course, the other thing is that the respiratory physiology staff are highly skilled. And in our case, certainly, many of them, if not all of them, were redeployed to ICU and acute respiratory units to help manage those. So it was a double whammy, really, in terms of lung function. And that's why it's been so difficult and it's taken such a long time to get lung function restarted. We had reduced imaging capacity, and many of you will have been aware of that because you may have had tests cancelled. And that was partly the demands from the COVID cases, because every patient needed a chest X-ray and many of them needed CT scans. But also, of course, because of infection control measures, including social distancing. So that just meant you couldn't have as many people in the department as once. You had to make appointments, you had to keep people apart, and you had to clean the facilities more thoroughly than you would have done previously between each patient. So that just meant we couldn't fit in as many people. On a more positive side, I think we made, in many cases, better use of community blood testing or phlebotomy. And some of you may have had recourse to home tests such as spirometry or blood tests, and that was very much up to community resources, facilities, clinician preference, patient preference, and so on. But there were some changes that some of you may have been aware of. In terms of management this year, of course, the big headline are the vaccines. We now have 3 approved in the UK. And I want to emphasize this incredible success, this headline figure of 82 to 95% protection against severe illness. And I want just to reflect on that, because we should really be celebrating and congratulating the people who've worked so hard on that. When I did a seminar or video for Sarcoidosis UK in December with Anna Blackney, I well remember her beautiful Christmas tree. She's a scientist who was working at Imperial College London, has now moved to Canada to set up her own lab. She told us that Pfizer, remember Pfizer, an American company with stretch targets, an eye on the bottom line. In April, Pfizer, April 2020, they set a target of 70% protection against COVID for their vaccine. So they would have been delighted if they'd had 70%. They've ended up with 95%, and that's a figure that's unbelievably good. So these are really effective vaccines. And the influenza vaccine, by contrast, has around 50% efficacy. But we don't agonize every year about whether it's worth having the flu vaccine. We do recommend it. So I'd just like to say what a wonderful achievement that was. And I know some of you have quite understandable concerns about whether the vaccines are safe if you're immunocompromised. There's no live virus in the vaccines, so they are safe for immunocompromised patients. We recommend every year that our immunosuppressed patients have the flu vaccine. And the flu vaccine has no live virus in it. The efficacy may be lower. There are studies showing that the influenza vaccine is less effective if you're on methotrexate or rituximab, but we still recommend it. And I'll come on later to point this out, but of course, if you've got 95% protection as a headline figure, we would hope that you would get protection, even if you're immunosuppressed, even if that efficacy is a bit lower. And of course, over 30 million now in the UK have now received their first dose, which is an amazing achievement. As Lisa mentioned, the UK shielding advice ended yesterday. Many of you will be very delighted about that, I'm sure. I would just touch on travel advice for the future. A number of my patients are hoping to travel. Please remember that it won't just be the UK government advice on holidays that we have to take into account. It will be the prevalence of COVID cases overseas. We're seeing what's happening in France at the moment, and of course, the presence of new variants. And some of those variants may be relatively resistant to vaccines. It should be perfectly possible to tweak the vaccines, but it may require a booster in the autumn. So we just got to be a little bit cautious about planning our holidays just yet, I think. In terms of changes in monitoring 2021 and beyond, I foresee that certainly for the moment, there's likely to be a hybrid model of consultations. I think we've shown that remote visits, in inverted commas, do offer convenience. You can often have a consultation with your doctor in the comfort of your own home. You don't have to travel to the hospital. You don't have to spend half an hour trying to find a car parking space and then find that the car parking machine either doesn't accept your credit card or you don't have enough cash. And of course, we've also shown that for many patients with long-standing respiratory conditions, there's a much lower risk from respiratory infection if we all stay apart a little bit. So that's a benefit. But of course, remote consultation is not always suitable. Not everybody finds it easy to use the telephone. And it's difficult to build up that rapport that you need if you're managing a long-term condition, I think, if you never see the person at the other end of the telephone. So I suspect there will be a mix, not least because we still want to keep our waiting rooms from becoming overcrowded, because we know that will increase the risk of community transmission, not just of COVID, but of everything. And I would hope that we can build better shared care with our community services. Many of our general practitioners have been fantastic in terms of offering local blood services and so on. And for many of you, that may be much more convenient than coming to the hospital. Changes in management, looking to 2022 and beyond. I think the recommendations on immunosuppression are likely to continue. And as I say, I think that makes sense and that's good clinical practice. Some trusts are using cloud technology to help store personal health information and allow you, the patient, to access your health records on your smartphone at any time. So you can have your scans and your letters and your blood test results available, and you can share that information with whoever you wish to. You can upload your own information. I think both with remote consultations and the increasing use of technology, it's really important that we build up good patient-clinician partnerships, because this has to be done in partnership with you, the patient. We need to know what you want, what works for you, and it needs to be tailored to your needs. Clinical research is absolutely vital. Pete's alluded to my role within the NHR. I'm the clinical director for North West London Clinical Research Network. We led on the REMAP CAPS study, which showed that dexamethasone reduced mortality significantly in seriously ill patients with COVID. We supported the recovery trial, and we've shown how important it is. So it absolutely needs to continue, and we need to think about taking part in research as part of our taking part in our receiving NHS care. You know, what can we do? What can we contribute? And we heard a lot about long COVID from Chris earlier. We heard a lot about fatigue in sarcoidosis from Chris earlier. And I'm really hopeful that some of the research into long COVID will give us a better understanding of sarcoidosis, and particularly strategies to manage fatigue, because it's been very difficult to do studies in fatigue in sarcoidosis. And you know, there is funding now for research into long COVID, and I think it's being taken seriously. So I'm optimistic and hopeful that actually we might understand more about fatigue in sarcoidosis as a result of long COVID. So what have we learned in summary? We know that immunosuppression increases the risk of catching COVID, but it doesn't appear to be linked to a worse outcome, which is encouraging. We've learnt that significantly impaired lung function, perhaps unsurprisingly, does appear to be linked to worse outcomes. Would we give the shielding advice again in the future? Yes, I think we would. I think it was the right thing to do. We had an unknown virus. We had it circulating at very high levels in the community. We had an absence of comprehensive testing or tracing, so we couldn't be sure where it was. We couldn't manage outbreaks. And I think it was the best way to protect people in the circumstances. It's possible that you could refine it with what we know now. And it's quite likely, of course, and I don't want to be to sound too pessimistic, but it's perfectly conceivable that we will have another pandemic in the next decade or 20 years. And of course, a different virus might behave differently. So we just need to be cautious about assuming that all viruses will behave like COVID. Encouragingly, I think because of the very high efficacy of vaccines, they're likely to confer some protection in immunosuppressed patients, which I think is great. We've learned that remote consultations can be effective. We've learned that all these measures, which we find rather burdensome, like social distancing and hand washing and masks and remote consultations, they are effective in reducing the transmission of common respiratory infections. And that's definitely going to affect how we review people in future and how we hold those consultations. The use of technology is going to increase, I think, exponentially. The NHS has demonstrated it can move quickly if it needs to. But again, engagement with yourselves, the patients, and community services will be absolutely vital for that to work. And clinical research is a lifeline. And I just want to thank everyone, every patient out there and anyone else who's listening, who's taken part in clinical research during this time. You have made a difference. And I'd really encourage you, if you haven't taken part, find something to take part in. If you want antibody testing, go and find a study where they're doing antibody testing. You can make a difference. And we've shown that it's a really important way to develop our knowledge, the only way to develop our knowledge about management of important conditions. So thank you.
That was another real masterclass, actually. And once again, you've gone through everything that everybody wanted to know. There isn't a question left that hasn't been covered, even in the chat, which you didn't know was going on. So that was perfect. And I'm really grateful to you. I'm grateful to all the speakers who have given up their time to speak in this last session. I think it's been a really, really comprehensive session. It's really hit the full breadth of what we wanted to know about the most challenging aspects of managing patients with sarcoidosis and patients understanding, I hope, more about the challenges of their condition and how to drive forward their care in a way that allows them to be very much at the center of everything that happens to them. And I'd like to echo Rabina's final point about the importance of clinical research and how each one of us can be an individual that is part of a very strong team in improving outcomes for people with these conditions. And the conversation about fatigue and long COVID is a particularly interesting one, which has got a number of times in the chat. So thank you for addressing that, Robina. There is a 7-minute break. It's now 6-minute break, so I will let you all go and get a coffee. I'd like to thank you all for staying on this long, and we've got a very exciting session on clinicians and patients' experience and future research aims next. Okay, thank you all. Bye-bye.
Vasily, hi.
Hi, Paolo. Very well. I will start the session. So thank you very much for attending, Paolo and Filippo from Italy. It is a great pleasure to have you. I would like to introduce Professor Spagnolo, who, apart from a very good friend of mine, he's a professor at the University of Padua. He is a WASOG Executive Committee member, and he has been recently elected as the next Sarcoidosis Group President in the European Respiratory Society. I've asked Paolo and Filippo, who is a patient advocate from the Italian Association, to describe to us the challenges that they are facing with the diagnosis and management of sarcoidosis patients in a different country, and see similarities and differences with ours. So Paolo, over to you.
Vasily, thank you very much for the kind invitation, and thank you all for being here today. Well, to me, it's always a pleasure talking about sarcoidosis and having the possibility to discuss with patients even more than with colleagues. The main challenge, Vasily, I mean, at least to me, is managing, and is also the scarcity of drugs. So the biggest obstacle or the biggest challenge to me is the development of novel drugs. I mean, we did something with a couple of colleagues last year. We reviewed all the molecules in development in sarcoidosis. I barely remember one molecule which is being developed specifically for sarcoidosis. It is either a repositioning of drugs approved for other indications, or the same drugs which we use now with all their limitations in, let's say, different settings and so on. So this is one. And also how to move forward with development of novel drugs. That's another big question to me. So how do you assess response to treatment? How do you assess disease activity? And even when you see disease activity and the novel molecule is reducing disease activity, is that clinically relevant? So in terms of diagnosis, if I compare with, let's say, 20 years ago, I think we definitely know more. We are probably more capable of excluding alternative diagnosis, but the big challenge, at least to me, is management. I mean, you guys are the greatest experts on how to manage, but the therapeutic options that we have, unfortunately, are limited. So to me, the biggest challenge is development of novel molecules. I just want to say one more thing, and then I'll leave to Filippo for his comments. Research in sarcoidosis requires much more than in other conditions, collaborations. I mean, you do need big numbers, but you do need the right, let's say, representation of clinical phenotypes. I mean, 200 patients with sarcoidosis is not 200 patients with IPF, in which you do have heterogeneity, but not as much heterogeneity as in sarcoid. We do need more representation of phenotypes like, I don't know, skin sarcoid, neurosarcoid, cardiac sarcoid. You are a master on that. And this, to me, can be reached only through collaborations, which is what I'm going to foster as a chair of the study group in sarcoidosis for DRS. These are just 2 or 3 topics which, to me, at least to me, are relevant.
Thank you, Paolo. Do you think from your end that there is any way in actually enhancing industry or pharma interest into sarcoidosis? And if you have any ideas around that?
Well, you know what, Vasily, the industry, I think, have interest in sarcoid. I mean, I've been involved actually 2 days ago as well in companies, in meetings with companies that are trying to develop drugs for sarcoidosis. I think the interest is there, but the big questions remain unanswered. For example, how do we assess response to treatment? What do we really want to treat? what is the right phenotype? Do you want to look at all comers, or you want to look at pulmonary fibrosis? And if you look at pulmonary fibrosis, should we be using FVC as in IPF? But IPF is different from sarcoidosis. So I think the only way, or one of the ways to answer these questions, is to have a larger number of patients, to have international collaborations, and obviously, I mean, patients on these are vital. So the interest, I think, is there, but they probably need some answers from us to move the field forward, because the problem is that you may run the risk to discard a drug which may be somehow effective, is just you're not looking at the right population of patients.
That is an excellent thought. And do you think, from your interest, it was mentioned earlier during the day, but do you think that there is a possibility that we will reach a point where we're talking about genetic predisposition and identify whether there are groups of patients that are more likely to develop sarcoid?
Well, I mean, as you know, at the Brompton, we did some studies on this. I mean, the genetics is definitely there. Particularly, I mean, the strongest association described until now is with the so-called DR3 genotype and Löfgren syndrome. So genetics definitely plays a role. This is kind of established for acute and often self-resolving sarcoidosis. Whether this applies to specific phenotypes, the answer is probably yes, but we're not there yet. Let's say we don't have the same level of certainty as we have with Löfgren syndrome. But again, in order to have, how can I say, a reliable genetic study, we need numbers, and more than numbers, we do need phenotypes. That's what we need. So large number of patients and well-defined phenotypes. Otherwise, sarcoid is not a disease in which you can find an association unless it's extremely strong, which is, I can anticipate this is not going to be the case. But the predisposition is more likely to be present with specific organs, which can be skin, uveitis, as in some Japanese studies and so on. But you can do this only with large numbers. That you cannot do otherwise.
And just to come to a more recent issue, which is COVID, and it has been mentioned before. You have obviously large experience in Italy as the country hit the most in the first wave. Do you think that first of all there is what your view is about the entity of long COVID, and whether you think that there is any association between COVID and sarcoidosis development?
Well, as you said, Vasily, unfortunately, we had to become expert on this. Now we've been doing the follow-up of 500 plus patients, and long COVID is there. I mean, we do see long COVID in approximately, I would say, 50 to 60%. I mean, and there is a percentage of patients who are complaining of exactly the same symptoms as when they had COVID. The only difference, and a huge difference, being that now they're negative, whereas when they had all these symptoms at the beginning, they were positive to COVID. In terms of sarcoidosis, I think the patients are well aware of the risk, and so particularly if they have extensive pulmonary involvement. I have to say that in my experience, obviously I can talk about my 700 or 800 patients, so I don't know how many they are. And I did, for example, with IPF, with the idiopathic pulmonary fibrosis, was completely different. I mean, I had a number of patients who unfortunately died after catching COVID. With sarcoidosis, irrespective, I would say, of whether they were on treatment or not, I did not personally see a higher, let's say, prevalence of infection, or definitely not clinically relevant disease in patients with sarcoidosis. I don't know whether you touched on this before and what your experience is, Vasily.
We had similar experience here, and I will say this more publicly. It was one of the things that we were discussing with Athol as to whether actually steroids were in a way protective against COVID for patients that were actually immunosuppressed. So we were having discussions around that issue. I think one of the main interests that patients have had is because long COVID is primarily characterized by fatigue. They are concerned as to whether this actually represents a form of sarcoidosis, and this has been mentioned during this day. So that was another area that I just wanted to see what you think.
But I always want to say something that in our country, for example, the number of patients on biologics is relatively small due to the difficulties in prescribing these off-label medications. So when I say treatment, I would say for 95% of my patients, I mean either steroids or methotrexate or azathioprine or these kind of drugs. I mean, we don't use that many biologics. With regard to fatigue, I mean, if I have to say from a clinical standpoint, what is the largest, the highest unmet need? I think we spoke about this a few days ago. That is definitely fatigue. So in patients with sarcoidosis who get the COVID with the post-COVID, and considering that a large minority of patients with sarcoidosis complains of fatigue, that is gonna be an issue, I think. And again, I mean, we do need research on that, because what we find very interesting is that patients with COVID, in post-COVID, I mean, they complain of fatigue despite rock steady lung function, chest X-ray, which has gone back to normal, and normal oxygen saturation, normal physical examination, and so on. So there must be something which I'm not sure we're missing. Probably we are not investigating properly, something to do with the muscle, for example. So we definitely do need more research on that as well.
Thank you very much. And so Athol mentioned earlier about the ERS task force with regards to guidelines for treatment in sarcoidosis. Are you aware of any further activities within the ERS group that are planned in the sense as information for patients primarily and their physicians?
Well, I'm obviously I cannot wait to see the document on treatment published, because at some point I was involved in the revision of the document, but a very, very preliminary stage. And with regard to other initiative, I think what we definitely need, and this is what I will definitely advocate or try to facilitate, is a document, and I want to go back to what I said before, on endpoints for clinical trials in sarcoidosis. I mean, in other diseases, because we tend to do the parallel with IPF each time, probably FVC is not ideal, but at least you have two drugs which have been approved based on FVC. We don't have the same, I wouldn't say level of certainty, because that's not certainty, but we don't have, let's say, something as reliable in sarcoid, but we need to sit around the table to see what the evidence is, what the data is, and come up with a consensus of what can be a reasonable bunch of endpoints for clinical trials. Because going back to your question, that's the way we can facilitate research and interest from the pharma, because the interest is there. They just want to us, they want to know from us what they should be looking at. And to do this, we need data, and while we're waiting to collect data, we need to have at least a kind of expert opinion on this. And obviously, I mean, we should involve patients as much as possible, and we'll hear Dr. Filippo's view shortly, and younger colleagues as well, because the main problem with sarcoid, which is why I'm so fascinated by sarcoid, is that it is a real neglected disease. So we should do as much as we can, the best we can, to, let's say, rescue sarcoid and sarcoidosis patients from this, because they definitely deserve more.
I think your points are, to be honest, very well taken. And I'm really grateful for your input. I hope that we have a very close collaboration moving on, and we both know that we are discussing about trying to identify the right study and the right design of bringing some answers to these questions. I will move on to Filippo, and I would like to thank him very much for joining. I strongly believe that sarcoidosis patients are not different, irrespective from where they come from. They may have different manifestations because there might be some genetic predisposition, although I don't think that this really stands between European and Italian patients versus UK patients and British. But Filippo, I would like to hear your views with regards to sarcoidosis in general, the patient's views in Italy, and how have you been dealing with COVID nowadays?
Okay. I thank you, and I thank you all thank to me for this speech in this fantastic day. I find it that a great opportunity to share a lot of fantastic idea for collaborate and work to grow up all this movement. I'm Filippo Martone. I'm the president of the National Italian Association of People Suffering of Sarcoidosis, that is founded in 2011 and is made of people with sarcoidosis, their families, doctors devoted to defeat this disease. Today, it includes over 200 members among patients, physicians, researchers, and caregivers. More than 4,000 people collaborate with us via web and in other ways. Changing things has been in our mission since 2011, and information and diagnosis, treatment and access to care, policy and research are the main focuses in which our mission develops. The objectives of our association is help sarcoidosis ill people through the arrangement of correct services, to promote up-to-date research, to speed up times to diagnosis and to improve and expand treatment chances, and urge the institution to properly organize the disease, medical and social taking charge. How we do it? We assist people creating a construction communication between doctors and assisted citizens through an appropriate web and telephone service over the national territory. We represent citizens to approach institutions, reporting and resolution of state of difficulty from the single citizen to the Italian struck by sarcoidosis as a whole. We represent a secure information reference through the selection of reliable information sources and the reporting of false and fraudulent information. We promote the research, stimulating scientific and research societies challenging objectives to pursue. ERS, ATS, ELF, WASOG, FSR, and all Italian societies are currently involved by us in our stimulating opera. Raising awareness among expert centers of support for sarcoidosis research is almost doing along the whole country. Uniting clinicians, researchers, and patients on common objectives by means of our official magazine, that is Focus Sarco, and School of Sarcoidosis, that is days like today. We did along all the country 3-4 times or 4 times a year, or by through the web in this pandemic time. Also, we create a national database of life with sarcoidosis experiences to create a sarcoidosis culture. We encourage the institution, thanks our firm commitment to urge governmental institution. For 4 years, sarcoidosis has been recognized as a rare disease, and included among these pathologies was patients can benefit from completely free healthcare. In more than few regions, major hospitals have been introducing multidisciplinary care pathways for diagnosis and treatment of sarcoidosis. Naturally, in the last year, we face the pandemic, as you told a while ago. It becomes a very tough moment. In February 2020, pandemic break through our cities and our people. Our association immediately established a direct link with the Italian Ministry of Health in order to protect people with sarcoidosis. In particular, we transfer doctors and researchers' suggestions to direct to the ministry in order he can take the adequate decision on what to do for these people. The same things regarding Ministry of Labor, because obviously Sarco people has to stay safe at home, but to also to keep their work and keep their salary safe. But also we felt a great need to discover more about this situation between COVID and Sarco. And there was a great opportunity, thanks to the Professor Bob Bofman, that asked us to participate in a multicentric international study that involved other countries. We had received questionnaire, web questionnaire that we translated in Italian, and we published in two different times, in April and in July, we and all the country involved. A lot of people did that questionnaire, over 823, but other people as enrolled by two university hospitals. And this teaches us a very important thing that is, I think, Paolo talked to us before. Over 5 people with sarcoidosis in Italy answered this questionnaire, estimating that 6,000 people with sarcoidosis lived in Italy, more 1,000 answered. If you consider that 10 years ago we have 12 members and 50 people following activities, now we have in a position that we can interest a lot more people, almost all the Italian people with sarcoidosis. And this is a great opportunity to develop work with doctors all together to obtain results in the way Paolo said before. We did this multicentric international study from idea to data collected in 4 months. Also, if we work with community and non-community associations, American, Dutch, Spanish, Italian, work together very smoothly. We received some data that almost told us the same thing you told before. So the sarcoid people in that period, because we feel that now is different, in that period suffer of COVID almost in the same way that normal population in Italy. All this work is published in the end of 2020. This is the scientific work. But we felt the need to do a first step because we felt different situation now for the people with Sarco and COVID. So let's see, we will start a third step in some 10 days, I think. At the same time, we are working with the Ministry of Health for vaccinate Sarco people. At the present time, there is no possibility for Sarco people to be prioritized in front of the other population, but I think in a couple of weeks this will be possible. So this is our little experience. I hope it can be useful for you, and I am very grateful to be there and to hear all of you. Fantastic speaker. Thank you.
Thank you, Filippo. I think it is a great presentation, to be honest. I'm really interested to see the growth that you have had in such a limited time period. You have done really well. I think what you've showed us, the questionnaire example, is an example that there are many studies that are primarily driven by patients rather than doctors. And I think that this is a new step, and actually technology, as it has fast forwarded nowadays, given the COVID pandemic, it allows for further collaborations between the patients. I think that what we need to be mindful is that the right channels of communications are made, because we wouldn't like any of these initiatives to be lost into translation. So I think that the clinician's input is critical in that sense. I just wanted to touch base on the fact that you mentioned that patients with sarcoidosis are facing some difficulties in accessing healthcare in Italy. Do you think that this is a problem, or?
Oh, it was obviously it was a problem. We now help the centers who ask us help to build up remote visiting. Okay, in between the second and the third wave, we had the possibility to see a lot of people with Sarco gaining access to the medical structures, but nowadays we are in the very middle of the third wave, and there is obviously some difficulties. Even if colleagues you are trained to face this situation, and they work very hard, like the face of Paolo can testify, to cure COVID and cure sarcoid, and we don't have the same problem as the first wave or the second. This is obviously a problem that can teach us that the service for rare pathologies has to be keep safe from this great pandemic situation or great situation, because these people are very difficult pathologies, difficult because, as Paolo said, we in Sarco have very different phenotypes, and we are in the need to have a very trained, well-trained doctors to manage them, and if they are taken away for manage all the other people, we are alone. So we have to work hard with the advocacy and the policy to preserve this situation.
Vasily, can I say a couple of things very quickly?
Yes, please.
The first is that Filippo has been the driver of most of what has been shown. I mean, Filippo has been tremendous in developing and moving the field forward. This has to be said, because many of the patients or many of the people who are here know Filippo, but probably not all of them. So this has to be said. It's been great. With regard to the vaccination, in Italy the situation is kind of heterogeneous, and now, which is good news, and this has been couple of weeks ago, the Regione Veneto, which is the county, the region that I'm working in, is asking each of us interested in rare lung disease to give them a list of people, of patients who deserve, let's say, or priority in vaccination. And obviously, I've given the name of all my patients, irrespective of sarcoid patients, irrespective of disease severity or organ involvement. So probably in the next couple of weeks, most of them will be vaccinated. The problem is that this situation may vary from region to region. Yeah. But at least there is how can I say, the appreciation that patients with sarcoidosis are among those who deserve a priority.
I think one of the things that this event and other events that will come are aiming for, and I think that, Philip, it would be a great opportunity for you to actually gain experience with Sarcoidosis UK, who has been tremendous support to us and also all the sarcoidosis patients in the UK, is that I think that patients with sarcoidosis are actually neglected. The majority of the patients are considered to have a benign outcome. As Paolo said, there are not many patients, there are not many medications for them. The majority of the medications cause side effects, and this is a problem for the patients. They're not using blood pressure tablets as such, but they are causing medications that affect their immune system and have various side effects. So the important bit is that we as a team, we recognize that although sarcoid is indeed a benign condition, there are certain forms of sarcoid that are really dangerous, and we need to be very mindful of that. There are patients that end up having transplant and having a very hard time. There are others, although that they do not have, as Athol has said, they don't have a disease that is dangerous for their life. They have a disease that is actually disabling them, and they cannot really work. They cannot look after their loved ones. So it is absolutely our responsibility to try to do the most of we can, either as a charity or as doctors focusing on that. I think the more that we discuss, the better it is. And I must say that I'm really, really happy about the fact that sarcoidosis specialists in the UK, but also across the world, are very friendly. They don't really care about their promotion, but they do want to actually look into the scientific aspect and improve as much as possible. I'm very thankful to Athol, who has actually showed me the channel to get in communication with Paolo and other colleagues. Unfortunately, Hilario Nunes, who's another colleague from France, was not able to attend to describe the French experience, but I'm very thankful to you all for coming to this session today, and I hope that we have a long-term collaboration.
Sure.
Vasily, I think we had this conversation before. A collaboration with you guys. I mean, you are one of the largest and one of definitely the best centers in the world. But the collaboration has to take place across Europe. I mean, even a large and experienced center like yours needs our numbers, our patients, and our experience. That's all we need. Heterogeneity is such that if we don't decide what patients we want to look at, and you can do this only with large numbers, this will drive us nowhere. And to me, there is collaboration going on, but we need to reinforce this. And if I can do something with the ERS group, that's definitely what I'm going to do. Promote collaboration, try to involve young colleagues, because I mean, to do the sarcoid clinic, you need passion first of all. I mean, don't get me wrong, it's all difficult, but with sarcoid specifically, you don't know the cause, it's difficult to manage. Sometimes you feel kind of guilty that you're not doing enough for patients. So what you need is a huge and endless passion. That's all we need. Which is why probably we are not only colleagues but good friends.
That's absolutely the case, Paolo. Thank you very much. I know that Athol is on the call and he's going to be the chair of the next session. I don't know if he would like to comment at all, if he has anything to add.
Vasilis has a habit of ambushing me from time to time, so thank you for that, Vasilis. Yes, I just have to reinforce what Paolo says, and I'll give you an example. There's a worldwide initiative now to separate lung sarcoid into separate, we call them phenotypes, separate disorders based on radical differences in CT. And I think if that's going to be explored, and I think if we then go on to look at genetic associations linked to individual triggers, linked to particular patients, we can't do that without the gift of numbers. And we're going to need to invite thousands of patients to take part in research. We're really entering key stages now with these growing collaborations where we have huge opportunities, and it's people like you, Vasilis, and you, Paolo, that will make this happen at the end of the day. So I can only support what you've said, Paolo, and only congratulate Filippo on what he's done. I've really got nothing else to add, I think.
Thank you very much. Thank you for joining. We will give a 5-minute break and we will join at 3 o'clock for the multidisciplinary meeting simulation.
Thank you very much. Thank you all. Thank you, Vasily.
Sujal, you may be interested to know that we've got I don't know how many people we have at this later stage, but there were 1,200 people, I understood.
Okay.
Were early, so.
Is that why you've combed your hair as well, Athol?
Thank you for that. It's nice.
Well, I don't have any hair, so you know.
So it's nice to have some.
Yes. Okay. Very good. Very good. So listen, Vasilis and Athol, I've anonymized these cases. Which is quite a task actually, and it's a bit of a pain. So, and we put them in the order that I've said. If you change the order, we're in trouble because there's no way of deciphering which patient is which. So patient 1, patient 2, patient 3, patient 4, patient 5. Vasilis, you got that email, right?
Exactly.
Okay, so you can only present it in that order. Otherwise, we're going to be really stuck. And I'm going to do patients 1, 3, and 5. Anand is going to do patients 2 and 4.
I would. I'm just waiting to see whether others will join. But overall, I would like to present the members of the team that have not presented so far. So Professor Zai is one of our radiologists leading the sarcoidosis studies in sarcoidosis. Thank you for that, Sujal. Professor Anand Devaraj is another member of our multidisciplinary team, also radiologist, with high experience in sarcoidosis too. And we have Professor Andrew Nicholson, who's also our histopathologist. And the main benefit from all this is that we are all sitting together, or we used to sit together in the same room, exchanging opinions about cases and their diagnosis and management, which is unique for everyone. I wanted to actually make a simulation of this meeting, because I think that this is for the benefit of the patients to understand a number of discussions that we are having in the backstage, and how difficult it is to have a clear management plan. Some of the questions raised over this session may also be answered during this meeting. So I will get on to present some of these cases. Also, just to say that we usually allow Athol and Sujal to exchange comments between each other.
We usually don't need much of an invitation.
I think the right word is insults, actually.
So the first patient is a 46-year-old gentleman who is an ex-smoker with a 5-year smoking history. He had a COVID infection in March of 2020, and then developed prolonged cough, breathlessness on exertion, and fatigue. His blood test showed mild lymphopenia. He had raised liver enzymes, for which he had an ultrasound of his liver. And his ACE was slightly elevated to 77 units per liter. This is not the right order, but I have given you the ultrasound of his liver, which actually showed that the liver was diffusely heterogeneous with a smooth contour, and the spleen was also diffusely heterogeneous. He had lung function tests that showed a gas transfer, which was normal. This was 91%. And he had mild airflow obstruction in his spirometry with an FVC and FEV1 of 127% and 84%, respectively. He had significant small airway obstruction, as is judged by his lung function profile. So, Sujal, I would like you to comment on his scan. This is the information that we have.
Okay, so I'm going to stop you sharing and I'm going to share my screen. And this is patient 1 or patient A as you've labeled it. I'm just going to enlarge it. Can everyone see that screen? I can see Elizabeth nodding, so that must mean they can see, everyone can see the screen.
Yes.
So what I see here is a relatively classical combination of findings in that there is lung disease and there are some enlarged lymph nodes. We'll come to the latter later, as you might say. The radiological pattern in the lungs is that of essentially of nodules. And the nodules are, some of them definitely have a subpleural distribution. This is the fissure here, and the fissure, as we know, is a pleural structure comprising 4 layers of pleura. Other nodules are very much in the sort of bronchocentric region, and that word bronchocentric is important. And other nodules don't really have a sort of distribution. They seem to be a bit random. However, most of the nodules are in the mid and upper zones, and that's another aspect of distribution that's important. So this is classical nodular parenchymal sarcoidosis, lots of micronodules. And then I said the lymph nodes were enlarged, and short of going on to a separate reconstruction, I can see roughly symmetrical hilar lymph node enlargement, subcarinal lymph nodes, and other mediastinal lymph node stations. So this is what you might call radiographically stage 2 disease. I don't see any signs of fibrosis.
So Sujal, can we draw you out into what I think will be the discussion point here? You look at this scan. Is there any other diagnosis than sarcoidosis that you think is sensible or plausible?
Not based on the imaging, but I suspect through a clinician's mind, a question, particularly if there's symptoms, a clinician's mind.
Just on the imaging.
On the imaging, there is no other diagnosis I would think of.
Okay, so now let me address this to the decision that you might be taking on whether or not to do a biopsy. Forget the medical jargon. We've heard that a very skilled leading international radiologist is unable to suggest an alternative diagnosis. So I see Elizabeth and I see Phil in the names there within our team, and I'm going to ask each of you to state a view, and please proceed.
So I think when you have this this type of very classical pattern for sarcoidosis, as Suja has described, with symmetrical lymphadenopathy, the micronodular pattern along the bronchovascular bundles, along the fissures, I would say that there doesn't seem to be the need to go for biopsy in this case. I don't know what the relevance of the COVID history and why, what that has to do with the case. But if we're going just on the imaging, I would be happy that this is consistent with a diagnosis of sarcoidosis, and that if the clinical features fit and there is no other concern, unless Suja is saying that there is something that worries him about this not being sarcoid, I think I would be happy to go without a biopsy.
And to ask Phil Molyneux to comment, would he share that view here?
I would completely share that view. The imaging is quite typical for sarcoid, and unless something in the disease behavior over the coming months was to change, I wouldn't go for a biopsy at this point in time.
I think we have a fairly firm statement from 2 people here, which actually moves away from the historical approach. I suppose one is candid with the patient and talks through the likelihood being greater than 95%. Some patients will feel that if it's not 100%, they really want a biopsy, but I think most people have a sigh of relief. You buy into looking at this closely, and you don't undergo an invasive procedure. The COVID is an interesting question. Elizabeth, you didn't provide an answer. I'll have a quick go. We know that COVID triggers a number of autoimmune conditions. That's one of the things it does. Auto-inflammatory might be a better word. So it would maybe not be surprising with some of the inflammation pathways that COVID triggers if occasionally it turns out that it triggers sarcoid. I can give you a list of 6 or 7 autoimmune conditions that seem occasionally to be triggered by COVID. Okay, I don't think we think this is a post-COVID profile on the scan in its own right. Any other comments from the group at all, or should we move to the next discussion?
Prof, I have a question, we mentioned that this patient has mild airflow obstruction. He does have some raised hepatic enzymes, and he has the CT scan. On the basis that we have given him a diagnosis of sarcoidosis, would you treat this patient?
No, I most certainly wouldn't right now based on danger. The lung function reserve is excellent. We have very robust data now that when your gas transfer and key lung function tests are as high as this, you have to get an awful lot worse before you fall into a danger category. Now, make no mistake, this can be hard sometimes, but the lung function reserve is so great that I wouldn't want on danger grounds to subject this patient to immediate treatment with potential side effects. Obviously, if you have full inactivity, you must have cat-like observation. You've got to look hard, you've got to watch hard, and maybe quality of life will drive a treatment intervention. Elizabeth.
Yes, so I was just wondering about the liver and the findings of the liver and whether they would require any further investigations. And we know that irreversible liver damage is rare in sarcoid, but can occur. Would that, would we be?
Well, I think the issue here is that probably if you routinely biopsy the liver of every sarcoid patient, you would find evidence of, in inverted commas, liver sarcoid in 70+% of patients. A smaller group have some liver function enzyme elevation, but certainly in the liver world, the view is rather skeptical about intervening until you have quite a high burden of disease. And I think one of the issues, if you do get more severe involvement, is liver involvement by itself enough of a reason to treat? Now, I would not have said from this level of liver function disturbance that you've got an immediate reason to do that. We see too many patients who do have this in the first flush of sarcoid, and it does settle down. But it's something else you certainly watch closely, I agree.
And I guess I was going for the CT report, which I may have misinterpreted, that there were some abnormalities or irregularities but I may have, I didn't catch it well, whether there was any sign of major abnormalities on the CT, but there wasn't, Vasilis. Did I get that wrong?
We mentioned about abnormalities or some heterogeneity identified in the ultrasound of the liver and the spleen.
Okay, ultrasound, fine. Okay.
You will get some variation in density when you have sarcoid involvement in the liver, but I don't think we're seeing anything that would drive us to risk poisoning this patient at this point. And I mean, if you're giving a drug with side effects that you don't need, that's not a bad definition of a poison. So personally, I'd watch closely and wait.
Okay, Sujal, I will move to patient 3 to allow Anand to give us a comment, because we may have to discuss less than the number of patients that I emailed you. So this is a very young patient, 35-year-old gentleman, ex-smoker with 10-pack years smoking history, who was given a diagnosis, who had a biopsy-proven diagnosis in 2015. He was referred to us 4 years later He has, when he was referred to us, he was on steroids 20 and methotrexate 12.5. He was oxygen dependent on 4 liters and was able to walk 50 meters on the flat. His blood test showed mild lymphopenia, raised ACE, and mildly raised D-dimers. BNP was normal. His lung function showed a mixed pattern with primarily restrictive, with an FVC of 58%, FEV1 53%, and a DLCO of 24%. I'm sorry, you're in front of it. Of 24%, yes. So, Anand, would you mind describing your imaging?
Well, patient 3, because Anand and I have opened up cases. I've opened up case 3. Shall I do it?
Yeah, sure, sorry, yes.
Okay. So patient 3 has got 2 studies. And
yes.
The first study is from 23rd of July 2019. And I'm just going to scroll through so you just get a flavor of what we're seeing. So right down to the bottom, then go back up. And although the eye is drawn to the upper zone, so around here where there is very marked bronchocentric fibrosis, another very striking feature of sarcoid is the way that the airways and the vessels are pulled backwards when they get fibrosed, or when there's fibrosis laid around them. And that's a sort of classical finding. So if you were to draw a line across here, the bronchovascular structures are pulled backwards. And that's a very telltale sign, I think, of sarcoid. Even down here in the lower lobe, this is the right lower lobe, again, there is very marked bronchocentric fibrosis with traction bronchiectasis and bronchiolectasis. But the rest of the lung away from that is also abnormal and comprises, and these lungs are of higher than expected density. And the reason we know that is if you compare the air inside those airways, you can see it's different. And the air in the lungs should be roughly, or not exactly, roughly equal to the air inside the airways, and it's not. So in other words, there's quite a lot of diffuse infiltration in the lung, quite aside from these areas of very, very abnormal fibrosis. And another sign which I think you sometimes do see is what I've started calling the reverse signet ring sign. And it often goes with this combination of very bronchocentric fibrosis, this posterior retraction. And then what you see is, as I said, the reverse of the signet ring sign, whereby the vessel is bigger than the accompanying airway. And whether that reflects pulmonary hypertension, I don't have proof for that, but it is something that I do see in sarcoid.
So can I briefly translate into English just a few things? The lung function shows that this is really nasty. The level of severity is quite a bit less than a third of the lung efficiency is left right now. Sujal, you're describing both very nasty scarring in places, but you're also describing something that is a good deal wider than that, which is not necessarily scarring. So I think you're saying there's a mixture of abnormalities here. Can I ask you, if you look at that scan, are you certain this is sarcoid, or are you actually more, it probably is?
I'm fairly certain this is sarcoid, because, and really it's because of these upper zone abnormalities where this very classical bronchocentric fibrosis and this posterior pulling back, which I think you do see in sarcoid.
Now you mentioned something called pulmonary hypertension. That means potentially this is so severe on the scan and lung function that there is pressure on pulmonary blood vessels from the severity of disease. And shall I make one more point? When you actually translate all of this, you are looking to need to look at treatment fairly urgently, right? And we'll come to that in a minute. But this does mean that you have to be that much more secure about diagnosis if you're going to be embarking on a fairly heavy-duty treatment based on the diagnosis. So let's, Vasilis, continue.
So my question is, you've answered, I think, the first question, whether the patient needs another biopsy. Do you need any further tests before deciding as to whether this patient requires any change in management?
And again, I think this should be put to other panel members. So Elizabeth, Phil, please express a view. And
yeah. So basically, as Suja was mentioning, the reverse signet ring side, so looking at the vessels, they seem enlarged compared to the airways, whereas there should be the same diameter. The pulmonary artery was bigger in diameter than the aorta, another suggestion that there could be pulmonary hypertension. And we saw from the lung function that the KCO is significantly reduced, which is a lung function parameter, which in the absence of emphysema could suggest pulmonary hypertension. So I would want to look at non-invasive measures of pulmonary hypertension, such as an echocardiogram, BNP levels, a 6-minute walk test to look at the level of oxygen desaturation, and then decide whether actually this patient needs a right heart cath to measure more precisely the level of pulmonary hypertension. And that's because in sarcoidosis, we know that at least for some patients, the treatments for pulmonary hypertension can help.
Okay, please proceed. Or unless Phil has a comment.
No, I would agree. I would not be doing any further biopsies here or anything else. The radiology is convincing, along with the serological tests.
And biopsy might be rather dangerous here, I think we'd agree.
A biopsy would add little and provide a lot of risk.
So Elizabeth, the patient was already oxygen dependent. His echocardiogram and cardiac MRI did not reveal any signs of pulmonary hypertension. He did desaturate when walking, had severe gas transfer impairment. So a decision about treatment.
Again, my colleagues, so I'm not sure if Peter George is with us, but again, Phil, perhaps you go first on this. Elizabeth, you follow.
So at this point, I think the initial therapy is likely to be more aggressive with a view to trying to get on top of the disease as quickly as we can. If there's any kind of reversibility or major improvement we can make, we want to do that straight away. So rather than the last case, which was watchful waiting, this is almost the opposite, where we're dashing in to try and make some change. So that would probably be with steroids and with a second-line immunosuppressant right at the start. So methotrexate, we may add in some pulsed steroids to try and really kickstart this. That would just be a discussion based with the patient, really, what they wanted. But I'd certainly be going on with 2 drugs right at the beginning to try and maximize any benefit.
Any comment, any addition to that, Elizabeth, at all? We seem to have studied silence.
Yeah, no, sorry, I was muted. So I agree with Phil. I think you would want to see in the quickest way possible whether there is still some reversibility. And sometimes the only way to do that is to treat intensely and IV methylprednisolone, so a drip treatment with very high doses of steroids just for 3 days, followed by a tapering dose of oral steroids, is the quickest and probably the safest way to do that, and to see if there is reversibility and the degree of reversibility. And that would represent your new sort of aim to maintain in terms of, for example, lung function.
The main challenge was that this patient was already on steroids and methotrexate.
Yeah, I heard that about the methotrexate. You would probably still want to, but of course, you know, we can hear what the others think. He was just on 10 milligrams, right?
He was on 20 milligrams of steroids and 12.5 milligrams of methotrexate. And just for the interest of time, we did perform a PET scan on him.
Very good point. Yes.
Yeah. But just to say, I mean, at 12.5 milligrams of methotrexate, that would have been increased straight away, and probably still a pulse of steroids on top of some oral steroids would have probably been our first line therapy while we wondered about either switching off methotrexate or adding in other immunosuppression. But I still think we would have gone with a pulse of steroids and a rapid escalation up towards 20 of methotrexate.
But I guess the PET, I agree with that, but I guess the PET would be useful, wouldn't it? Just to show whether there's still activity, yeah.
Just to say that we did the PET, we gave him IV steroids, just to show you very quickly. So we did the PET, which showed some activity within the lymph nodes as well as the fibrotic areas. We did give him IV steroids, but the main challenge was, and we referred him for transplant. The patient, this is his serial lung function test, where he had some response originally in DLCO values, but then went back to similar levels, 25% of gas transfer values, and his FVC continued to decline. The patient was rather disappointed by what was happening, and he stopped treatment altogether.
So, Vasilis, it is possible the treatment slowed or arrested decline rather than achieving a response. We'd accept that much. But you're now taking us to transplant, I think.
Yes, and I'm now taking you to, he had a repeated PET that showed increased activity within his lungs and fibrotic areas that I think was the main reason for reinstituting therapy. So even in a patient who has end-stage lung disease, high level of immunosuppression didn't really help, but it did stabilize things. So we need to comment on whether treatment in fibrotic patients is actually achieving improvement or what is the target there. I will leave this for you to comment.
Well, what I would say is that in areas of scar tissue, if you don't have PET signal, I'm not clear that the treatment is likely to achieve much. But we're not yet at a stage we can use PET exactly like that, I don't believe. And I think most of the time we hope for response, and we often, somebody in this situation, hope more for stabilizing things and giving us more time. And sometimes a small improvement is a very big thing if somebody is really on the edge of their reserve. So even small gains can make all the difference in the world on all sorts of levels. So I would not routinely at this point use PET to drive the treatment approach. But I know that there's a lot of variation in that around the world.
The main reason for using it was the fact that he stopped treatment. But the important bit comes next, which is January 2021, when the patient is transplanted. And Sujal will show his current scan.
So this scan I'm about to show you is from 21st of January of this year. So these are the new lungs, as it were. And clearly we don't see all that abnormal disease that was previously present. There are some pleural effusions, I guess, any to be expected. There are small pneumothoraces. Again, I presume this is relatively recently transplanted because there's also an indwelling catheter on the right-hand side. So this must be immediately, well, not immediately, but in the relative immediate post-operative or post-transplant period. There are small effusions. There are some thickened interlobular septa, probably representing a degree of interstitial edema, but clearly a new set of lungs.
Yeah, I must say that the patient is of oxygen, as you may imagine. Yes, he's using medications, but he's very well. You can see that, of course, he's very young. He's 35 years old, but he has done remarkably well post-transplant. We're very happy for him. And in actual fact, I think looking in retrospect, we may have actually given him treatment to bridge the time of his presentation until transplant, but it's a lot of discussion around that issue.
Well, that's, if the patient was describing worsening breathlessness in the time immediately before coming to us, and then you see there's a period of complete stability on lung function, I think you've got as a fair bit that maybe the therapy has at least temporarily bought some time. Now, that's all I would say about that. It's a fair assumption that it's quite probable.
Would you mind staying for having one more? Let's do patient 4, just because of the interest of time. I know that everybody's very busy, but I think it would be nice to do this patient too. So patient 4 is a 42-year-old lady, non-smoker, who was referred to us in 2020 due to cervical lymphadenopathy and systemic disease symptoms. She was also diagnosed with fibromyalgia 6 years prior to referral, and she was on painkillers. And her blood test showed mild lymphopenia with normal ACE, no other significant abnormalities, mild iron deficiency, but everything was normal. Her lung function showed a gas transfer of 73% and a normal normal spirometry with FVC and FV1 109 and 113% respectively. So we would like to hear the comments on the scan.
Thank you, Vasilis. Can you see the screen?
Yes.
Okay, so this is the scan from 2019. I'll just go up and down. And what this shows is abnormalities mainly in the upper lobes and apical lower lobes. And what we see are these multiple small nodules, which are centered on airways. And in some areas, we also have larger confluent nodules that are forming consolidation. The distribution of the nodules is in a very typical distribution for sarcoid, situated along the vessels and airways. And those nodules represent what we call granulomas or granulomata in the lungs. At this stage, there is very little evidence of fibrosis. Maybe there are some dilated airways up here in the left apex and right at the top of the left lung, but most of this you would say is potentially reversible, and the lower lobes are completely clear. I have one more scan, but let me know when you want to look at the follow-up.
Just to ask you a couple of questions, do you entertain any diagnosis other than sarcoid?
No, this would be so characteristic of sarcoid that there would not be any other diagnosis.
Okay, and you said very little scar tissue. If you look at the overall burden of disease, taking everything aboard, how would you say rate the badness of the disease on the scan?
So the fibrosis component is maybe 5% at most, which is very limited. The rest of the abnormalities even though they are affecting maybe 30, 40% of the lungs, the top and middle, if you like, they are, in terms of severity, potentially less clinically significant, potentially more reversible. But of course, that can vary from patient to patient, and you'll need to correlate that with the lung function. But so in other words, even though there is quite a lot of disease, it's potentially quite quiescent and reversible.
Yeah, the lung function indicates what we would call minimal loss of lung function. And we'll be asking further management questions. The one thing I would say, this might be only 6 inches deep, but it might be a mile wide. In other words, it may be that if 30 to 40% of the lung is involved, you've got to watch rather closely how this develops and come back quite quickly to looking at the behavior of the illness. Anyway, Vasilis, please.
So the patient wanted a biopsy to be 100% confident, especially because of the size of the cervical lymph nodes, and this was obtained and showed non-caseatic granulomas, and was rather reluctant to take treatment. So she preferred a watch and wait approach, and she is coming back.
She's coming back for review. So
yeah, I'll have that. Sorry. So she's coming back for review approximately 9 months later. She has had lung function in the interim. And there is a slight decline, I would say stability in gas transfer values, 72%, but a decline in both her spirometry and in both spirometric values. Both of them are within normal range, so the significance of them is to be considered. But she had a repeated scan also as part of monitoring her condition.
Vasilis, can you hold that on the screen? Because some people will see 6.2 becoming 5.94, and they'll say, what is this? You've actually got an obvious drop in the number with time. I'm looking at TLCO corrected, which is 6 up from the bottom. But what we do know is that these tests have noise of measurement, and a third of healthy individuals will have that sort of variation when you put that test and you repeat it, say, 4 weeks later. So this is stability because it lies way within the variation of the test. So don't be fooled by the exact numbers. So Vasilis, please keep going.
I will hand back to Anand to comment on the latest scan. Which is, I think, 18 months apart.
Okay, so the scan on the left of the screen is the follow-up scan. The scan on the right is the one I showed you a few minutes ago. Just to recap, I'll go up and down. But what we can see has happened now on the scan on the left, which is a little time apart, as you say, is a couple of things. First of all, there are now very numerous nodules affecting all the lobes. Previously, the lower lobes were clear, but now we see all of these tiny nodules, these dots, indicating that the sarcoid has involved more of the lung than it did previously. But also importantly, we're starting to see more fibrosis, which we know has the scarring that has set in because the airways are dilated. That's the sign we look for on CT to look for fibrosis. So this is progression of disease, both in terms of more fibrosis, but also in terms of more new non-fibrotic sarcoid.
So let's just talk through what is sensible at this point. I've bullied my colleagues on management to this point, so I'm going to let them off and say something quickly and let them agree or disagree, I think. This really is, in terms of lung function, still just 6 inches deep, but on the scan it really is a mile wide. And the risk is that if the tide comes in, it becomes more severe, it will come in with a vengeance. And we will be seeing something very severe developing. You've got the clue that scar tissue is now forming, the word fibrosis meaning always scar tissue, which won't be reversed. So I don't think anyone is going to sit on their hands at this point. But can I now turn to Elizabeth and Phil and ask them exactly how they'd manage, what they'd introduce. Please go ahead.
So I would agree, I completely agree that you wouldn't want to sit on this. There has been a loss in spirometry, which although not great, is about 10%. The gas transfer was stable, but her spirometry is coming down. And the CT in this case is much more suggestive of a major worsening with now scarring. So we've heard this morning from Anjali that we don't tend to use as high doses of steroids for as long as we did before. So you would discuss with the patient whether she would be willing, I mean, you would be now treating to avoid danger to the lungs, danger in the sense of irreversible damage to the lungs caused by scarring. So we are no longer having a conversation about quality of life, but we're having a conversation as with your, subdivision about the need to treat to prevent irreversible damage and to gain back any lost lung function. So if she is agreeable, I think my first option would be to go for a reasonable dose of prednisolone between 20 and 40, probably around 30 for a month or so, and then start reducing and seeing how she responds to that. If for some reason she is very reluctant to go on sarcoidosis or there are other issues, one might introduce from the start a steroid-sparing agent. But I'll leave Phil talk more, but I think that would be my option to begin with.
Yeah, thanks, Elizabeth. I think I probably tend to use more steroid-sparing agents from the start to avoid steroid side effects. So, but it'd be a decision down to the patient, and I'd give them both options because we have a little bit of time here to slowly build up therapy. So there would be an option of going on methotrexate and building it up over a few weeks, as opposed to the last case where we had to go in all guns blazing. So I think given the side effect burden of steroids, I'm more and more seeing a benefit of going straight onto methotrexate, given that the majority of patients do tolerate it. But it would be up to them at the end of the day.
I think this case illustrates three separate views on management, and that does show us that actually a lot of the time we do have to act beyond hard evidence. So personally, I would say that a short, sharp pulse of steroid might actually deliver a dramatic response and establish very, very quickly that low-dose therapy is enough. Now, I'm saying that because the huge bulk of the abnormality looks very reversible right now. And my worry would be that if you don't find out fast that you can manage this with very low-dose therapy, and if you don't find that out fast and you pick at this with less definitive treatment, you actually end up not in the first 10 days, but over a period of months with a greater treatment burden. So to me, this seems like a case for post-therapy, a very quick reduction to say 20 milligrams daily, a further quick reduction perhaps a week or 10 days later to 15 milligrams daily if there's a striking response. And I'm really saying that because so much of what is extensive looks nodular and reversible. And I don't think I'd feel that way if there was a lesser reversible component to this. But I think the three of us can agree that no one of us is correct about this. And I think the important point I suggest is sitting down and discussing it with the patient and talking through whatever patient preference there is for steroid dose. Do either of you have any more to say, though? Do you accept that there's really division on what we might do in this case?
I'd be happy with all three of those plans. And,
pulse steroid involves 3 trips to a hospital. Methotrexate without steroids, can have some more side effects. Steroids alone have side effects. So I think all 3 of those would achieve the same outcome ultimately. You may find out slightly quicker with the pulse steroids, but I think I'd be happy with either 3 of those.
Okay, Vasilis, do you want to have a casting vote? Because you've opted for 3 options, so anything you vote for becomes the official view. Or are you?
I will just. I don't know the result, but I will just say what was the patient's choice. The patient's choice was with Elizabeth.
Yeah, so that means Elizabeth is correct.
I don't know. Well, how did she do? How did she do?
She's currently on treatment.
So you're saying that she's changed her mind and she's accepting therapy is the start of right sort of outcome?
Yep.
Okay.
I definitely want. I had asked both Sujal and Anand, and I know that they will be frustrated to work up 5 cases, but it's more the discussion that is created as a result of those that is very interesting for the patient and everyone, I would say. I think that we need to bring the MDT to a closure, I want to thank all of you for participating. It's a major plus for the patients. Thank you all. I would like to introduce Philip Molyneux, who's our consultant for a few years now, who is also a member of Imperial. He's the director of the clinical research facility at the Brompton, and he will chair the last session. Phil, over to you.
Thanks, Vasilis. So none of those things qualify me to be able to keep this to time because we're obviously already running a little bit late. But I will do my best to get us out of here before we all want some dinner. That being said, the topic here is a research strategist, what's going on in sarcoid, but more to the point, what should we be looking at doing from a patient perspective? What should our priorities be? How can we help patients and how can we drive sarcoid research over the next decade? Because without preempting what's coming, we all know that the sarcoidosis research field is dwarfed really by the pulmonary fibrosis field in general and idiopathic pulmonary fibrosis, which has got all the attention over the last decade. So without any further ado, I'll hand over first to Professor Athol Wells, who will try and give us an overview of what the Brompton are specifically doing. Thanks, Athol.
I hope you can see my slides. I knew this would be a little time shortened. So all I've done really is set out the 3 areas that we are both involved with, but might be, and there are just 3 slides. So first of all, understanding what drives sarcoid. And I think we must all continue to pursue whether particular triggers apply to people with a particular genetic makeup, with the trigger then triggering overexcitable macrophages and other pathways. We have in our discussions earlier today separated these possible causes of sarcoid, but I think that exploring genetic predilections and what happens with pathogenesis is terribly important. There is currently a large grant proposal in development in sarcoid with collaboration between the hospital and Imperial College and between the hospital and other basic scientists and translational workers. So that's the first domain. Now, the second one is the area in which we're most advanced. And that's actually trying to work out who in sarcoidosis has danger and trying to do that more accurately. So trying to get a better balance of who can escape without having to have treatment and who you would want to intervene in as early as possible. And I can highlight that Vasilis and Rakesh Sharma have been at the core of developing this in cardiac sarcoid. Firstly, how can we pick it up easily and what is the best balance of routine tests? But also how can we find out as quickly as possible as to who is at risk so that we're not treating too late, but we're not over-treating either. Now, I can say that we've developed a staging system using simple lung function in pulmonary disease. It's now very close to completion. It's been validated in 2 major European cohorts, each of over 1,000 patients. And I think we are working towards taking part and hopefully co-leading treatment trials in cardiac sarcoid once we have the best possible working out the best possible stratification of who's at risk and should have earlier treatment. And then finally, I kept this slide and just made it up about half an hour ago because I wanted to pull together all of the questions that were asked. But I'm going to confess now in my election to what will become the president of WASOG, you had to set your goals. And I have felt quite strongly, but didn't want to say it because it committed me to it, that we need an international patient charter. We need a document that defines what patients have a right to expect from their expert advisors. And I've seen enough today to become entirely convinced that to define a profile of what really matters to sarcoid patients in a very large patient group has got to be the way to shape this. So you've all taken views as to what is missing and what matters. I think to have a UK-wide profile of the impact of sarcoid, you've done great stuff, Sarcoid UK, with actually some of the questions you've asked. But I would really like to see a patient charter built on what really matters to patients. It also seems very clear today that what we need is a better sense of what happens with calcium and vitamin D metabolism. And if we have research into this area, this should then drive expert guidance. And finally, for trials, we have to develop what are called patient-related outcome measures. And Phil, I'm just going to close. I haven't taken, I think, too much time. But think about quality of life. Think about some of the complex questionnaires that are not fitted to particular patients. Now, there is a move in the disorders known as inflammatory myopathy, that when you construct a trial and you're looking at a drug to improve quality of life, you find out in each individual patient what matters to them in their quality of life and what is threatened by their recent experiences. And you actually have individualized endpoints. And I think that in sarcoid, there's going to have to be this sort of approach so that we can really have proper trials of quality of life rather than relying on these complex questionnaires that are very uneven in how they apply to individuals. So for example, some people hugely value exercise. If I had sarcoid though, my attitude would be, I think, that if I ever feel the urge to exercise, I try to lie down until it has passed. And so I think to have those sorts of outcome measures is crucial. That's my lot, I think.
Thanks, Athol. So yeah, I mean, I think that's some very interesting points and areas to look at. When we think about research from sarcoid, you look across the breadth of disease areas we've heard about today, it's unsurprising that big pharma companies have really struggled to tackle this problem, given the different patient types we have and we care for. So we've heard from what Athol thinks and what the Brompton think, but really
we're now going to hear what Sarcoidosis UK think from a research strategy, and it's my pleasure to introduce Peter Tickbon from Sarcoidosis UK, who's going to try and give us a brief update in what their upcoming research strategy is. So over to you.
Thank you very much, Phil. And I should be now on screen. Thank you very much. So, yeah, I mean, first of all, I just want to thank Vasilis, the Royal Brompton, and all the other speakers today. It has been an absolutely amazing day. And for Sarcoidosis UK, we've been really pleased to partner in the delivery of this. That's been absolutely fantastic. What I thought as we went through the day, one thing that leapt out of me was something that Dr. Paolo Spagnolo said, which was sarcoidosis is a neglected disease. And that sort of resonated with me in that, and he said how big pharma is engaged with sarcoidosis, but they sort of need a steer. I think that's sort of when we talked about Sarcoidosis UK, that's perhaps one place in which we fit. And within that, what we've been doing over the last number of years now has been funding what I would call, and I don't know what an expert would call it, but sort of seed research. Clinical trials, large-scale clinical trials cost millions of pounds, and obviously developing specific drugs for specific illnesses can be hundreds of millions, billions of pounds, depending on the disease. And I think with something as wide-ranging in terms of effects on individuals as sarcoidosis, those pharma companies are also looking for a steer. I mean, and that's one of the things that Paolo said. And that's where Sarcoidosis UK has been very effective. We raise money, and with the British Lung Foundation, we partner with them to fund research. We have funded relatively small-scale trials, both in existing drugs where research tells us that they may make a difference in the way they interact with the body. They may make a difference to sarcoidosis. And of course, we've talked about research into causes of sarcoidosis, whether that be environmental factors or genetic factors. So for us, it's very, very important that that the experts we've had on today, the researchers, physicians, etc., continue that research, and we're very proud to play a part in raising money year on year to fund those seed studies, as I would call them. The charity has grown very significantly in the last 10 years, for sure, and I think today, the success of the day, the amount of people that have engaged, I've seen peaks of over 600 people watching during the course of the day. We're definitely resonating with people, and I think the fact that we've been able to work together to present this to sarcoidosis sufferers has been absolutely amazing. So, so for us, one important thing out of today is that we are able to continue to fund the research to find a cure. That's one of the things we're here for, apart from supporting people and finding information. So I guess the one last thing I would say before I hand back is, it is important that we raise that money, continue that funding. So for those people who are still on, if they could go to sarcoidosisuk.org/donate and make a donation that continues to fund the research that helps all of the researchers we've had on here today, that would be absolutely fantastic.
Thank you, Peter. Thank you, Phil. Thank you, everyone, for an excellent day. I honestly, I'm really, really happy about everyone's contribution. I want to thank all the external colleagues that attended and stayed until now, the international colleagues, and Filippo particularly, but also all the Brompton group that participated, and I hope that this was informative, and we will take it from here and continue to support the sarcoidosis patients.
I think I'd like to offer a final thank you to you, Vasilis, because I have to say, I think everyone involved in this day has got a huge amount out of it. You've set up a forum where I think the doctors involved have also learned a great deal. And so this is fabulous, I think. So well done indeed.
Thank you, Prof. So I think that we will bring this to a closure. We finally managed to be on time, so that's great. Lots of thanks to Leo, Leo and Charlene, who have really worked with me in the background quite a bit. And we were meeting every week discussing about every issue. So thank you, Leo. Thank you, Charlene. Thank you, SarcoidosisUK. Bye-bye to everyone.